Double tap on the thing.
Sir, there is an option below. There is option.
Rajiv, is it that only 10 people can come in, or
Dinesh, only 10 people, I think.
we're already?
Is it true, Dinesh? Dinesh, how many people can join?
He has mentioned 10. I mean, when he has sent a message, Dinesh has sent that 10 people can join.
But the good question, Rajiv, how to make the screen full?
That's
Sir,
we cannot.
Sir,
Okay, we got it.
sir, yeah, I will do, sir. Whatever switching and all this thing, I will do. We can start. We are alive, and then after basically Mahendra sir can go out, so sir also can go in. There's a limitation is there
Yes,
only
yes.
10.
Okay.
Yeah. Me and Ranjit will go out.
Yes, sir. You please start, sir.
You can
Okay,
focus
start.
me. Now you can focus me instead of focusing this theater.
Yes, Dr. Mahinji, yes.
Yeah.
Assis was congratulations for the last week. Wonderful macrosia. Wonderful. It was nice.
Dinesh,
Hello.
can we?
Sir, please go live, sir. You are live. Start.
Yeah. Very good morning to all of you, all the delegates, all the participants today, and also the panel. And as usual, today we have a galaxy of stars led by Dr. Satish Jain, who is a operating faculty today. And on behalf of Sun Pharma, I welcome you all to this program,
जो ज्वाइन किया
which is the 25th program. This is, I would say, this is a silver leap. I mean, we started this webinar with Dr. Jain and Dr. Rajiv Pachori during our lockdown period. Now almost lockdown is over, I would say. We have crossed more than 25th, and this is the 25th program. And if I take average around 6,000 delegates every time, and this crosses almost around 1.5 lakhs of delegates participating, I mean, the visits. So this is a wonderful program and a very big success where even other pharma companies are telling about this. And it's a wonderful program, I would say. And today again, then we have Galaxy of Stars, and we have lots of session today. And my heartiest welcome to Dr. Bunker, Dr. Narayan, Dr. Naidu, Dr. Ubo Mittal, and of course, I cannot leave Dr. Rajiv Pachori. Once again, my heartiest welcome on Sun Pharma, which is a manufacturing and marketing of Cipodom XP, Vitavert, Montec FX, and Reciprocity. And my heartiest welcome once again, and wish all the success for this today's program. Over to Dr. Rajiv Pachura.
Good morning. Dinesh, share the screen, please. Yeah. Good morning, all my friends from India, abroad, and those who are just been with us since almost 4 months, and they were enjoying all the ABCD of the ENT, and this is I think the peak of our discussion about the ENT. Today is the lateral ischial base, and that is I would say this is the highest version of ENT discussion which we can have today. And those who are joining since the starting, and those who have missed it, they can revise their everything today. They can ask more and more questions. They can discuss a lot, and this will last till late evening. So I think welcome all my friends again and again, and I would like to thank all my guests for Sun Pharma especially for doing this wonderful job, helping out in this way. And this I think this lockdown period is, as per the feedback from all of us, from all our colleagues, it is a boon for this ENT fraternity. And thanks to Dr. Satish for giving us this so much of the information by live dissection, cadaver dissection, and his theory apart. So that is the wonderful dissection. Thanks, Dr. Ashish Bose, Jaishankar, and Deepak Boss. Good morning, Udbhav, Sandeep, and Sun Pharma again. I would like to thank. So over to Dr. Satish for his starting and take us to again one of the highest version of the ENT discussion today.
Thank you, boss. Thank you. And I welcome you all again to this live webinar. It's a big day for us as we are having some very important, very senior people with us who have agreed to come as guests to honor our event. I can see on this screen the people who have been part of these webinars from beginning. Our brothers, Dr. Ashish Bhumkar, Dr. Narayan, Dr. Sandeep, Dr. Udbhav, all have been part and parcel of all the events. Big thanks to Sun Pharma. About our guests today, these are the people who are very, very close to our heart. Both are ENT surgeons who have orientation, their career, their life devoted to the oncology. Dedicated oncologist, head neck as well as skull-based oncology. So I welcome Dr. Deepak Sareen sir for being with us today. Dr. Deepak Sareen presently is heading the prestigious Medanta Hospital's head and neck oncology department. Besides that, he has been part of, the head neck oncology department of Gangaram Hospital, Artemis Hospital, and many, many prestigious hospitals where he developed and propagated head neck oncology science. Besides having his fellowship in Miami, he has to his credit a lot of publications. He is deeply into academics and developed new approaches, his presentations are mind-blowing, and is always a learning experience being with him. Thank you, sir, for being with us today. And then we have Dr. Shiva Thiagarajan. We have seen him earlier couple of times, the kind of person he is, we all know. Dr. Shiva presently is Associate Professor of Head Neck Oncology at prestigious Tata Memorial Hospital, Mumbai. He has been a fabulous oncologist. It's always a treat to watch him operate. And his clear concepts is, the way he teaches is something amazing. We are grateful to him for being with us in our previous webinars, and he always makes something, very, very specific for the learners. Thank you, Dr. Shiva, for being with us. Dr. Shiva is an integral part of skull-based unit, which is a dedicated unit in Tata Memorial Hospital, wherein our friends like Prathamesh, Dr. Deepa have been nurturing the unit and treating a lot of malignant lesions of the lateral skull. Today, our webinar is dedicated to the advanced dissection. It's a three-dimensional anatomy of a very, very complex region, the temporal bone and the lateral skull base, and various surgical approaches and decision making. In the previous webinars, we have discussed about the basic anatomy of the temporal bone. We all know temporal bone is a complex structure, and it's always a challenge to understand the three-dimensional anatomy. So this webinar is something about discussion of more and more complex aspects of the temporal bone anatomy and surgical approaches to the lateral skull base. Can you bring the camera behind? So today we'll be discussing all the.
Satish, if you don't mind, make a mention of the en bloc dissection, which probably most of us, including me, will be seeing it for the first time ever. Just elaborate on that.
Yeah, temporal bone dissection.
Yeah.
Yes, I am coming to that, Ashish, definitely. Yeah. So, to simplify the things today, what I have brought to begin with, I will show this overview of the anatomy from the skull model.
Yeah.
Can you focus on the model of the skull? Yes. Give me a close up. Can you hear me?
Yes, sir.
Deepak sir. Dr. Deepak Sareen.
Deepak boss.
I can't hear you. I think you have to unmute. Deepak
Dr.
sir.
Deepak.
Dr. Shiva.
Trial version.
Deepak sir is back, sir.
Oh, I think he's logging in again.
Some issues with the
issues?
net, Satish, today. Yeah.
Trial version.
Okay. So, can you see the skull from inside?
Yes, sir.
Zoom in further.
Trial version.
See. Yeah. Zoom out. Let me show you the overview of the skull base from below. Above.
Trial version.
Again and again. Oh, Dinesh. Can you hear me, Ashish?
Trial
Yes,
version.
We can
Yes,
see,
sir.
we can hear, all good. if you don't mind, if you can ask your assistant to hold a green towel behind, the contrast is not there. Behind somebody, that
Trial
will be fine.
version.
Okay, chalega. Okay, go ahead. Go
Why it
ahead,
is showing
Satish, you are
trial
fine.
version again and again?
Forget it. It's not
Yeah, I
interrupting
I'm
our.
I'm checking, sir. Don't worry.
Trial
Okay.
version.
Dinesh, can you do something?
Yeah, I'm doing, sir. I'm doing. Don't worry.
You carry on, Satish. We can see you and hear you well.
Okay.
Trial version.
So this is to make you a better understanding of the three-dimensional anatomy.
Trial version. Trial
This is the
version.
come on, Dinesh. Why did he?
Sir,
Trial
yeah.
version.
Shit, why is coming? It's not trial version at all.
Trial version.
Why did he experiment?
Trial version.
We'll ignore that lady's comment. Satish, you go on because we can hear you. You don't have to interrupt.
Okay, either allow.
Trial
Perfect.
version.
So this is the inside view of.
Yeah, very well seen. Yeah.
This is the foramen. Where brain
Trial
stem,
version.
you can see this brain stem like this. With this is the brain stem basically. This is the brain stem
Trial version.
with the medulla and cord going in through the foramen magnum like this. Okay,
Trial version.
come on. And this is the posterior cranial fossa between the two
Satish,
pincer.
your voice is also breaking.
Trial version.
My voice is breaking.
Yeah, your audio is breaking a lot.
Can you change to Zoom, please?
Trial version.
It's not allowing us to focus.
Yeah, even what you're talking, there is
Trial
there are only
version.
2-3 words heard, so you just have to hold.
I know this Dinesh is experimenting today with something. I don't know why.
Trial version.
I think we should wait for his module to change.
Trial version. Trial version. Trial version. Trial version. Trial version.
Hi Shiva, good morning. Narayan here.
Trial version.
For all the guests who are attending, kindly bear with us. There's some technical hitch. Trying to fix it for an uninterrupted experience.
Trial version.
I think I was muted. I didn't. I think probably you couldn't have heard me. Good morning to all once again. Yeah.
Morning, Shiva. Morning.
Trial version.
As with every technology, one has to experiment with it. So Dinesh, rightly
Trial
with good
version.
intentions, is trying a newer technology. There is something that's not going right. So please bear with us. If it clicks, it's going to make our
Trial
experience
version.
even better than
Yeah,
what we were
Ashish.
used to before. Yeah, Satish.
Ashish, a couple
Yeah,
of minutes.
Satish.
He's changing to the Zoom again.
Okay, so
So
we'll
I
have
will,
to.
I will send
Trial
you a different
version.
link
Yeah,
to
yeah.
join you again.
So what about the people who are on that expert? Those are the other
No,
people.
that is on. That will remain on.
That will
So
remain on.
probably in
Okay.
next
Trial
few
version.
minutes we'll be back with the
Okay.
Zoom link.
Only. No problem.
Okay,
Okay.
please.
So should we disconnect?
Uh,
Or
Wait for some time. Wait
we'll
for some
wait
time.
till you give us the
Trial
instructions.
Wait for some
version.
time.
yeah, please bear with us. We'll be back in couple of minutes.
Yeah.
So in the meantime, we can say something, Dr. Satish, because the sound
Yeah,
is going on.
talk about
Trial
this
version.
thing, Satish, that you mentioned that
Sound.
this is only in 2013 that the Japanese doctor published this technique about complete resection of the temporal bone.
Trial version.
Hello.
Satish, we can make the announcement regarding the ISO.
Yeah, Ashish, can you hear me now?
I can hear you well. Yeah.
I think
We
the
can hear.
problem is sorted out now.
Yes, sir, we can hear you.
Yeah, I think now it's clear and we don't even have the trial version coming in, so you can probably go on.
So, am I audible?
Yes, sir.
Yes. Very nice.
I think I can see Deepak sir on screen. Can you hear me, sir?
Yeah, I can hear you. Can you hear me?
Now
Thank
I
you.
think this
ये करो कैमरा
issue is resolved now.
ये कैमरा करो ये माइक्रोस्कोपिक कैमरा ऑन हेलो
Yes, sir.
Yes.
आर यू गेटिंग द पिक्चर
Yes.
Yeah, getting it.
Yes, copy
Getting
it.
it.
दिस इज टू बिग छोटा कर see this is the temporal bone model what I wanted to show you for many reasons. Today we are going to discuss some of the important approaches to the temporal bone. So we need to know how temporal bone is related to the skull base. So this temporal bone joins many surrounding bones making the skull base. Do I show with the distal view or through this microscopic? Which one is better?
This is okay. We are able to understand, Satish.
Okay. So this temporal bone, basically, this will not be, you will not be able to see with this smaller view. Can you make
Okay.
our external camera?
External.
Idhar aao.
Okay. How many sutures are there in the temporal bone?
Yeah, Ashish, this temporal bone forms by union of four parts basically, embryologically. The petrous part, which is right here. You can see this entire is the petrous part. The two petrous bone on both sides joining in the midline with this clivus. This clivus is formed of two bones, the sphenoid and the occipital bone behind. Can you see this clivus?
Yes, very well.
And this is the petrous bone which ends as an apex. This is petrous apex.
Yeah.
So this area of the clivus and the petrous apex, they form this as a petroclival region. This area is known as petroclival region. This is a very, very important area for many pathologies which arise from here, which need to be addressed. Can you switch off the mic? वीरेंद्र, इसका माइक बंद करो ना यार.
हाँ, there is an echo.
मेरी आवाज क्यों रिपीट हो रही है? मार दो. वीरेंद्र, my voice is repeating ना.
Yeah, tell them, sir, reduce that your the TV audio, nothing else.
Which one?
Sir, TV का आवाज थोड़ा सा कम करने को बोलना बस.
There will be a monitor in your dissection lab. You can mute that.
If you switch off this, how will I hear them? उनको कैसे सुनूंगा मैं?
हाँ.
यार इनको
वो एकदम faint पे रखो and you sort of mask it down in your brain. This was the same problem in Thane, if you remember.
Yeah. And Narayan sir.
Hello.
Hello. Yes, sir. We are.
Okay, let it be.
Yeah.
So this is the petrous bone. So there are four parts of the temporal bone which join together. This is the petrous bone, which is the medial most part. Then the outermost and above, this is the squamous part of the temporal bone. Then this is the extra-auditory canal, which is formed mainly by, on three sides, posterior, anterior, and the floor by a triangular semilunar bone, that is tympanic bone. And from below, that is another bone, which forms the styloid complex. Zoom in. That includes the styloid process and the styloid eminence inside the posterior part of the middle ear, which I will show as I go inside. This process behind is the mastoid process, which is not actually a developmental part of the temporal bone. It develops after birth with a fusion of squamous part outside and the petrous part inside. Okay?
Sorry, Satish, the styloid eminence is a part of the tympanic bone?
Yeah, it arises from the tympanic bone,
Okay.
but it is a different part because it is attached to the tympanic bone is one aspect, but it goes all the way inside the temporal bone to the posterior part of the mesotympanum.
Okay.
All structure in the posterior part of the mesotympanum like caudal eminence, pyramidal eminence, all those are part of styloid complex.
Oh,
Okay?
okay.
Then
Okay.
these four parts meet at various levels in the temporal bone, laterally, medially, anteriorly, posteriorly, superiorly, inferiorly, and they make almost more than 34 suture lines inside the temporal bone. See how
34.
complex this is. Yes. Now, what you see from inside is the petrous part of the temporal bone. Today, like I mentioned, we'll discuss about the subtotal temporal bone excision or total temporal bone excision. We need to know how temporal bone is situated in the skull base and how it makes connections with other bones. So temporal bone is, has connection behind with the occipital bone. This is all occipital bone behind. And this is the petrous part of the temporal bone. This is the petrous part of the temporal bone, and here it makes the petro-occipital suture. Can you see a little bit? Yes, from this side.
Yes, sir. We can see.
This is the petrous bone.
You can take a longer pointer, Satish.
Yeah. Can you give me another pointer? Yes. This is the petrous bone. and this behind is the occipital bone, and they meet here inside at the petro-occipital suture line. Okay?
Yeah.
This is the petro-occipital fissure, you can see. Can you see from the petrous apex, from the clivus, this is petroclival fissure, you can say. This clivus here is a part of occipital bone. So this is the petroclival fissure, you can say. And here what runs? See, here is the clivus and above is the cavernous sinus on both sides. From cavernous sinus here, the inferior petrosal sinus extends along the inferior petroclival fissure to go to the jugular foramen. Can you see this foramen?
Yeah, very nice.
Jugular foramen. So basically this foramen is situated between two bones. This is the petrous bone laterally, above is the petrous bone, and behind is the occipital bone. And in between these two bones is the jugular foramen situated. Okay?
Yes, sir.
And to this jugular foramen, this venous connection coming from the cavernous sinus running along the inferior petroclival fissure joins the jugular bulb over here. Okay?
Yeah.
Now, this jugular bulb, as I said, it is formed by the petrous bone here and the occipital bone here. This posterior margin of the jugular foramen, this is very important. I will tell you the region. This is formed by this jugular process of the occipital bone. Okay?
Yes.
Now, this jugular bulb is going to be here. How the jugular bulb is formed? I will rotate this bone from behind. See this from behind. This superior sagittal sinus comes and continues as a right transverse sinus. The left transverse sinus formed by the inferior sagittal and the great cerebral vein. Focus. Yeah. So this superior sagittal sinus continues as a transverse sinus, and here at the petrous ridge behind, see the petrous ridge behind. Again, see this petrous ridge behind. Here it becomes the sigmoid sinus and runs in this groove over here. Can you see this?
Yes.
Yes, sir.
And forms the jugular bulb over here. I hope it is clear.
Very
Yes.
clear.
So this jugular bulb in the jugular foramen, it is formed by petrous bone above and the occipital bone behind. And this is the sigmoid sinus which runs behind the petrous bone. We all know all the critical structures, the entire labyrinthine structures, carotid canal and the facial canal are contained in the petrous bone. Okay? Now, how? Yeah, focus, zoom in. See, if you see from the above, this is, zoom out. This is middle cranial fossa, zoom out. Out here. This is middle cranial fossa, can you see?
Yes.
This is posterior cranial fossa. And petrous bone has relationship with both the middle as well as posterior cranial fossa. So, important inner ear structures are contained in the petrous bone. This is posterior. So, if I show the corresponding internal ear structures from above, how they are contained in the petrous bone, there are certain important landmarks. See, on the posterior surface of the petrous bone towards the posterior cranial fossa. Can you zoom in? See, on the posterior face.
Yeah.
This was jugular foramen.
Yeah.
Above is the internal auditory meatus. See this?
Yes.
Yes, sir.
Superolateral to the internal auditory meatus is the site for the vestibular aqueduct. Above that and behind is the arcuate eminence, which is the eminence of the superior semicircular canal. Here is the petroclival fissure, the petrous apex. Now zoom out. See the 7th and 8th cranial now ascend from here to the intra-auditory meatus. Okay? Here is going to be the brain stem, And from here the 7th and 8th now ascend to the intra-auditory meatus. 9th, 10th, 11th ascend to the jugular foramen. Zoom in. And see what is there medial to the jugular foramen. Medial to the jugular foramen, this is jugular tubercle. And medial to that, this is the occipital condyle. Can you see this?
Yes, sir.
If I rotate the bone down, see this. From the inferior surface, these are two occipital condyles. These are two occipital condyles on the inferior surface of this bone. So, this jugular foramen, this is important to understand when we see the dissection. This jugular foramen, like when you are operating like from here, medial to the jugular foramen is the jugular tubercle, over which the 9th, 10th and 11th cranial nerve run to enter the jugular foramen and go extracranially, and medial to the jugular tubercle is the occipital condyle. Okay, and here lateral to that, superior to the jugular foramen, superior to the jugular bulb is the intra-auditory meatus, and above this is the superior petrous ridge. This is the superior surface of the petrous bone. As I said, here is the sigmoid sinus coming. This is the sigmoid sinus coming to the jugular bulb. Here, until then it was transverse sinus, and here it becomes the sigmoid sinus. So at the junction of the transverse and the sigmoid sinus, the another sinus comes from the another venous channel coming from the cavernous sinus, running over the superior surface of the petrous vein, joins the junction of the transverse and sigmoid sinus. This is the superior petrosal sinus. And the inferior petrosal sinus running in this groove join the jugular bulb here. Again, for everybody, the superior petrosal sinus and inferior petrosal sinus, both connecting the venous return of the cavernous sinus to the jugular bulb, to the jugular system. The superior run all the way above the superior surface of the petrous bone to join at the junction of the transverse and the sigmoid sinus. This is superior petrosal sinus, and the inferior run along the inferior petroclival fissure to the sigmoid sinus. This is the inferior petrosal sinus. Okay. Now, here this is the internal acoustic meatus. This is the skull model. Here the nerve run in the interacoustic meatus. This internal acoustic meatus is a centimeter long, like this, and on either side, laterally on the interacoustic meatus at the lateral end, anteriorly is the cochlea and posteriorly is the vestibule and the semicircular canals. Can you see?
Yes.
Inside this bone, look at the skull. Where are the cochlea and vestibule situated? See, this is middle cranial fossa above. This is posterior cranial fossa, foramen magnum. This is the clivus, and where is our cochlea? We see the cochlea from here. See this? Can you show this? In a regular approach, we see the cochlea. This is external auditory canal. This is mastoid tip. This is the styloid process. This is the mandibular condyle. We are all convergent with this anatomy.
Yes.
When we go through the external auditory canal here, see this, from the external auditory canal here, on this surface, where is the external auditory canal? Here is roughly the external auditory canal. Here is the external auditory canal. See this? And this behind the external auditory canal, this is mastoid. Can you see this? And here behind the mastoid is the groove for the sigmoid sinus. You can see this. I hope you are getting what I am trying to say. Zoom out.
Doing very well.
Now zoom in. Yes. So here is the external auditory canal. And what is this bone, thin bone above the external auditory canal? This is tegmen. When we see from this side, the external auditory canal is roofed by tegmen. We know it. So where is the tegmen? Here is the tegmen. See, here is the tegmen. This is middle cranial fossa. This is where the temporal lobe is. Here is the tegmen tympani, here is the tegmen entri, thin bone. Here is the intra-auditory meatus, where the internal auditory canal is there. And here is the vestibule posteriorly, and all the three canals. This one is the superior canal here, forming the arcuate eminence. The posterior canal is here, and the lateral canal is there, going laterally. The posterior canal is here. I hope you are getting what I am trying to say. So this is roughly the location of the vestibule and the semicircular canal on the skull. Now this is intra-auditory meatus on the anteromedial aspect. क्या हुआ यार? छोटा क्यों किया? What are you doing?
दिख रहा है बराबर दिख रहा है.
Hello, Dinesh.
Yes, sir. बोलिए sir.
Why are you changing?
No, I'm not changing anything, sir. We able to hear.
Can you make
Satish, I think you keep the bone down or keep your hand steady on the table so you're able to focus constantly at the same spot.
Okay. Can you
Keep your hand steady somewhere so the bone is steady.
Yeah, focus this. Focus this. Yeah, that's a good idea. Say this. Focus. Now, is it clear? So, this is the site of the vestibule and the semicircular canal on the skull. This is all Peter's bone containing inner ear structure. Extra-auditory canal here, the mastoid here, the vestibule and the semicircular canal here. This is intra-auditory meatus and the cochlea anteromedially. And the cochlea anteromedially. This is very important. And anterior to that, here is the petroclival fissure, which is crossed by the fifth cranial nerve. Fifth cranial nerve comes from the forearm, comes from the brainstem here, and pass over the petroclival fissure like my pen. And then, zoom in. Why are you changing the window, Dinesh? What has gone wrong with you today? क्यों चेंज करते हैं वीरेंद्र? चेंज क्यों करते हैं यार? इसको हेलो? Yes. Can you hear me? Hello?
Yes, we can hear you.
Yeah.
Yeah, we can hear you, Satish.
Yeah, so fifth cranial nerve runs from here over the petrous apex, and here is the ganglion, the Gesserian ganglion for the fifth cranial nerve, and here it divides into three branches like this, diverging from each other. The most lateral one going through this here in the floor of the middle cranial fossa, that is foramen ovale. Just behind that is foramen spinosum in the middle cranial fossa. And then the second cranial nerve, that is foramen rotundum. We have seen in our endoscopic dissection previously. This is V2 passing through the foramen rotundum, and that continues in the pterygopalatine fossa. And then V1 passed through here to the superior orbital fissure, and here is the superior orbital fissure if you see. So V1, V2, V3 in the middle cranial fossa floor, and this is foramen spinosum through which the middle meningeal artery enters. Then see how close are all these structures. The fifth cranial nerve going here, the sixth cranial nerve going above in the cavernous sinus, I will show in the dissection. Seventh, eighth coming inside to the intra-auditory meatus. 9, 10th, 11 going to the jugular foramen, and 12th passing through this condyle. There is a canal in the condyle, hypoglossal canal, which I will show in the dissection. And this is the entire petrous pyramid. Now, in temporal bone resections, for malignancy of the temporal bone, we all know, particularly involving the petrous part. So far, if you see the results are not encouraging. It is one of the most frustrating malignancy to treat for the oncosurgeons, because so far, like for other oncology procedures, the principle of en bloc excision is not very popular. Because of the major resection and the associated morbidity, of injuring the surrounding neurovascular structures and the brain tissue. That's why the en bloc resection of the temporal bone is not very common. Ever since, if you know, Dr. Komune from Japan, who published in 2013 this procedure of en bloc subtotal resection, we have been practicing this and we have done couple of cases with amazing results. You know, so far what we have been practicing for the petrous bone malignancy, for middle ear, inner ear malignancy, is a piecemeal resection or followed by chemoradiotherapy or chemoradiotherapy alone. For such kind of a piecemeal resection, which is not an oncologically sound procedure, we can't expect a good result. And the need of the time to propagate this en bloc, complete temporal bone resection. So let me show where is the complete temporal bone. See, this is the petrous part. This makes the anastomosis with the sphenoid bone. This is greater wing of the sphenoid. See, one of the most complex bone in the skull base is the sphenoid. This is sphenoid, a lesser wing here and the greater wing here. All these foramina are in the greater wing of the sphenoid.
Sir, we lost audio, sir.
Sir, we can't hear you, sir.
Sir, we lost audio.
Sir, we can't hear you.
दिनेश मेरा आवाज आ रहा है?
Hello, can't you hear me?
Yes, sir, we can hear you very clear.
Okay, then what happened? Focus. So this is the sphenoid bone. This temporal bone has connections all around, and we have to, for an en bloc resection, we have to dissociate temporal bone from all surrounding connections. So the first connection here is to the sphenoid bone, that is the greater wing of the sphenoid, and this is the petrosphenoid suture line. I will show during the en bloc resection how to cut this. Then the medial limit of the resection is the petroclival fissure. This is the clival bone and this is the temporal bone. So this is the medial level of resection. For the lateral level of resection, see, for the lateral level of resection, this is the extraordinary canal. This is the squamous part of the temporal bone. So what we are going to do, we'll make a craniotomy of this. Yeah, why do you change this window? Dinesh. Yeah.
Sir, we are not changing any window, sir. You can continue. We can hear you. Just finish doing something.
Why it is going? What are you doing, Dinesh, today?
Yeah, no, sir. Just continue, sir. We able to hear you clearly, sir.
Okay. So this is the squamous part of the temporal bone, which we are going to make a craniotomy to separate this temporal bone from the temporal lobe above and the intracranial structures. Now behind, see this is mastoid part. This temporal bone is connected with surrounding bones, 3 bones all around here. Above is the parietal bone. This is parieto-mastoid suture line. This is squamo-parietal suture line. And this is occipito-mastoid suture line. So my craniotomy will extend behind this all the way to segregate the temporal bone like this. We have to remove this temporal bone en bloc. This is the lateral aspect. We have seen the medial aspect. This is lateral aspect. Now inferior aspect. See inferiorly. This is very important. This is so complex a resection. You can understand. See on the inferior aspect, this is jugular foramen. This is carotid canal. Our resection is going to spare the jugular vein, bulb, and the carotid artery. So our resection line will go lateral to these structures, lateral to this, involving the styloid complex. So we'll go medial to the styloid and join this. This is the jugular foramen, and this jugular foramen is the posterior limit of the jugular foramen is formed by the jugular process of the occipital bone. So after this craniotomy, we will disconnect this this temporal bone from the occipital bone by making this cut. So this entire medial part of the occipital bone will be spared. The jugular foramen, the carotid artery is spared, and all lateral thing will go all the way to this. This is TM joint. Now see, in the temporal bone malignancy, anterior to the external artery canal, the structure which is very often involved is this anterior wall, and see how close to the anterior wall is the TM joint. So in our such en bloc resection, we almost always involve the condyle of the mandible along with the entire TM joint. Our resection will go anterior to the TM joint and will involve the TM joint in the resection completely along with this zygomatic arch. Along with this zygomatic arch, so this resection will involve this entire structure en bloc along with parotidectomy. The reason for removing the parotid is the parotid contains so many lymph nodes, particularly the superficial lobe, and the first echelon lymph nodes of the temporal bone drain to the parotid nodes. So it is almost always we include parotid, particularly the superficial parotid, in temporal bone malignancy resection. Even if you do lateral temporal bone resection, we include superficial lobe. In such massive resection, we include the entire parotid along with the TM joint. Entire parotid means including facial nerve. When you do this en bloc resection, the facial nerve and the vestibulocochlear nerve is going to go. This is directed for cancer where the oncologically sound resection is a priority with some morbidity related to the 7th, 8th cranial nerve. We are definitely going to spare the 9th, 10th, 11th cranial nerve. The 7th and 8th altogether will go completely en bloc with the temporal bone and the TM joint and the parotid. That will be the most oncologically sound operation for this. Along with this, all these temporal bone malignancies, extensive malignancies, are not many times limited to the temporal bone. Very commonly, they extend anteriorly into the infratemporal fossa. I will show during this section, if the malignancy extends to the infratemporal fossa, since we do craniotomy and make this anterior cut from inside, we will elevate the temporal lobe of the brain and make this anterior cut under vision from inside. And when we make the infratemporal fossa here is the site of infratemporal fossa. This is the temporal fossa and this is the infratemporal fossa. So all our infratemporal fossa resection will be under vision. Even if the malignancy is extending, this is condyle, if it is extending to the infratemporal fossa, we can remove en bloc wide with a good margin all around the infratemporal fossa and resect altogether. Not only infratemporal, but the parapharyngeal space, even we can include very easily. And that is with no compromise with the oncological safety. So this is for the petrous malignancies. For the middle ear and the petrous bone involvement. For the extraordinary canal involvement, our primary resection is the lateral temporal bone resection, which we'll show after this. And that will be a complete resection of the extraordinary canal en bloc with the TM, tympanic membrane, and the malleus and the incus all together, the entire cuff together, along with the superficial parotidectomy. That is a different for limited extraordinary canal malignancies. Dr. Shiva, can you hear me? Dr. Shiva, can you hear me? Hello?
Yeah. Hello.
What is the protocol for the malignancies of the temporal bone?
Sorry.
What is the protocol at Tata for the malignancies of the temporal bone presently?
Protocol in the sense, surgery, of course, whenever the lesion is resected, considered resectable, we would do upfront surgery followed by adjuvant radiotherapy. That's what, I mean, broadly speaking, is the protocol. And the extent of surgery would depend on the disease, the lateral temporal bone or the subtotal. But we don't do a, I mean, we don't embark on doing a total temporal bone dissection, as we consider that to be a
So you
very
do
morbid
piecemeal?
procedure. Uh, we drill out. It's it's a drill out is what subtotal temporal bone dissection
Okay,
is a drill out
drill
essentially,
out and go around till you
not an
get the
en bloc
normal
resection.
bone.
Yes, it's a drill out because there is enough evidence in literature which supports a drill out procedure, which is considered safe for the patient, and it is less morbid
I
for the
know
patient
morbidity
compared to an
issue
en bloc
is
resection.
morbidity is
Now,
definitely less. That's why that piecemeal resection is preferred.
yeah,
With this resection,
that's why many of the skull based tumors are piecemeal resections. Let me remind. It's essentially because of the fact that there are so many important neurovascular structures that are in and around the skull base that we embark on doing a piecemeal resection to minimize the morbidity. The general principle, while we do give any treatment in oncology, is be it surgery, be it radiotherapy, be it chemotherapy, is the aim of any oncological treatment is to improve survival. Well, first, that's the foremost aim. The second important aim is to
yes,
retain the quality of life, or at least the quality of life of the patient should be as best as possible
agreed,
for the patient. Before
agreed.
he or she treatment. So if any treatment does not fulfill these two outcomes, that treatment has to be revisited, and we have to think as to how we can better. First, improve the survival. Next, quality of life is very essential, and that is one reason why an on-block resection is not undertaken, and we don't do it, at least in our practice. I'm not sure if rest of the panelists do. So, the results are not, are comparable in literature. Whatever has been published with the published literature, if you look at the survival that we have, it's not bad.
Okay,
It's
I
comparable for
agree
sure.
to your point to minimize the morbidity. Now, with this kind of resection,
Satish,
what?
Satish,
Yes, yes, Narayan.
can I
Yes,
interrupt?
sir.
I
Yeah,
think
Satish,
Narayan is
there are a lot of
trying
people
to
in
make
the
a point.
audience. What I would want you or Shiva to do is, you should talk about the T1, T2, T3, and T4 lesions, and what is the minimal oncological resection you would do in this. That's more specific. So then people will get an idea as to when to do a lateral temporal bone
Correct.
resection or when to do,
Okay,
further
okay.
extension.
Exactly.
So
Narayan,
talk about those
Narayan.
respects.
First
Yeah.
of all,
Perfect.
there is no standard classification which
Yes,
is
I know.
widely acceptable for the temporal bone malignancy. What Pittsburgh people have proposed,
Can I come in there?
is basically for the extraordinary canal, and a lot of things are lacking to answer a lot of questions in that classification. Number one, by and large, for the extraordinary canal malignancies, lateral temporal bone resection is the standard of care. The moment it extends to the middle ear or
Yeah.
the Peter's bone, the standard of care, in our opinion, is the en bloc resection of the subtotal resection of the temporal bone. Why subtotal? Let me tell you. Why not total? What we are sparing? What we are sparing is the part of the Peter's apex. The reason is, see, see this. Anterior to the jugular foramen is the carotid foramen. The internal carotid enters this as a vertical portion of the carotid artery, Petrus carotid, and then here, zoom in. Then here, anterior to the cochlea, it becomes horizontal. It runs in the Petrus apex to become vertical at the level of the foramen lacerum. This is foramen lacerum. So this horizontal Petrus carotid, which is running all the way at the Petrus apex, with the cavernous sinus being there, this procedure leaves the part of the Petrus apex here, which is mostly uninvolved, to make it as a subtotal resection. It is almost total, except leaving the small part of the Petrus apex to prevent morbidity of the cranial nerves in the cavernous sinus and the carotid injury. Rest is complete radical excision. Now, coming to Dr. Shiva's point about the morbidity, this
Hello.
procedure, if executed properly,
Nilesh.
believe
Nilesh,
me,
can you just send me the
doesn't have
numbers
any additional morbidity
subtotal
except the 7th, 8th cranial
क्या
nerves,
हुआ है if you have those numbers?
which Otherwise, in
that we have.
extensive temporal bone
Just watch
malignancies
the
are difficult to preserve,
perspective.
even if you do piecemeal. And many a time, the seventh nerve is already preoperatively involved. Even if you do piecemeal and a complete resection, till the normal margins, it is difficult to preserve the facial nerve. So here in this resection only the seventh and the eighth nerve are going to be resected, nothing else. Everything else will be preserved. So the hallmark is disconnecting the temporal bone from all around. This is a major procedure. In my practice, in the live surgical scenario, it takes me 8 to 9 hours to do this procedure, because I will show you one by one in detail how to dissociate the temporal bone from below, going from the neck, separating the vertebral artery so that it doesn't include in the resection, how to dissociate the temporal bone from the mandible, from the zygomatic arch, from the squamous bone above, from the sphenoid bone, from the clival bone, and from the jugular foramen here. All these cuts you have to execute properly to prevent any morbidity. The only morbidity is the seventh, eighth nerve resection, which is otherwise difficult to preserve in any extensive temporal bone malignancy. Otherwise, even if you do piecemeal. Number one. Number two, it gives you additional ability to clear the infratemporal fossa in detail, because you look at the infratemporal fossa from above. You can clear any anterior extension of this malignancy, which is otherwise difficult to do in a piecemeal resection if you go through the soft tissues. It gives the opportunity to clear the parotid radically and the TM joint, which is most often required to be resected. So as far as the morbidity is concerned, it is only seventh now, which is otherwise difficult to preserve. Number one. Number two, if we look at the oncological results, this is much above following the principle of en bloc resection as compared to the piecemeal. The reasons are very few people in the world are doing. There are not big series. So in times to come, we'll be able to compare much better than the present scenario.
Dr.
Yes.
Dr. Satish Jain, can I just come in here? For this en bloc subtotal resection, it was, there is a series published, of course, the series is 10, 20 in number and all that. The first series was published in 1975 by Stephen Aryan.
Yes.
If you remember his name, Stephen Aryan is the person who also, devised the pectoralis major myocutaneous flap. So he published a series of, en bloc subtotal temporal bone resection, followed by subsequently the Ann Abor group. They did the en bloc temporal bone resection and the en bloc subtemporal bone resection. And subsequently, there was a meta-analysis that was done of all the en bloc resections of the subtotal and the total resections. And it was compared over the years. In 2017, 2015, there was a series published where they compared all the en bloc resections, the lateral temporal bone, and the drill out procedures. And essentially, there was no drop in survival. Essentially, there was no drop in survival. What I'm trying to say here is to the audience, you can do an en bloc resection. If you are skilled enough to do an en bloc resection, please do it. Nobody is saying you shouldn't do it. But what I would like to drive home the point for the audience is, if you are not able to do an en bloc resection, it's okay. You can still have a good resection doing a drill out. And you can have a reasonably good survival for these patients. And the quality of life, there is no study which compared the quality of life between en bloc and drill out. So that's the second point. We really don't know the answer for that. But what I want the audience to take home the point here is that let them not consider that if you are not going to do an en bloc resection, they're doing anything inferior. I would like to emphasize that point. If you're able to do an en bloc resection like how you just described safely for the patient, please do it. But it's not a must. You can still have an oncological, a good amount of survival with a drill out as well. Is the point that I would like to make.
Issues to answer your issues. Number one, why it is not so popular? The fear was earlier was the reconstruction. Now with the advancement in the reconstruction technique, believe me, after such a major resection where you need to do two craniotomies, the middle fossa and the posterior fossa craniotomies with the lateral, we use the anterolateral thigh to reconstruct, and it reconstructs so well without hardly any morbidity of CSF leak or anything. Number one.
sorry, I just would like to place a point again, because it just is very important for the audience to understand that reconstruction is not the limitation. It's not because the reconstruction was a difficulty that the en bloc resection is not done. No.
Yeah,
Because
it was
Stephen
earlier the
Arden in
concern.
1975 used a PMMC to cover the subtotal en bloc resections.
Now
So
that's
let me
what I'm
remember.
coming to. That's what I'm coming to. Temporal bone has a lot of avenues for the tumor to spread easily anywhere. Let me tell you, temporal bone, like malignancy in the extramedullary canal, there are a lot of fissures and canal through which the malignancy can spread easily out, like fissures of Santorini, foramen of Hashka. Through a lot of suture lines in the temporal bone, there are a lot of dehiscences, lot of windows in the temporal bone through which this malignancy can spread easily. There are many channels in the bone through which this malignancy can spread easily to the distant sites in the temporal bone. That's why this piecemeal resection can never ensure you a complete clearance at the time of resection, whether you have gone all the way around the tumor or not. There are lots of fissures, foramen, windows, dehiscences, so many things in the temporal bone, so many avenues for the tumor to spread. That's why it calls for an en bloc resection, which ideally should be the standard of care. In times to come, this will be established. The reason for not being so popular is the extensiveness of the resection, the so-called the fear of the morbidity. That's why. That's how the surgical science is evolving. With the development of approach and the propagation of this technique, believe me, a lot of people are going to do. This is not difficult. Remove this fear of difficulty. This is not at all difficult once anybody understands the three-dimensional anatomy of the lateral skull base and the temporal bone and the connections of the temporal bone all around. The question that is always asked, the morbidity. Where is the morbidity? There is no morbidity in it. Only seventh now. That is our goal today, that how this can be resected without injuring the carotid artery, without injuring the jugular foramen, without injuring the lower cranial nerve, without injuring anything, with no CSF leak and a beautiful reconstruction with a free flap. The only morbidity is the seventh now. The first question for the people who are propagating the piecemeal is the less morbidity. Believe me, this is equivalent less morbidity, number one. Number two, with piecemeal resection, particularly in the temporal bone, with a lot of avenues of spread of the tumor, which is beyond the sight of the surgeon. There are a lot of fissures and foramina in the temporal bone through which a surgeon cannot ensure a complete clearance intraoperatively. Complete microscopic with negative margins cannot be ensured. With your experience, you can try to, but it is difficult, and it is always, no doubt in the oncology surgery, if en bloc resection is feasible, it is always superior. So the morbidity is the biggest question, and believe me, this is what we are here today to discuss, how difficult this en bloc resection is, which is I'm going to demonstrate. And believe me, this can be practiced, and you will love it. So let us start and let us discuss the pros and cons. Can we go ahead? Hello?
Yes, you carry on.
Yes. So can you bring the external camera first? Cautery on. Cautery the number. Down. So in this resection, as I told you, I will show you the incision first. Then one by one will dissociate the temporal bone from all around. The goal is to preserve every important structure around the temporal bone, not to damage anything. So the hallmark is the understanding of three-dimensional anatomy around the temporal bone. Temporal bone in itself is a very, very complex structure to understand in terms of anatomy. And more than that, the surrounding structures, particularly at the skull base, with a lot of neurovascular structure, particularly the serpentinous course of the carotid artery and the jugular bulb and the sigmoid and the transverse sinus, make it more difficult. So it's a teamwork. Definitely, it's a teamwork. We need to have a neurosurgeon in the team for the craniotomy. You can make, like we do our craniotomy on our own, with having done so many. So, but yes, neurosurgeon is an integral part of the team. And the plastic surgeon, of course, is an integral part of the team. And you being an oncologist, you can add on the neck dissection as a part of the procedure. Generally, for N0 lesions, we advocate level 1B, 2 and 3 for sampling, and if any positive, go for a comprehensive. Otherwise, it's a selective neck dissection level 1B, 2, 3. In the clinically positive, obviously a modified neck dissection from beginning. That is a part of the procedure. So you have to go, anyway you have to go in the neck to dissociate the temporal bone from below. You have to go anterior, you have to go posterior, you have to go superior, and then ultimately we have to, remove this N block with all surrounding structures preserved.
Okay, Satish, can I ask a question?
Please.
Yeah, so we were discussing piecemeal versus subtotal resection of the temporal bone. Now, you have a situation, for example, I'm just giving a hypothetical situation. You have a situation where you have the CA, which is cyst squamous cell carcinoma, which has invaded the otic capsule or invaded, say, not even the middle ear, and is going and adherent to the dura. So, what is the minimal oncologic surgery that you would do in these cases?
So, Narayan, once the tumor goes to the middle ear, once it involves the petrous bone, our procedure of choice is N block. That is the most oncologically sound procedure with same safety margin, same morbidity profile. Number one. This has the additional advantage of involving the surrounding structures which are involved otherwise. Many of the temporal bone malignancies present in advanced stage. Many of them, when they present, have already involved the mandibular condyle, the infratemporal fossa, above the temporal dura, sometimes the posterior fossa dura. Many times they are already involved. Narayan, tell me which piecemeal procedure can ensure a wide excision around the infratemporal fossa? How can you ensure going from inside around the infratemporal fossa? How can you remove the involved dura? Dural involvement is not a contraindication. You can remove the involved dura and reconstruct with a free flap. It is the N block resection which only can give this opportunity. That's why this procedure, that's why you see the world over, the results of temporal bone malignancies are relatively inferior, because such procedures are not very popular because of the fear of the morbidity.
Satish sir.
Yes, please.
Sir, many people are asking in which patients we have to subject them to radiotherapy in temporal bone malignancies.
Yes. These are all T3, T4 lesions for which this procedure is indicated, and they're obviously all subjected to radiation therapy. No doubt. This is only for the advanced malignancies, not for limited ones. Even in the limited ones for the this extra-auditory canal malignancy, we have indication for the post-op radiation. Like if the parotid is involved, if the anterior wall bone is involved, if there is perineural invasion, if lymph nodes, there are so many indications there are for the radiation, even for the limited T1, T2 lesions. Not all, but it depends upon the post-operative and the intraoperative findings, histopathological results and all that. But for all these advanced, definitely radiation is always a part. Idhar aao, piche. And focus. This is a fresh cadaver. We have 3 fresh cadavers today for different approaches. We'll try to cover as much as possible. See, focus on this. Idhar piche aao mere ko. Bilkul piche. Aaj isko upar karo. Upar karo. Camera up. Camera up. Light. Light ज़्यादा होगी क्या? Yes. इसमें light है क्या? जलाओ. Yeah. Are you getting the picture?
Yes, sir.
Yes, sir. Very clear.
Yeah. थोड़ा zoom out करो. थोड़ा सा. See, I am showing with the external camera the incision part. Then the rest of the procedure, for the fine detail's sake, I will show with the microscope, because there are so many critical structures that need to be understood. The anatomy is so complex. So my incision, as it requires 2 craniotomies, because above is the squamous part and behind is the occipital bone. So I have to expose the entire area and I have to go in the neck. And I need to have an option for the neck dissection as well if required. Zoom out, zoom out. Yes. Bas. So my incision would be right at the level of the superior temporal line. It is a curvilinear incision 4 inches behind the, full kar do, Quadri. 4 inches behind the ear, and then cutting. I will extend in the neck as required. So this will be roughly the incision. For the better cutting ability, I am using the cautery here, even in the cadaver. See, this is all suboccipital muscles. I can easily divide. And see, this is the area of the temporalis fascia. Anybody, please feel free to interrupt me any point of time.
Yes, sir. Yes.
Sir, this is a common incision for mostly for all infratemporal fossa approaches, no, sir?
See this? This is the temporalis fascia, and below is the temporalis muscle. Yes.
Sir, this
Yeah.
incision is given for most of the lateral skull basis cases.
Pardon?
This is the common incision for infratemporal fossa approaches, right?
Yeah, this is little bigger
Yes, a little bigger. Yes,
because we have to expose the occipital bone completely.
yes
I
sir,
mean,
yes.
few inches behind to make the craniotomy.
You should have the middle fossa and lateral both in view.
Yeah. Yes. So this is the incision, and now I am going to transect the extraorbital canal.
Yes, sir. Yes.
See, this is the extraorbital canal. And I need to go to the anterior end of the parotid gland, which is going to be completely excised. I am going to show you en bloc with total parotidectomy and TM joint resection. And this will involve the excision of the facial nerve and its branches as well. So in the reconstruction later on, not only the reconstruction of the defect, but some sort of animation of the facial nerve is also required. In young patient, you can do a good, along with the resection, you can do, along with the reconstruction of the defect, if you use the latissimus dorsi, you can do the reanimation of the face as well. So that depends upon the reconstruction team and the requirement. In the elderly patient, you may do a simple reanimation of the, the eye and the angle of the mouth. See, I am superficial to the parotid, going anterior to the parotid.
Yes, sir.
Just this is the simplest version for the sake of explanation what I am going to show you. As we go in the neck, you can always, as I said, involve the level 1B, 2 and 3 as you go in the neck. See, this is the primary exposure. I hope it is clear.
Yes, sir.
This is your extraordinary canal. Let me make it more clearer. This is your extraordinary canal for a reference. Okay? And this is the entire temporalis muscle which you can preserve. You can preserve the temporalis for the end for reconstruction. Additional muscle for the reconstruction you can always spare. There is no need of resection per se of the temporalis muscle. So this is temporalis. And what is this? This is the root of the zygoma. See, this is zygomatic arch.
Yes, sir.
This is zygomatic arch. And this is where the temporalis is going beneath the arch. This is the temporalis where it is going underneath the arch. This is the extraordinary canal. And this is the, what is this? TM joint, just for your reference. Can you see this?
Yes, sir.
This is the temporomandibular joint. This is the anterior wall of the extraordinary canal, and this is temporomandibular joint. This is zygoma.
In TMJ
And
ankylosis, what we do in
TMJ ankylosis, you have to resect the TMJ and reconstruct. We use sometimes silastic along with the TP flap.
okay.
So for
A lot
people
of
who
people,
want to, yeah, for
lot
people
of
who want
people
to learn
nowadays
this
use
picture,
processes.
Satish?
Yes, please, Narayan.
Yeah, I think I sometime back read an article by Professor Mazzoni about the subtotal, and he has given a beautiful description about this subtotal temporal bone resection. Fantastic article, exactly as you're describing.
Oh, great. Now, Narayan, I'm switching to the microscope for the better picture.
Yeah.
Yes.
Microscopic picture, please. Yeah, are you getting?
Yes, a wonderful picture.
So this was the bigger view with the external camera, and then we'll go from one by one to the different areas. Okay?
Yes, a beautiful view we are getting.
Is Dr. Shiva there? Dr. Shiva?
Yes, yes, yes.
Dr. Shiva?
He's, I think, he's there, but I think disconnected somehow.
Deepak sir?
I am there.
Yeah, please feel free to comment, feel free to interrupt. See, this is the lateral aspect of the mastoid. This is the external canal, you can see here.
Yes, sir.
This is the zygomatic arch. This is the temporal line, inferior temporal line. And this is the mastoid with the attached periosteum, musculoperiosteal tissue. And then I'm going towards the mastoid tip.
Yes, sir.
If the external soft tissue is involved, you have to resect that en bloc.
Satish, if you don't mind, can you show the occipital artery where exactly it runs?
Yeah, I'm going to show you, Ashish. That's a very important landmark.
Yes.
Now,
And show how to mobilize it, I think, from the nuchal.
yes, I will show you, definitely. Yes. See this, the first structure which is attached, the lateral most structure attached on the mastoid process. There are 4 muscles in order from lateral to medial which are attached to the mastoid process. The first one, we all know this is what?
Sternomastoid.
Sternomastoid.
Yes, sir.
Can you see?
Yes, sir.
Yes, sir. Yes.
Now this second muscle, see the orientation of the direction of the sternomastoid like this. And now the direction perpendicular to it, this is what? Splenius capitis. See this?
Yeah.
This is the second muscle in order. Now see underneath the splenius capitis. What is the third muscle? This one? Your occipital artery, your question is valid, Ashish, is still deeper. That is what I'm showing you, all the muscles in order.
Okay.
Now this third muscle, which now I am resecting, is longissimus capitis. See, all these muscles are on the mastoid process. See this?
Yeah.
This is third one. Now, what is the fourth one underneath? Can you see this?
Yeah.
What is that? See, going anteriorly? This is digastric.
Yeah.
Can you see?
Yes,
sir.
beautifully.
Now, is that clear?
Yeah.
So the 4 muscles in order for everyone, lateral to medial. Leave it. This was sternomastoid. Then the lateral one was this splenius capitis. Then longissimus capitis. And then digastric. And your occipital artery is going to be deep to digastric. See this? This is your mastoid tip.
Yeah.
And see how deep is the digastric? An occipital artery, which is a branch of external carotid, is a posterior branch of the external carotid. After emerging from there, goes underneath the digastric. It goes underneath the digastric. This is digastric. See this?
Yes.
And I will show you the external carotid and the digastric, how it goes underneath the digastric over the jugular vein, come behind. See now, all these muscles are attached here on the lateral part of the superior nuchal line. Now the medial part of the superior nuchal line here behind, the muscle attached there is the trapezius. Can you see here?
Yes.
And this occipital artery come here in between these muscles behind. So that's a very, very important anatomy to know the the occipital artery, which you have asked. Now I'm opening the neck. Artery. See this. See the structure, very, very important structure I can feel here is the transverse process of first cervical vertebra.
Yeah.
Here. And this is always behind the jugular vein. Hello?
Yeah, we can hear you, sir.
In the live surgery, it is very, very prominent, but here in the cadaver, all the vessels are collapsed. If you inject the latex, it makes the life, it makes the things different. Anyway. Now, this is the transverse process, okay? Now, if you see this is, this is your sternomastoid. Now, in the posterior triangle of the neck, I lift. There are many, many muscles in the floor. I told you, you have to separate the temporal bone from below. You have to go around if anything is involved. Separate from all around. See this. Yes. Now, let me show you some important anatomy here. Number one, and the most important here to understand, is this jugular vein. This is IJV. Pakadna. Correct? Yes. Yeah, it is completely collapsed. See, this is IJV, which is collapsed. You can see this.
Yeah.
Yes,
can you see this IJV?
Yes, sir.
Yes, sir.
Completely collapsed. Now, the cranial nerve related to the IJV, which goes behind, mostly lateral to IJV, we always see in our neck dissection. Couple of times I have shown you, is the spinal accessory nerve, and the other cranial nerves, which I am going to show you, are anterior to the vein, between the vein and the artery. Can you see the cranial nerves coming there in the neck?
Yes, sir. Yes.
So this is much, much simpler in the live surgical situation because the vessels are distended. This is your carotid artery. See, all collapsed. See, this is carotid artery here. This one.
Yeah.
Completely collapsed. So I can see the jugular vein, I can see the carotid artery, and now a lot of nerves which you need to pick up, because we are supposed to preserve all this all the way to the cranial fossa. This will form our medial limit of resection. So what here I am trying to say is why we have gone below here. The important structure below here to preserve is the vertebral artery. In your craniotomy, in your lower separation of the temporal bone from below, your vertebral artery is very, very important. That's a very close structure which you need to see and preserve. For the audience, for the sake of demonstration, this is your transverse process. See what I'm doing.
Satish, I was just going to tell you, you should show them what is the suboccipital triangle there.
Yes.
On the C1 process. So if you show them the suboccipital triangle boundaries.
Exactly, Narayan. See, from this transverse process, Narayan,
Yeah.
This is the transverse process. Can you see?
Yes, yes, clear.
There are a lot of structures, lot of, this is your occipital artery. Anybody? Yeah, yes. See this, Ashish.
Yes, sir.
Ashish wanted to see occipital artery. It is here. See, this is occipital artery.
Yes.
And this word deep to digastric. See this word
Digestive.
digastric? And this is occipital artery. Is that clear?
Yes.
Which need to be ligated. Now I am deep to digastric. Now, see what Narayan is saying, keeping an eye on this is posterior triangle behind. This very, very prominent muscle is the levator scapulae in the posterior triangle. Leave it, shoulder. Then this another muscle is semi-spinalis capitis in the posterior triangle behind. Now, if I retract this, if I cut and retract for the sake of demonstration, this levator. See this levator? I am cutting off. This is not required to be cut otherwise, for that matter. See now. We are going in the depth behind, and this is the suboccipital triangle. Narayan, you were asking.
Yeah. Yeah.
This is the suboccipital triangle. The boundaries are, see, this is your transverse process. This is a very, very important anatomy. And see, there are a lot of muscles emerging, or you can say attached to the transverse process. This is your occipital artery. Yeah. See this muscle going superiorly. What is this? Superior oblique. Narayan?
Absolutely, Satish.
And this muscle going inferiorly here is the inferior oblique, you can see. See this? Between these superior and inferior oblique, behind is the rectus capitis posterior. And that makes the triangle complete. Why we want to see this? Because this is a very, very important anatomy for an important structure, very, very crucial, vertebral artery. And this approach is one of the preferred approach for the anterolateral and lateral part of the foramen magnum. You know,
Yeah. Far lateral approaches.
yes, foramen magnum can be addressed anteriorly to the transoral, transnasal route, transadventite, posteriorly. But the only thing, if your lesion is extending laterally, you need to mobilize the vertebral artery. You need to have a control over vertebral artery. And this approach, what I'm doing is a far lateral approach, gives direct control over the vertebral artery. How come? Let me show you where the vertebral artery is for everyone. This is the transverse process. Keep an eye. The vertebral artery emerges in the lower part of the neck, lowermost part of the neck from the subclavian artery, goes up and it passes through all the transverse process foramina of all cervical vertebra. C6, 5, 4, 3, 2, 1. Passes through the transverse process foramina of all vertebra. This is 1. Below is going to be 2. In between these two transverse process, you can see the vertebral artery here if you want to. If I drill this transverse process, my vertebral artery is contained in this transverse process. See, this approach I told you, if I am operating for a patient in a live surgical scenario, this subtotal dissection takes me almost 8 to 9 hours. But believe me, it is worth. It's not the time which is the criteria, because you have to do extensive dissection all around. Now see, this is the transverse process of the second cervical vertebra. Can you see?
Yeah.
And from here, this vertebral artery, can you see the vertebral artery?
Yes, sir.
Quite
See
clear.
this vertebral artery?
Yes. Coming
Coming out of the second transverse process of the second cervical vertebra, this is going toward the first cervical vertebra. See this transverse process of the first cervical vertebra. Here, see the artery. See this vertebral artery. Very
Yes,
clear.
sir. Yes, yes.
And what is this now? What is this now? This is the ventral root of C2.
C2.
Second cervical nerve, which is the important landmark to identify this artery. I could identify because of this. This is the second cervical, the transverse process of the second cervical vertebra through which this artery is coming in relationship with the ventral root of C2. The dorsal root is behind, and then it is entering the first transfer process of the first cervical vertebra. Give me the bone nibbler or the drill. Bone nibbler first. Now let me remove the soft tissues over the transfer process. The important muscle which goes from here, from the transfer process of the first vertebra here, going up to the jugular foramen. See this? Can you see this muscle? This is rectus capitis anterior. That's a very important landmark in this surgery, because this will guide you to the posterior border of the jugular foramen. So now I'm uncovering the transfer process here for the sake of demonstration. This is transfer process through which the vertebral artery is passing through. Now either you have to drill it or I can remove it with the bone nibbler.
Satish, this is the same this is the same course between the C2 and C1, where if you get hit and the patient can die. Correct?
Pardon? Can you repeat?
The dangerous area is the one between the C2 and C1, where this guy got injured with a cricket ball. Remember?
Yes, exactly. You remember?
Exactly. That Australian.
Now see, this is passing through this foramina. Passing through the foramina. See this artery? And see a very important course of this vessel. In this approach, this is why you need to see this, to mark your inferior limit so that you don't go down to injure this vessel. So you need to see this vessel. See this artery.
Nice.
And then it takes a turn here going behind.
Yeah.
This is transverse process. This is transverse process, and it arches around the transverse process to become horizontal. See this horizontal portion.
Absolutely.
See this horizontal portion of the vessel. This is all vessel. This vessel coming from here, passing through the transverse process, going around, going behind. See this? Behind,
Yes,
and
sir.
where? This is your posterior arch of the atlas. See this bone? See this posterior arch of the atlas? Can you?
Yes.
Yes, sir.
This runs over the posterior arch of the atlas. See this? This is the posterior arch of the atlas where this artery is running over. And between this artery and the posterior arch, here is the C1. Yeah, this nerve here is the C1. This very thin nerve is the C1 here. So below we saw the C2 and C1. See this artery? And this artery goes behind. This artery goes behind all the way to pierce the atlanto-occipital membrane to enter the foramen magnum. So here, for the sake of demonstration, let me remove these muscles. This artery here is surrounded by extensive venous plexus. Once you dissect this region, you always face extensive bleeding of the venous plexus. And here, see this artery takes a medial turn. Here this takes a medial turn to enter into the foramen magnum. So such a tortuous course this vessel has. So what we need to have as a landmark, number one, this transverse process, the C2 arch and this vessel, and see how close we are to the mastoid process. So even in our jugular foramen surgery, even in our advanced otology surgery, let me clear this region. This is our principle. I always make sure to tell everyone our principle is 1 by 1. 1:1 principle means to safeguard yourself. See this, let me show you. Yes. This is your mastoid process. Can you see?
Yeah.
Yeah. See, this is mastoid process. So to safeguard yourself, you can go 1 centimeter inferior and 1 centimeter deep. If you try to go more than that, you can injure vertebral artery. Can you see here? Can you see very clear?
Yes, it is
Yes,
clear,
sir.
sir.
This is 1 by 1 principle. The vertebral artery is arching over here. See, in this approach to the foramen magnum, here it is going here deep to enter into the foramen magnum from here. And just above here is the occipital condyle. If I remove this to show you, above is the atlanto-occipital joint. Here. This is the atlanto-occipital joint, this bone. Can you see this? Here, this bone is atlanto-occipital joint. And above this joint is the occipital condyle, which I will show from inside. So, see this artery being elevated from all around. So, in lesion, suppose you have medially placed lesion, you can mobilize the artery laterally. If you have laterally placed lesion, you can mobilize the artery anteriorly, like that. So, this kind of control over this vessel, this is C1. This is C1 again, which I am dividing, yes. So with this kind of control over the vertebral artery, this is just to show you anatomy. This is the hallmark of far lateral approach to the foramen magnum. And this is the only approach to the foramen magnum, particularly for the lateral and anterolateral lesions, which gives you the ability to control the occipital artery. It doesn't restrict your approach, it gives you ability to control and then work in the foramen magnum. So here, if I resect, this is the suboccipital region. This is entirely the suboccipital region which I have uncovered. I will later on show you how it enters the foramen magnum and goes. So our goal here is, first of all, to show you en bloc resection, and inferiorly, this is my target to see the vertebral arteries. The reason is my occipital craniotomy will come behind here. And anteriorly, this cannot be, I have to join with the jugular foramen. And in this process, I should not injure the vertebral artery. That is my goal. I hope you understand what I'm trying to say.
Yes, sir.
Okay? Now, in the inferior anatomy, you have seen the mastoid process. Now the another process. What is another process? Let me show you here. This is styloid process. Can you see this styloid process?
Yes, yes.
This styloid process I had shown you on the temporal bone model. Projecting inferiorly, it leads to attachment of certain ligaments and the muscles. This one, the lateral most, is the stylohyoid. This one. It goes along with the digastric. And see the carotid artery. See the carotid artery. This is the external carotid between the, see the styloid process. The internal carotid is deep to styloid process, internal carotid and internal jugular, and the external carotid is lateral to the styloid process. That's an important anatomy to understand. This external carotid here arches above in the deep lobe of the parotid. Can you see here?
Yes, sir. Yes.
That runs lateral to the styloid. The external carotid is lateral to the styloid. The internal carotid is medial to it. See that? This is styloid process. And all the three muscles which are attached to it need to be resected. Now see, on the medial part, the muscles which are very important. This is important to preserve a certain important structure there. Let me retract and show you. Let me retract this. See, these are two muscles. Two muscles arising from the styloid. The superior one is the styloglossus. And this one, see this one. This is what? Stylopharyngeus. Can you see? Hello?
Yes, sir. Yes, yes.
And what is this nerve? in the depth of the stylopharyngeus. Can you see this now? Anybody? This is glossopharyngeal. Hello?
Yes, sir. Yes.
This is glossopharyngeal now, which is running anteriorly in the upper part, just below the jugular foramen. So
this is your Eagle syndrome, Satish.
Pardon?
Eagle syndrome.
Eagle syndrome, sir, is asking. Sir.
Eagle syndrome. Eagle syndrome is different. So, you know, there are a lot of misconceptions about the Eagle syndrome. It's not that your styloid is enlarged and you remove the styloid every time. This syndrome is of two types. One is when it happens to compress the glossopharyngeal nerve, then it gives neuralgia. And another one is arterial, because when it happens to become a ligament, solid, bone, this ligament ossifies, it may compress the internal carotid and the patient turns the head. And then it is dangerous. It can give rise to stroke as well.
Absolutely.
So there are two types of styloid syndromes. We have to be careful and able to identify, diagnose properly, so we can address. Now, see now, this is styloid which I have divided. This is the transverse process. This is your 11th cranial nerve. You can see.
Yes, sir.
Can you?
Yes, yes.
Yeah, that is the 11th cranial nerve. This is external carotid. Let me cut. Yes. This is jugular. That is carotid. This is the.
If you all are watching, you can see how the transverse process of C1 is a very important landmark. Just anterior to that, you get the internal jugular vein, and if you trace, you can probably find almost all the nerves in that same region.
Yes. Now, there are certain nerves in the upper part of the neck, just below the jugular foramen, which we need to keep an eye. That's the carotid artery. This is crossed by the glossopharyngeal above. And the second branch, which is crossing below, this is the pharyngeal branch of the vagus nerve. Below and parallel to the glossopharyngeal. It crosses the carotid artery. Anybody, one more branch crosses in the same direction, going deep to the carotid artery, which is a branch from the vagus. Anybody? Yeah, hold it. Yes. See? No, that is superior laryngeal. That goes deep to the carotid in the same direction. So this is 11th, this is 10th cranial now. Chodo. This is your carotid, the external and internal. This is crossed by the hypoglossal here. Hypoglossal doesn't come out of the jugular foramen. It comes out of the occipital condyle through the hypoglossal canal, which is deep to the jugular foramen, which I am going to show you later. So this is how we are reaching the jugular foramen from below. This is carotid artery. See this?
Yes, sir.
And the jugular vein here. So we have almost reached the level of the jugular foramen. Why it is important? See this. Let me remove this part of the styloid little bit. Because when we make the craniotomy here, it should go below to the posterior edge of the jugular foramen. We saw on the skull, the jugular foramen posterior edge is formed by the jugular process of the occipital bone, which need to be divided to make the jugular contents free of the resection. So that is going to be from deep to the mastoid process. This is where the jugular process of the occipital bone is. See this? Can you see this?
Yes, sir.
This we will cut. We will cut to free this temporal bone from behind. So you have seen this temporal bone from behind. You have seen the relationship of the temporal bone from below, and we have seen the vertebral artery preserved. We have seen all the cranial nerves, and here we have seen the posterior border of the jugular foramen. This is the jugular foramen.
Sir, can you summarize again 9th, 10th, 11th, 12th, all the nerves and vertebral artery once again for the people who have
Yes.
joined? Yes.
Yeah, this is the 11th nerve. See here behind. Okay.
Yes, sir.
That is the 10th cranial nerve
Yes, sir.
between the carotid and the jugular.
The two branches, sir.
Yeah.
Okay.
The ninth one is going anteriorly. See this.
Glossopharyngeal.
This ninth. This is glossopharyngeal. That crosses the carotid artery. This is carotid artery. It
Yes,
crosses
sir.
the carotid artery
Styloid process.
underneath the stylopharyngeus. We
Hmm.
saw the stylopharyngeus muscle and it was going underneath the stylopharyngeus. Okay.
Okay.
Yes,
Okay.
sir.
Yes, sir.
Now coming anteriorly, since this resection I told you, this will involve the facial nerve and the entire parotid. So I will not compromise with the resection here and go on to excise the parotid gland in toto along with its branches, because ultimately I told you the facial morbidity is associated with this, but that we cannot compromise with the resection. See, I am on the masseter muscle. Can you see?
Yes,
This
sir.
parotid
Yes, sir.
gland contains number of numerous lymph nodes. This parotid gland contains numerous lymph nodes, which I want to remove and block. And block and bring this parotid to the posterior margin of the mandible. This is so simple as far as the resection is concerned. See, I am elevating the parotid. Can you see? Very clear?
Yes, sir.
From the masseter. This is your external carotid. This is my external carotid, which I am preserving as it goes behind the mandible. See this? Here, this external carotid divides into two terminal branches, which I intend to preserve. I don't need to resect both the branches. The maxillary, because we have preserved the temporalis muscle, which is fed by the branch of the maxillary. See this? This again, a posterior branch above the digastric. This is posterior auricular artery. Can you see?
Yes, sir.
There are three posterior branches of the external carotid, three posterior branches. You can say, or one of them is medial, you can say the ascending pharyngeal, which is sometimes posterior, then occipital, and then this one is posterior auricular.
Yes, sir.
This is much above. And then finally, it divides into terminal branches. See this?
Yes, sir.
So I have elevated the parotid tissue anteriorly. No. See this? This is my border of mandible if you want to see. This is something need to be seen here. See, this is border of mandible.
Yes.
Yes, sir.
Is that clear? And this is your condyle, which is going to be part
It
of
would
this
be
section.
excised. Yes, sir. And block.
This is your external carotid, which divides behind the condyle. See this? This is your external carotid, which need to be preserved like this. This is your branch above. And this divides into two branches, the superficial temporal, which I am dividing here, and the maxillary branch going behind, deep to the mandible. See that?
Yes,
That
sir.
is the mandible condyle. This is the TM joint. Can you see?
Yes,
Yes,
sir.
sir.
Can you? TM joint, and this is the condyle. Okay?
Yes, sir. Ramus, we can see.
So I am going around the temporal bone, around and around.
Healthy margin. No?
Satish, some people even ligate the external carotid below,
Pardon?
right? Some people ligate the external carotid below itself, right? Before the branches, terminal branches.
External carotid itself. This is external carotid.
External carotid. So some people ligate it over there to finish the resection. That's what I'm saying.
No. In this external carotid need not to be ligated. Need
Just
not to
before
be
its terminal
ligated.
branch.
Narayan, this need not to be ligated.
Okay.
because we want to preserve the maxillary artery, which is the terminal branch of this vessel. We can ligate the superficial temporal, but not the maxillary. Maxillary, we should preserve. My maxillary is going here. See this? Behind the mandible. Can you see here?
Yeah.
This is my maxillary artery. This is the external carotid, and this is the maxillary artery going. See everyone, this goes behind the condyle mandible. And this is the TM joint now. This is the notch of the TM joint. And this is the zygomatic arch. I told you initially in the resection, give me the drill. No, Patli. But I told you in the resection, we will remove this N block.
Yes, sir.
So far, why we are spending so much of time to save everything outside the temporal bone, which are not involved. There's no point in removing everything and giving morbidity. Give me a good cutting bar. Generally, we use the disc bar over here. This is only the condyle I'm taking because this condyle is in the close proximity of the external canal.
Yes.
Sometimes even this entire skull base is involved by the tumor, and this approach gives you opportunity to remove N block. Everything, wherever it is going, go beyond that.
Sir, Dr. Ravi wants to throw some light on fascio-mesentéric nerve reanastomosis.
Fascio-mesenteric.
Yes, sir.
Oh, I have shown you earlier a couple of times. Let me, for everyone, where is the mesenteric now? I have not so far gone deep, so still I can show you. That's a right point you have asked. See this. Mesenteric nerve is a useful nerve for the facial nerve anastomosis, and that is a preferred nerve now for the facial nerve anastomosis. Now see, this is TM joint, this is zygomatic arch, this is the muscle, mesenteric muscle. In the depth of the mesenteric muscle, there is a tendon. See this tendon of the masseter?
Yes,
Yes,
sir.
sir.
Yes, sir. Wonderful.
If you go to the tendon, this
You can
45
see,
degree
sir.
angle, see this 45 degree angle.
We
Yes, sir.
got a
Yes.
glimpse, I think, sir.
Nerve to masseter courses in a 45 degree plane in the depth of the muscle, more than a centimeter depth of the muscle, antero-inferiorly, underneath the tendon of the masseter. That is some people consider it difficult to identify. Believe me, if you follow the proper landmark, it's not difficult to identify. Here it comes out of the mandibular notch. It's a branch of, V3, and you can tap this nerve in that region.
It has strong motor function. That's why you are using it, sir.
Pardon?
It has strong
Pardon?
motor function. That's why you're using it.
Yeah, this has a strong motor function. This nerve is one of the strongest, it is supplying one of the strongest muscle in this region, and that is masseter.
Yes, sir.
It's extremely useful motor nerve. This is my nerve. That is nerve.
Yes, sir.
See
Beautiful.
how deep it is. Can you see?
Yes, yes.
Yes, sir.
How deep it is. So in that situation, another advantage is your facial nerve trunk is right here. This mastoid process, your facial nerve trunk comes out here, and this is the shortest anastomosis one can think of. Shortest of the anastomosis one can think of, it is given out by the masseter muscle, masseter nerve. Now this is temporalis muscle, this is masseter muscle. See it? Okay, leave it. My ये पतला देना यार, ये काटने को देना, देखो इससे कट जाएगा, कट जाएगा. Give me. नहीं चल रहा. छोड़ इसको, छोड़ दे. I'm using this craniotomy to Section. Drill. See, I am resecting the TM joint.
Sir, Dr. Faisal from Pakistan is asking about rehabilitation after you remove the resection of the mandible joint.
Yeah, generally on ipsilateral mandible, yes, it needs resection, and that is what I told you. Your plastic team is there, and many a times we leave it. Doesn't give too much of morbidity.
Yes, sir.
It's always better to reconstruct. Sorry.
Yes, sir.
Because this resection will require a lot of reconstruction later on. Post surgery, this require extensive soft tissue reconstruction, because everywhere you will find the middle and the posterior fossa opened up.
Yes, sir.
You require something for the facial now, at least ophthalmic reanimation by means of a lid loading or something, and something for the angle.
Yes, sir.
Can you hear me? Okay.
So is Shiva around? Is Shiva around?
Is Dr. Shiva there? This is a zygomatic arch. Okay?
Yeah. Yeah. So either Shiva or Dr. Sareen or Dr. Satish can take this. What is the role of superficial paroticectomy, if any, in squamous cell carcinomas of the external auditory canal? Or is it always that you would go and do a deep lobe paroticectomy as well?
See, Narayan,
Yeah.
the extra-auditory canal or the temporal bone, they drain to the lymph nodes, and the first echelon lymph nodes are where? They are in the parotid. So it is always good to do a parotidectomy along with that. It is not for the contiguous involvement of the parotid gland. It is for the sake of nodal clearance, to ensure that no nodal disease is left behind, and if there is any nodal disease present, it warrants a neck dissection as well. So that is for the part of for the sake of managing the secondaries. Now, pen,
So my question is, Satish, would you always do a radical paroticectomy, total paroticectomy, or would you sometimes consider doing even a superficial paroticectomy?
For this massive malignancy, we go for the total parotidectomy.
Yes.
See,
so when do you consider superficial?
Yes. Here the survival is more important. You have to accept a little bit of the issues. See now is the time for our double craniotomy. What we are going to do, let me tell you. This is our zygomatic root, Narayan.
Yeah.
It passes, it goes behind. And see, what is this point? This point is asterion. Asterion is what point? There are three suture lines meeting at this point. This is asterion.
Yes, sir.
What? This is parietal. This is occipitomastoid. And this is parieto-mastoid suture line. Can you see this?
Yes, sir.
Yes, we can.
This point is asterion, and this point is an important point which marks the inferior border of the transverse sinus. You know, our sigmoid sinus, this is external canal. Our sigmoid sinus runs like this, okay? Toward the jugular foramen, and here it becomes the transverse sinus. I had shown on the skull model. So this point where the sigmoid sinus becomes the transverse sinus, this is what we need to see. And this angle, this is the sigmoid, this is the transverse, and in this angle below is made the suboccipital craniotomy, which we see in the retrosigmoid approach. Below, between the angle of these two sinuses, okay? Now, Here, our craniotomy is going to be like this. The squamous part, and then going behind this up to the occipital bone like this. See this? I
Yeah.
am going to remove the complete bone without going into the temporal bone. My temporal bone is here. This is all in the occipital bone behind. This is the squamous part above, and this entire craniotomy will be done. And I have Pankaj Boss here, a neurosurgeon, to give this craniotomy super fast. Pankaj Boss. So this is a very, very important part of the surgery to give this temporo-occipital craniotomy. Again, this will be my superior limit of the temporal bone to resect. This will be the posterior limit of the temporal bone to resect. Inferiorly, we have dissociated. Anteriorly, we have marked. And then from here, the craniotomy side to the jugular foramen, we will drill away this jugular process of the occipital bone, forming the posterior part of the jugular foramen. And then, superiorly, once we make this craniotomy, we will raise the dura from above, and from under vision there, we will enter below into the infratemporal fossa. From under vision there, from above, we will see this carotid goes vertical segment, then horizontal here above, and anteriorly. We will go all the way following the carotid artery horizontal segment and remove this this temporal bone lateral to staying lateral to the carotid artery. Then posteriorly, once this craniotomy is formed, we will separate the posterior fossa dura from the temporal bone and cut the 7th, 8th nerve in the intra-aortic meatus, and then remove this entire thing and block. So let's see the craniotomy first. Pankaj was ready. So he'll do with the craniotome. He'll first make a hole to engage the craniotome. Yes. थोड़ा इधर कर दो, यूं कर लो ना, हाँ, मार्क कर दो, यूं करो, यहाँ से ये लाइन है, यहाँ ले लो, यूं, yes, yes. This is the marking for the craniotomy I have made. ले लो, ले लो.
What we can do, we can take the landmark from the superior border of the zygomatic arch to the mastoid group.
This is almost asterion.
Yeah.
He is almost at the asterion. Udbhav and Sandeep, meantime, any questions you can take?
Yes, check till now. Yes, sir. Yes, sir. We are.
The last question was about rehabilitation, sir. Again, there is no question.
Yes.
Satish.
Yes.
Till you are at it, I want you to make it absolutely certain to people that sleeve resection is not an option in any cancers.
Check out.
Yeah.
If you have a disease in the temporal bone, number one, the bony part, occipital bone, and you are trying to remove piecemeal.
Exactly.
Number one, this is very practical, you have to understand. You cannot ensure if the disease is going beyond your visible confines because there are a lot of avenues in the temporal bone for the disease to spread here and there. You cannot remove. Number one, there is a chance of leaving the disease behind. Number one. Number two, how will you ensure a free margin in the bone? Number three, okay, you have removed part of the bone. If the disease is going in the infratemporal fossa anteriorly, dura behind, above, anywhere, how can we ensure a complete removal if we are going
But
to
then,
the center and going to the periphery of?
periosteum though, fine.
So, we all know the oncological principle that we need a safe margin all around. How can we defy that? The reason it is not popular is the difficulty I have already told you. But that cannot be the basis of an excuse for a more oncologically sound procedure.
Yes, sir.
Dura seems to be very much adherent.
Sir, Dr. Satya wants to know about sigmoid notch and mesenteric notch. Are they same?
What?
Sir, sigmoid notch. Dr. Satya wants to know sigmoid notch and mesenteric notch. Are they both same?
Sigmoid notch and
Mesenteric
Mesenteric
notch.
notch.
I didn't get. Sigmoid notch and posterior mark.
Mesenteric notch and sigmoid notch, are they the same?
Mesenteric notch.
Yes, sir.
Mesentery is different and sigmoid is altogether different. They are not anywhere close to each other. I don't know.
Yes, sir.
Sir, recently they had done a same thing in Hyderabad. I think they're asking, is this a subtotal resection or a total temporal bone resection?
Total, see this, craniotomy. From this
Yes,
point,
sir. Beautiful.
anteriorly just above the zygoma.
And sir, meanwhile, Dr. Faisali from Pakistan wants to know about the fish classification in short. Can you throw some light?
Pardon?
So on the fish classification, Dr. Faisali wants to know in brief.
Fish classification for paraganglioma.
Yes, sir. A brief discussion on the classification.
Okay, we have discussed earlier, but fish has described the paraganglioma into 4 categories A, B, C, D, which now have been modified by Mario Sana, being more practical. This is the inferior cut, occipital, more inferior. Yes, now this is the occipital craniotomy. So join करना है. See the craniotomy mark.
Yes, sir.
That's a very, very important step. This is uninvolved bone, which has to be fixed again at the end of the surgery. See, the temporal bone has been segregated below and behind.
Yes,
Can you
sir.
see once you remove the bone flap?
Yes, sir.
Sir, can a PMMC flap also be used for reconstruction?
Flap?
PMMC flap also can be used.
This is temporo-occipital craniotomy.
No, for reconstruction, can a PMMC flap be used, sir? One person is asking.
No. The best is free flap. Preferred is the anterolateral thigh or the this latissimus dorsi. Sir, morning, sir. Latissimus dorsi. The advantage that you can use it for the facial reanimation also at the same stage. गर्म हो गई? Oh, craniotomy not working. चलो, ये लग गया. बैठो. एक बरोल बना लो, एक one more बरोल. So making one more burrow to complete this craniotomy. So this way we'll be able to segregate this temporal bone from above and behind. In the skull model, I had shown you in the beginning how temporal bone is related to the intracranial segment, related to the intracranial structures from inside. Above is the temporal lobe, middle cranial fossa, and behind is the posterior cranial fossa related to the cerebellum. तो नहीं जाना वो बर ड्रिल रेगुलर ड्रिल या ये रही यस
Satish sir,
yes Bob.
Sir, Dr. Dishit from Bangalore wants to know about the minimal invasive retrosigmoid approach.
Minimal invasive retrosigmoid approach I am going to show you on the other side. It is basically retrosigmoid approach with a small
Endoscope.
opening, and you can use the endoscope to go to the posterior cranial fossa for various procedures of microvascular decompression.
Yes, sir. Yes, sir.
Neurectomies can be done through that approach using the endoscope. You don't have
Sir,
to go by the classical retrosigmoid, but with a small incision, small craniotomy using an endoscope, you can go and do the same thing.
Yes, sir.
You can do a lot of microvascular decompressions and neurectomies through that procedure. And the popular are all the cranial nerve compression syndromes. Like fifth cranial nerve compression is trigeminal neuralgia.
Yes.
It could be seventh cranial nerve compression, it could be facial nerve, spasms. Then the eighth cranial nerve could be hearing loss and tinnitus, glossopharyngeal neuralgia with the ninth and
Yes.
10th cranial nerve. All these, compression syndromes can be tackled through that. So that
Then,
gives
but
ample of exposure. Even with a minimal invasive, you get adequate exposure to do all that. I will show that after this.
yes, sir.
Sir, thank you so much. We have sir here, principal sir here, this college, who has always been helping. Perfect. Thank you.
And sir, Dr. Hello.
Yes.
Sir, Dr. Dishit also wants to know difference between subtotal petrosectomy and subtotal temporal bone resection.
Oh, subtotal petrosectomy is a sort of exentration of all air cell tracts of the temporal bone, preserving the labyrinth.
Yes.
And this is subtotal temporal bone resection, wherein you are too radical to remove the entire temporal bone intact.
Yes. Yes, sir.
So this is a different procedure. It is more extensive, more radical, and it is meant for malignancies. Now the last part is going to come, and we are going to remove this flap. और लो करिए उसको. So now it is almost complete. See, this entire bone flap is coming.
Yes, sir.
In the live situation, you have to be very careful preserving the dura all everywhere. Yeah, and that can be done through making multiple burr holes. Here we have made only 1 or 2 burr holes to expedite, so probably injure the dura at 1 or 2 places.
Sir, especially in elderly patients, it is adherent to the bone, sir.
Yes, in elderly patient, it is the dura is very, tightly adherent. Yes. See this. See now the temporal bone here.
Yes, sir.
We have segregated already from below. You can see the vertebral artery and all. This craniotomy, I told you, we will connect this to the jugular foramen from here to here in the end to mobilize. This is posterior cranial fossa. Here, a little bit of the damage to the dura, no issues. That is behind to separate from the posterior. Yeah, sinus is intact. This is from the posterior cranial fossa, and here superiorly from the middle cranial fossa, the dura is little bit again injured here. Anyway, we can still tell you what exactly is required to be done. Okay? Now give me bone nibbler. Bone nibbler, bone nibbler. I will remove this little bit for the demo. Section. See this. This is purely extradural otherwise, unless the dura is involved. Unless the dura is involved.
Yes, sir.
Once dura is injured, it poses challenge to preserve the, to prevent the injury to the brain. This is our zygomatic arch, Yes. So this entire temporal bone has to go. Now you can understand what is our goal. Patla dissection. Patla section. आगे आगे. See, I am elevating the dura. Hello?
Yes, sir.
Yeah. And that needs to be removed for a better exposure. Now, you can see the middle fossa floor better now.
So Satish, will you elevate this dura to the superior petrosal sinus or
Madam,
more?
to the?
Towards the superior petrosal sinus, where are you going now? Elevating the dura
Ideally,
right
it
up to the
should be
superior petrosal
elevated
sinus?
from behind to front. Your point is valid, Narayan.
Yeah, I know.
See, many a times what happened, why Narayan is asking, I can understand. Many a times, this, see the structure which we need to see the greater petrosal now. And many a times it is dehiscent, And your dural elevation can injure the greater petrosal now. Narayan, am I correct?
Yes.
See now, what
Absolutely.
I'm trying to show you. This is middle meningeal artery. Let me magnify
Yes.
to give you a better view.
It's
Narayan, this is middle meningeal artery. Can you see? This
Yes, we
is
can.
your GSPN. Can you see knife?
Beautiful groove there.
Could you see the GSPN? Chota knife then. What are you doing?
Yeah, it's a beautiful groove, I said. Very prominent groove.
Now the important landmarks are arcuate eminence and the GSPN.
Yes,
I think
sir.
arcuate eminence is also pretty prominent in this case. You can see the arcuate eminence.
Yes, sir.
Yeah.
This middle fossa approach, that's a part of the middle fossa approach, what I'm doing. See this?
Yes, sir.
This
Even use
is
this for
your
Otori also. CSF Otori also.
GSPN. Yes.
So Satish, you're going to elevate all the way to the superior petrosal sinus, right?
Pardon?
You're going to elevate
Yeah.
this dura up to the
No,
superior
no.
petrosal.
In this, you don't need to elevate there because our goal is not to go to the posterior fossa from here.
I understand.
We have already posterior fossa cannot Narayan behind.
Yeah, I understand that.
This looks like arcuate eminence, Narayan.
Absolutely.
Many a time it doesn't correspond to. Many a time.
So the actual figures they say corresponds to only 49% of the times to the
Nice.
superior semicircular canal.
See, for everyone, this is your external artery meatus. This is going to be your, middle ear in the depth, and superiorly is going to be the attic over here. And we know in the attic there are a lot of, ossicles there. So this is the area where I'm working, just for your information. So this is my GSPN here. This is the part of the dura. That is GSPN. You can see very clear.
Yes, sir.
And this is your arcuate eminence, most likely, probably corresponding today.
So Satish, I can see your GSP and I can see your arcuate eminence. You should show them where your internal acoustic meatus would be, and also the direction. Means if you put an instrument in the external auditory canal, you'll also get an idea of where the internal acoustic meatus would lie.
Yes, Narayan, I'm going to show you. And for that matter, what Narayan has asked is a very complex question because a lot of people have different techniques to identify the intra-auditory meatus. There are 4 common techniques described by 4 different, legions. By Hugo Crash, by Garcia Ibanez, by William House, by Mario Sana, are different techniques. So now, first to orient you, let me orient you where I am. इसको उधर करो थोड़ा, कुर्सी दे दो कुर्सी, इसको उधर खिसका दो, बस, हाँ इसको इधर खिसका दो, ये कुर्सी देना. See this, to get this, Narayan, what we are going to get out, this bone harboring the malignancy intact. That is our goal. And for that, we have to go all around this bone. These 2 craniotomies. Now, where to make the release? How to release this bone from such important structures? So, number 1, to orient you, this is our external canal. Why I am saying you, this is my GSPN. Give me the drill. Let me show you something for your orientation. This is not to be done in end block resection. See what I have opened, Narayan?
Yeah. Pigment.
Can you see something? Ossicles. See this, Narayan?
Yeah, pigment.
What you see the anatomy from below, pick the right angle. See the malleus head? Can you?
Yes, sir. Yes.
Very clear?
Very clear.
That is the horizontal facial nerve.
Yes, yes.
That was the tensor fold. And that is the, see this, the tendon of tensor tympani. Could you see?
Yes, sir.
Yeah.
And this is your this thing,
Tympanic segment. Tympanic segment.
tympanic segment. Give me the diamond one. This I see. So this, let me magnify. See, this tympanic segment is the continuation of labyrinthine segment. So the facial now, see, our internal auditory meatus is roughly here. From here, the labyrinthine segment comes and continues as a tympanic segment behind, and this GSPN anteriorly. Is that clear?
Yes, sir.
Absolutely.
This is what I want to show you from here. See it very, very clear. This is just for the sake of anatomy. Or this. See, to everyone, this is tympanic segment of the facial now. We are seeing from the middle cranial fossa approach.
Yes, sir.
See this very clear. What I am trying to show is the geniculate ganglion. This is geniculate ganglion. Can you see?
Yes, sir.
See, this is geniculate ganglion. This is the ganglion. So from geniculate ganglion, the nerve which is going anteriorly, this is GSPN. Can you confirm this, Narayan, now?
Yes, absolutely.
This is GSPN. Now, having seen the GSPN, there are a lot of important structures to be, related to it. Intra-auditory meatus is going to be here, which I am not going to open in this process. I am going to cut the intra-auditory meatus from behind. So this is the geniculate ganglion, and this is the horizontal facial, and this is how my labyrinthine segment is going to go to the intra-auditory meatus. Clear?
Yes, sir.
And this is geniculate ganglion, and in this junction here, what is going to be there? What is going to be there at this junction? Cochlea.
Cochlea. Yes, sir.
This is just to orient you so that you will never forget. See this. My labyrinthine segment is going to be here where I am drilling. See this. This
Yes,
is
sir.
where I am drilling is going to be the labyrinthine segment. Here.
This is where it divides GSPN
And now where I am drilling is going to be the site of cochlea.
yes, sir.
Colletti is the surgeon who initially described the middle cranial fossa approach for cochlear implantation. Nowadays, with the advancement and the subtotal petrojectomy approach, this is no longer of use. See this. This is the labyrinthine portion of the facial nerve going.
Yes, sir.
See that? This is the labyrinthine portion going like this. This is GSPN, and in this angle is what? Cochlea.
Cochlea.
In the live surgical situation, when you do a complete facial nerve decompression, like I mentioned you the indication in our facial nerve webinar, you have to be very, very careful not to injure the cochlea and the vestibule, which are in close proximity to the labyrinthine portion. This is labyrinthine portion, which is going like this. And now here, give me the skull. I told you where the cochlea is seen in the skull. Yes. You remember where I showed you the cochlea?
Yes, sir.
Let me show you where I'm working. See, this is the Peter's bone on the skull.
Yes.
Can you see the Peter's bone?
Yes, sir. We can
This
see.
was the extra-auditory canal. This was the mastoid. This is the site of the intra-auditory meatus. The vestibule and the semicircular canal, and the cochlea is here. See this?
Okay.
So imagine in the skull, I am working at this level. Got my working? Got my, see what I'm? That's why in the transcochlear approach, when we remove this entire thing from laterally, we get the widest exposure of the brain stem. Once you excise the cochlea here and rest of the petrous apex, with from here to here, you get the widest exposure one can think of in any lateral skull base approach of the entire brain stem is the modified transcochlear approach, which I'm going to show you on the other side. So that is the approach, because the cochlea is here. If you don't remove the cochlea anteriorly, this area remains unexposed and you can't go anterior to the brainstem. So to go anterior to the brainstem in all transtemporal approaches, you need to drill out the cochlea to go anterior to the brainstem to the basilar artery region. So this is where the cochlea is, where I'm drilling. This is intra-auditory meatus. This is the middle fossa roof. Can you see a middle fossa roof?
Yes, sir.
And now see, this is middle fossa roof. I am in the middle fossa roof, just to orient you again and again. Drill. And now see, in no time, I am going to be inside the cochlea. Patli the neck. See here, can you see the blue lining?
Yes, sir. We can see.
That is the blue lining of the cochlea. Patli de na. That is inside the cochlea. Give me the ball, bro. Patli de na. See, this is my labyrinthine segment going like this in the intra-auditory meatus here. This is the superior semicircular canal, and this is going to be the cochlea, which I am opening from here. See this?
Yes,
This
Satish.
is the basal turn of the cochlea. Everybody.
Beautiful, sir. Beautiful, sir. Wonderful.
And here is the labyrinthine portion, which runs in close proximity to this upper turn of the cochlea. Here. This is the inside of the cochlea, and you can implant from here. Professor Coletti was the one who described this technique for the cochlear implantation in patients having chronic suppurative otitis media. You don't need to go to the temporal bone. See this? This is the basal turn of the cochlea. Okay? Now, we know in our ear anatomy, we know in our anatomy that the vertical petrous carotid comes anterior to the cochlea and takes a horizontal turn. You remember?
Yes, sir.
See now, so that is cochlea anterior to the cochlea. Number one, it is going to be the genu of the carotid. Got my point? Number two, we know this GSPN runs in the roof of the carotid. If I go just below the GSPN, this is superior inferior exposure. What I'm looking at is from superior, and just inferior to the GSPN, anterior to the cochlea is going to be what? Carotid. Got my point?
Yes, sir. Yes.
And see this carotid, once it becomes horizontal here, it is crossed laterally by this structure. What is this? Middle meningeal artery. Try to recollect all these points. These are important. Remember, now, this is my GSPN, which now I am here. At this point of time, I am cutting off. See this?
Yes,
One
sir.
more now, that is lesser superficial petrosal now runs anterior to it. Very slender now runs anterior to GSPN. Okay? So I have cut the GSPN over here. Remember? And what is this lateral to the GSPN there? Anybody? Surprise. What is this muscle? Here is a muscle. This is tensor tympani. Now see, focus on the point of the carotid, which is most important for our resection. We have to spare the carotid, we have to stay lateral to it. See this, I have cut the GSPN,
Yes,
I have
sir.
exposed the cochlea just for the demonstration, and now I am going deep to GSPN. See carefully. I am going deep to GSPN and anterior to cochlea. What is going to be there?
Petrous carotid.
Narayan?
Petrous carotid, Satish.
Yes. And see lateral to the carotid. What is this? Tensor tympani.
Okay, sir.
Beautiful.
See the carotid coming in the picture. We know the carotid is just anterior to the cochlea. See the cochlear wall.
Yes, sir.
And carotid is having a millimeter distance from the cochlea. We see in the middle ear. Now this view is different. Why I told this? This is three-dimensional anatomy. What we see in our regular ear surgery is the posterior approach, lateral approach. And what is this? Superior approach. The same anatomy in different perspective. This skull-base anatomy need to be studied from different perspective. We advocate in 5 perspectives. See, this is carotid artery, genu. This is
Yes.
cochlea, and just anterior to that is the carotid artery, genu. Is that clear?
Yes, sir.
Now, see, genu turns horizontal. See this, genu turning horizontal now. Yeah, that is more anterior. See, this has become horizontal now. Can you see?
Yes, sir. Yes, sir.
Now, what is there lateral to it? This is tensor tympani.
Tensor
I have
tympani.
resected. What is then lateral to tensor tympani? What is there underneath, below the tensor tympani? What I'm opening? Anybody? What is there below the tensor tympani?
Eustachian tubes.
This is Eustachian tube.
Eustachian tube, sir.
See where I am? This is Eustachian tube.
Yes, sir.
This is bony Eustachian tube which I have opened. This is bony Eustachian tube, Panita. See this?
Yes, sir.
This is bony Eustachian tube. This is genu of the carotid, the horizontal petrous carotid. Now, if we follow this carotid, let me show you. See, I am not opening the intra-aortic meatus from here, but for the sake of what Narayan mentioned earlier, this is what I am retracting is the dura till the petrous edge, the superior edge of the petrous, where the superior petrosal sinus goes. I can open my intra-aortic meatus from here. If I run by here, it will be my intra-aortic meatus. Now see, my intra-aortic meatus is in this direction. The petrous region here, just below. See this posterior fossa. See, this is petrous ridge. This is the direction of the intra-aortic meatus. This is the carotid. This is the cochlea. And what is this bone? This rhomboid area. If I drill this bone, I'll be right onto the brainstem. That is what anterior petrosectomy. This is what anterior petrosectomy is. So you can extend the dimension of the anterior petrosectomy scissors. Let me show you how you can extend. If I drill away this bone, I'll be right on the brainstem. Anterolateral part of the brainstem.
Yeah. So this is also called the Kawasai's approach.
Kawasai's approach. See now I have divided, Narayan, I have divided the middle meningeal.
Yes,
Yes.
sir.
Now see what I'm elevating. The dura in layers.
Gasserian ganglion.
See what is this now?
V3.
Yes, the thickest of all the nerves. This is V3.
Oval, yes, sir.
See this mandibular nerve.
Yes, sir. Spine, foramen
This is
spinosum,
mandibular
oval.
nerve.
Yeah.
I have already resected the middle meningeal. This is the V3 which I'm, retracting here till the petrous ridge behind. And see, this is the carotid artery going anteriorly. See the carotid, the horizontal petrous carotid, you can see very clear.
Yes, sir.
Yeah.
See, this is crossed by two structures. Posteriorly was the middle meningeal and then the V3. The
V3.
same structure, if you remember, I had shown in the endoscopic dissection from the nose, wherein this horizontal petrous carotid, this is the horizontal petrous carotid you can see through the nose. It goes here anteriorly to the level of the foramen lacerum. And here, this is crossed by two structures, the V3 and the middle meningeal artery. This is foramen oval, this is foramen spinosum, and this is the horizontal petrous carotid going. And here is going to be the petrous apex. See this?
Yes.
Anterior to this is the petrous apex. Now, this is, one of the branch of the trigeminal. V3 is one of the branch. Where is the other branch going? See, this branch going is V2.
V2.
Yeah. This is V2 which is going up in the foramen rotundum. This is V2. This is V3, this is V2, and in between them is the anterolateral triangle. This is V2, this is V3, and in between them is the anterolateral triangle. And if I go in this triangle, Udbhav,
Yes, sir. Yes, sir.
what tumor comes out in the middle cranial fossa from this triangle? I have mentioned several times. Angiofibroma.
Yes, sir. Yes, sir.
See, if I drill this into this, what is this?
Yes, sir.
Pterygoid process.
Very good process.
Yes, sir.
This my bone. See the same
Extension with
anatomy.
the
Skull-based anatomy means you have to be three-dimensional, four-dimensional, five-dimensional. In our skull-based course, we emphasize our next course after this COVID era is a 5 days course. 1 day dedicated to the endonasal anatomy, 1 day
Yes, sir.
dedicated from the different perspective, lateral anatomy, lateral skull-based anatomy, 1 day transcranial anatomy,
Wonderful,
Yes,
sir.
sir.
1 day transfacial anatomy by open approaches, maxillary swing, and 1 day radiological anatomy.
Yeah.
So,
Satish,
Ultimate.
can I interrupt, Satish?
yes, please. Narayan.
Satish, you have shown the same anatomy from the endoscopic approach. Now we are seeing
Yes.
the same Vidian and V3 and carotid from the middle cranial fossa approach. And I think in
Yes.
one of your previous dissections, you have also shown the lateral approach. For people who are used to the lateral skull-based dissection, the infratemporal fossa B and C. So when you start drilling all the base of the zygoma and going, again you come through the same anatomy from the lateral approach, what Satish is talking about.
Absolutely,
Yes,
Narayan.
So there are 3 layers of
I'm
looking at
going
the
to
same
show
thing.
of the carotid and all these structures from the lateral approach after this.
Yeah.
I am going to show the same anatomy with the lateral approach after this. That will be totally different from different perspective.
Yeah.
So this is
But-
V2 I have separated. Can you see the V2 now?
Yes.
Can you see the V2?
Yes,
Yes,
sir.
Now see, there are a lot of things to be, picked up over here. This is the posterior fossa petrous ridge, from where the trigeminal nerve is ascending into the middle fossa.
Yes, sir.
Okay? This is middle fossa, where we are. यार काटने वाली देना यार, क्या दे रहा है नरेश? Give me different scissors. See, this is middle fossa floor, and here is the trigeminal nerve, which is ascending. Give me, hold on. See, this is tentorium.
Yes, sir.
Yes,
This
sir.
is tentorium.
Cerebral.
Yes. So from here, the fifth nerve is ascending into the middle fossa, dividing into 3 branches. See this? This is the V1. This is V1. Narayan, can you see?
Yes, sir.
Yes.
Yes.
Two layers
This
of
is V1. This is V1, V2, V3.
Wonderful, sir.
And in this tentorial edge, if you see carefully, can you see some nerve in the edge of the tentorium?
Fourth nerve.
This is cochlear nerve, fourth nerve. This one. Okay?
Yes, sir.
Very clear?
Common site for cavernomas, no, sir? This area?
Common site of?
Cavernomas.
Cavernomas. Yeah. Maybe.
Sir, can you show the Meckel's cave? Throw some light on Meckel's cave.
Yes. See, this is. See, this is the ganglion from
sir.
where V1, V2, V3 diverging.
Yes, sir.
This is the ganglion. This is the petrous apex. And here, this is the Meckel's cave.
Yes, sir. Dural fold.
See, I've broken this. This is Meckel's cave. And see what is this now below? Can you see something?
Yes.
Anybody? This is 6 now.
6 now. Yes.
Wonderful, sir. Yes.
V3, V2, V1, Meckel's cave, and Meckel's cave is crossed by, laterally. This now is ascending onto it. It's a 6 now. See this? Can you see this?
Sir. Beautiful.
This is the petrous apex, and this now ascends under one ligament. Can you see this ligament?
Yes, sir. Yes, sir.
That forms a sort of canal. See this?
Yes, sir.
This is petrosphenoid ligament, and that forms the Dorello's canal. See everyone?
Yes, sir.
How the 6 now
Ultimate.
ascends here into the cavernous sinus. Now see, this was just to show you anatomy. I deviated from our temporal bone dissection, but this anatomy is important to understand because that is also our goal. So this is horizontal petrous carotid. You can see
Yes, sir.
horizontal petrous carotid, and what it becomes after this. What the horizontal petrous becomes, the vertical petrous, horizontal petrous, and it turns up here. Can you see this? This is horizontal petrous and it turns up here. Can you see this turns up here? And this is crossed by the abducent. This is the cavernous carotid.
Wonderful, sir. Yes.
Paraclival carotid. There are different terminologies you can use. This is paraclival carotid. This is foramen lacerum.
Yes.
Where my instrument is foramen lacerum. Got my point?
Yes.
Now, see this. What I cut this? This was our GSPN. If you remember in the beginning, this was our GSPN, which comes here. GSPN which I cut. Under the GSPN was carotid. This GSPN comes here till the foramen lacerum, and then what happens? It goes. See this canal. This goes here. Can you see this here? Yes, between V2 and V3, in the depth is the pterygoid process, and this goes in a canal of the pterygoid process. What is this? Median now.
Median canal.
See, all this you see from endonasal side. This is different perspective. So what is this? This is the median canal. If I drill this this pterygoid bone.
Yes.
So this is pterygoid bone between V2 and V3. If I drill in the depth between V2 and V3 is the pterygoid process. This is where my instrument is the pterygoid process, thick one. And from the foramen lacerum, the nerve goes through this pterygoid process anteriorly. See this anteriorly is the median nerve if I drill in the depth. I hope it is clear.
Yes, sir.
Crystal clear.
Okay. Now,
sir, vein of Labai, can you show, sir?
Skull, wo pen dena.
Sir, vein of Labai.
Vein of Labai is different, man. That is in the temporal lobe. I will show you. See now, again to the skull to orient you. This was the petrous surface.
Yes,
we
sir.
elevated the dura till petrous surface like this. This was the petrous ridge I showed you. This is the cochlea here. This is the intraocular meatus.
Yes.
This is the cochlea here. Okay? And this is the petroclival junction where the fifth nerve ascends. Can you see here the fifth nerve ascends?
Yes.
That crosses the petrous carotid. You have seen the petrous carotid in the depth. Horizontal petrous.
Yes.
And this nerve, one branch goes in foramen ovale. You have seen.
Yes, sir.
This one
Yes.
middle meningeal you have seen.
Spinotum. Yes.
This is V2 you have seen.
Yes,
And the
sir.
V1 goes in the superior orbital fissure here.
Wonderful, sir.
V1, V2, V3, foramen spinosum for the middle meningeal, and this is the foramen lacerum, where this petrous carotid horizontal becomes vertical.
Vertical.
And from here, the fifth nerve comes, the sixth nerve comes, and crosses, the fifth nerve crosses the entire structure. Now again,
Yes.
see.
Sir,
The
can
same
we see
thing.
the Gogelos canal also, Doctor?
Yeah, I have shown you. I'll show
Yes.
you again. See now. This fifth nerve, see all the three branches of the fifth nerve. This is coming from the posterior fossa here.
Yes.
See this fifth nerve? This is the petrous ridge, the superior petrosal sinus. Okay?
Yes,
This fifth nerve, if I elevate, see it crosses what? The carotid artery.
Yes,
This is
sir.
the sixth nerve, the Dorellos canal. Can you see this?
Yes. Yes,
Yes,
sir.
sir.
Yes.
And this is the petrous apex. Okay?
Yes, sir.
And I
Yes.
shown you just before the petrous apex, I had shown you this cochlea here. This one.
Beautiful. Yes, sir.
Okay? So you have seen the cochlea, you have seen the petrous apex, and this is the foramen lacerum, and here it turns the Vedian canal anterior to it between V2, V3, V1. And V1, if you follow, see this. This V1 is going to the superior orbital fissure. This is the superior orbital fissure. See this one.
you can see that, yeah, quite clear.
Yes. So all this fourth nerve, sixth nerve, V1, and the third nerve above here, they all enter into the superior orbital. Boss, we'll show in the afternoon the middle fossa transpetrous approach. Then we'll show all this anatomy from different perspective. There we'll see in this anatomy why it is important. If you have suppose I have a temporal bone lesion which is extending into the middle fossa, I can remove from here. I can remove the petrous part through the transpetrous route, and the above part is the middle fossa route. If I have a lesion extending far anteriorly into the temporal lobe, I can use the combined approach, the middle fossa transpetrous, extended. Now, if I have a lesion from here going into the orbital apex, this is orbital apex, I can combine anteriorly, and what you can do, you can better combine with the FTOZ, frontotemporal orbitic. In our next webinar, we are going to show that FTOZ. There you remove the entire zygomatic arch and the lateral wall of the orbit, and the entire lesion. If the disease from the temporal bone, even if it is going to the eye, you can remove completely. FTOZ with a transpetrous approach, and you can remove altogether. Complete skull base extension you can remove in one go. This is why the anatomy is important. Now this is V1 and V2. Udbhav,
Yes, sir. Yes, sir.
what is there in between if I drill? Gift is waiting for you. Udbhav,
Yes, sir.
see what I'm doing. This is V1 and V2. See from the, imagine from the endonasal perspective. Imagine from the endonasal perspective, what is there between these two? I am going. See this. What is this? Sphenoid sinus, man.
Sphenoid sinus.
Yes, sir.
Yes, sir.
This is sphenoid sinus. See
Sphenoid
this.
sinus. Yes.
Between V1 and V2, the sphenoid sinus. In the lateral wall of the sphenoid sinus, superiorly is the V2, and below and medially here is going to be the Vedian now. Vedian canal is going to be here. Okay?
Yes, sir.
And between this superior orbital fissure, this is V2, foramen rotundum. What is this bone in between? I told several times. Man,
Yes.
in the endonasal dissection, I have told several times, the bone between the foramen rotundum and the superior orbital fissure is what? Maxillary strut.
Sir.
I have shown in the angiofibroma surgery earlier.
Yes, sir. And And
Yes,
superior is
sir.
the optic strut. Yes.
Lateral
Remember
lateral
everything.
viscous limitation.
So this is a different perspective, you can say. Here is going to be the clinoid process,
Clinoid.
and I am not going to show here in detail now. We'll go with the different appraise. This is clinoid process, and medial to that is the above that
Op,
is the optic nerve,
optic
and
chiasma.
between this optic nerve and the superior orbital fissure is the
Op,
optic strut.
optic strut.
वो बस FTOZ में दिखाना पड़े. Can you see this dural band?
Yes, sir.
This is the clinoid process, the lesser wing of the sphenoid. And this band coming from the orbit to the meninges is known as orbitomeningeal band. From neurosurgeon's perspective, this is an important structure. From the transorbital surgery, it is important structure. In the next webinar, when we show the open approaches, we are going to show the open approaches like maxillary swing, open approaches for the frontal sinus like osteoplastic flap, cranialization, facialization. Will show the entire in-depth anatomy of the orbit from different sides, each and every nerve and muscle of the orbit and their relation, and many other open approaches. FTOZ, including FTOZ in one of our next webinar. So here we got deviated from our this for the anatomy. So we started for the subtotal dissection. See where we were. This was the carotid artery. Can you see?
Yes, sir. We can see.
We have already given a cut over here for our zygoma. You can see. For the TM joint, you can see. And now, staying lateral to this V3, I am going to combine this cut to this. Got my point?
Yes, sir.
And then staying lateral to the carotid, I will mobilize the carotid. This is Eustachian tube, you can see. Can you see this?
Yes, sir. We can see.
Yes, Satish.
This is your carotid artery. From here, this carotid has become vertical to horizontal. This carotid coming from the neck to the vertical petrous here in front of the cochlea. This is cochlea here in front of the cochlea. It has become horizontal. So at this point of time, I am going to mobilize this carotid anteriorly away from the temporal bone and resect this temporal bone all the way. Got my point?
Yes, sir.
Yeah. So I think now you stick to your resection, bony margins.
Pardon, Narayan?
Yeah, I think you stick to your resection margins, then you can show further anatomy after that.
Yeah, let me resect this and I will show you.
Exactly. Then you can see more anatomy after that.
Now, this V3, if I follow, I will be in the infratemporal fossa. I told you in the beginning, if my temporal bone malignancy is extending in the infratemporal fossa, I will see from above and remove accordingly. This kind of access this kind of access cannot be given by other approach. We will see and go around the infratemporal fossa. Each and every anatomy of the infratemporal fossa you can see from above. See this? See,
Yes, sir.
under vision, I have to stay lateral to the carotid. I have to preserve all the V1, V2, V3. This I dissected for the sake of anatomy demonstration. This is something beyond this point you need not to go. You need not to go beyond V3. You have to identify the V3, that's it.
Yes,
Okay?
sir. Yes.
Now see, just after the foramen ovale, this is foramen ovale. The V3 will get into two divisions. See, this is my craniotomy. नहीं चल रही यार. This is how the V3 is. And V3 will divide into two divisions. The larger posterior one, we all know. We should know all the branches of the V3 because all are important. This is foramen ovale.
Yes, sir.
See, this V3 will fall down in the infratemporal fossa like this, like a horseshoe leg. So, once you come by the endonasal side, this V3 is roughly, see how much? 4 to 5 millimeter anterior to the horizontal petrous carotid. Got my
Carotid.
point?
Yes, sir.
This is one of the most important landmarks. From endonasal side, when you have to identify the parapharyngeal carotid and the horizontal petrous carotid, the V3 is one of the best landmarks, I would say. Yeah. Now see, I am into the Eustachian tube.
Yes, sir.
This now is to mobilize the carotid. See, I am going below. See, that is the genu of the carotid.
Yes, sir.
In light surgical session, it takes long time because once you drill along the carotid, all the time you have to use the diamond bar. Okay? You cannot be so aggressive.
Yes, sir.
See here, what I am trying to show, give me the scissors, just for the sake of anatomy. These are V3 branches. See the V3 branches. This is posterior division. It gives 3 branches. After the section, I will show you the infratemporal fossa anatomy if you want. This is the posterior division going behind. See this?
Yes, sir.
It divides into 3 branches. See here under vision you can cut. See, this is lateral pterygoid muscle. How much deep, how much inferior, how much anterior you want, you can go from here. See under vision. This is the
Beautiful, sir.
posterior division which I want to show here. Posterior division of the V3 which divides into 3 branches. See this?
Yes, sir. Yes.
The one which goes underneath the TM joint, crossing the, see the middle meningeal here is the auriculotemporal. Then 2 branch going down, those are lingual and the inferior alveolar. Okay?
Yes, sir.
Clear?
Very clear.
Now, the next step is mobilizing the carotid artery. I will mobilize from here the carotid artery to the carotid foramen, where the parapharyngeal artery enters into the carotid. Okay?
Okay.
Now, in next probably 10 to 15 minutes, we'll be through with this procedure. Periosteum. See what I'm trying to show you here? Our cut will, this is our carotid. See this?
Yes.
Bone nibbler. What is lateral to carotid is the Eustachian tube, which you have to drill away. वो देना कैरिसन. Give me कैरिसन यार, ये नहीं.
Satish?
Yes, Narayan.
Just a quick question. You started off from the say posterior of the patient. Now we are all dealing with head end of the patient. So do you want to change your angle of working back to your behind the ear, or would you want to walk from the same angle?
Narayan, I couldn't hear you because of the echo. Can you slowly repeat, please?
I said we started the resection like we do ear surgery. Now we are sitting in a position like the middle cranial fossa surgery. Correct?
I can't hear.
Can't hear. Hello?
Yeah, Narayan, can you repeat, please?
I said we started surgery like we sit behind the, like we do ear surgery, standing posterior to the patient, okay, with the head turned. Now your orientation is middle cranial fossa.
Yeah, I am sitting above.
Yeah, exactly. So do you want to change for the resection back to the original position, or you want to resect it in the same way? This is
Yeah,
from the delegate.
I will go back there.
Yeah. So from the delegate's point of view, show them from that approach. So it will become much
Yes, sir.
more, because
Yes,
middle
yes.
is difficult for people to appreciate.
Yes, yes. See, Narayan, now, what I'm doing. See,
Yes.
this is my vertical petrous carotid.
Yes, sir.
I am drilling this eustachian tube lateral to it and this part of the petrous bone to mobilize it. Because once we mobilize elevate the temporal bone, you have to segregate the carotid out of this place. All this petrous bone lateral to it. See this vertical petrous carotid, and here you will always find a thick periosteum.
Yeah.
Always,
Is,
always you will find a thick periosteum.
is Shiva around?
Uh, I can't hear him. Is Dr. Shiva around, please?
Yeah, I'm here. I'm here.
Shiva, just a quick
Yeah.
question. When you have tumors coming and say along the sheath of the carotid, whether it be the vertical or the petrous carotid, would you be able to do a complete resection if it is involving the carotid sheath? Would you excise the sheath, or would you still go by this approach if the carotid itself was involved?
If the carotid sheath is involved, maybe yes. So that's the point I was exactly trying to make. So that's T4A as far as the Pittsburgh classification is concerned, and maybe now you have to really think of what is the the treatment approach for those patients, and if it is that, if only that is the point of contention,
See,
and there's nothing
so
else.
that's what I'm trying to Shiva make a point that if it is completely resectable, you go and do
Yes.
such a big procedure. And if you're not going to be achieving say N0 resection or R0 resection, then
Yes.
would you be doing your piecemeal resection and then giving a patient post-op radiotherapy?
Narayan.
No. I wouldn't make it an R plus dissection and try to justify an adjuvant radiotherapy and hope that the adjuvant radiotherapy will take care of the residual disease that has been left behind. No, that's not going to
Yeah.
be our approach. If we
Narayan.
will definitely assess as to whether this patient can be operated upfront, and if he's if we can do that, we will definitely give him that option for sure.
Yes,
Narayan, can you
Satish?
hear me?
Yes, I can hear you, Satish.
Narayan, now I have moved posteriorly.
Yeah, I can see that.
Superiorly, you have seen the exposure.
Yeah. You can see the
Now
seventh
I'm
and the fifth nerve also very nicely.
yes. Now see, I'm posteriorly, and there are a lot of important structure you can see in the posterior canal fossa. What I want to cut is the 7th 8th. This is 7th 8th complex. Can you see?
Yes, sir.
What you need to ensure is to preserve the ICA loop, if any going. See this?
Yeah, Satish.
Yes, sir.
This is lower cranial nerve 9, 10th, 11th. Mat read sakte.
Hugging
Can you
the
see this?
tubercle. Yes,
9,
sir.
10th, 11th. Though this dura should not have been opened, just I am showing you the anatomy. This is 9, 10th, 11th. You can see.
Yeah. This is all posterior fossa. Completely.
Yeah. I'm posterior to the bone.
Yeah,
So
yeah.
this is 9th here, most likely 10th, 11th. This is the spinal accessory. See the spinal component of the 11th.
Yes, sir.
Yeah.
Yes, sir.
And these are the rootlets of the 12th cranial nerve. Can you see?
Yes.
And what you see here is the vertebral artery. See this vertebral artery?
Yes.
Wonderful, sir.
And this vertebral artery is the same which is going from here.
Sir, this is the same view we get from minimal approach when we put the endoscope inside.
Yeah. So this vertebral artery is the same which is coming from here and going through the foramen magnum here.
Yes, sir.
It enters the
Beautiful
foramen magnum
CPI.
here and it enters the intracranial space over here. So this is
So that is-
vertical. This is spinal accessory.
Yes, sir.
That is the 12th one passing to the occipital condyle. This is occipital condyle.
Yes,
And
sir.
here it passes through the condyle. And here, if I drill, would be the hypoglossal canal. This is 9/10. and this is the dura.
Yeah,
Actually, you have to stay extradural.
can you point over the tubercle? That
Tubercle.
yes, sir. Yes,
Oh,
sir.
these now run over this tubercle. That is jugular tubercle.
Yes,
To
sir.
enter, I will show when we see these approaches later on. So this is jugular tubercle. This one, over
Yes,
which
sir.
these nerve arch into the jugular foramen.
Yes, sir.
Okay.
Yes.
So now this was our craniotomy, and this we have to communicate with the the the, the jugular fossa over here to here, and then we'll mobilize this this temporal bone and block. Could you see?
Okay.
This is
Wonderful, sir.
the middle fossa. This is posterior fossa. You have to stay extradural completely. I had shown the anatomy. This is extradural completely and remove this out, staying lateral to the carotid and lateral to the jugular bulb and the lower cranial nerves. Okay?
Yeah.
Yes. See, en bloc resection. I told you this is a difficult procedure in the sense you have to be used to the three-dimensional anatomy. You have to have a team. You have to have a good craniotomy. All this is required.
So Satish,
See, in
again, I'll ask
oncology,
you.
what we read in oncology, if the cure rates of the two procedures are same, you can opt the one which gives the least morbidity. But when the cure rates are different, you have to choose the one which gives the highest cure rates in spite of the morbidity, whatever. Same thing in the larynx. If a conservative approach gives the inferior approach, I will not mind doing a radical one. In spite of it, it involves sacrificing the voice. That is what the principle of oncology.
Yeah, but the survival, as far as the literature is concerned, I just would like to reiterate again,
Yes,
is
boss.
T3, T4, the latest meta-analysis by Lovini, published in Laryngoscope, the T3, T4, and all the surgeries have been drill outs. Let me remind. I'm not, I mean, of course, hand block resections is great. You can do it. I'm not criticizing that. What I'm trying to say is the survival is the same. And since 2006 to 2020, the survival for T3, T4, T3 has increased from 35 to 76%, and T4 has increased from 5% to 36%. So the survival has only increased and not decreased for a T4 temporal bone cancer malignancy. And there's no comparison, head-on comparison between an on-block and a drill out. To say a drill out is inferior to an on-block resection, or an on-block resection is superior to a drill out, like what you said. If any study shows that an on-block is superior to a drill out, of course we will adapt that. There's no question of not adopting that. We would not want to give an inferior treatment to any of our patients. That's for sure.
Hello.
Yes, sir.
So I am in the last process of mobilizing this bone. Pardon? Drill. Yeah. Udbhav, you can take further questions. Meantime, I drill this part.
Sir, I think you have explained each and everything about all the foramens, all the anatomy, and people are totally mesmerized. They are saying
So this
absolute
is
mind.
just to
Yeah.
the final detachment process is on. Give me the cautery fast.
So you have shown each and everything. People, whatever people have asked, station tube, cancer, campani, Douglas canal, everything you have shown.
See, anatomy is different, but this has to go completely extradural.
Yes, sir. So many people are seeing this first time, this superior anatomy of temporal bone from this perspective.
This is not commonly practiced, as I told you. Yeah, retract. This is not commonly practiced, Udbhav.
Yes, sir.
You have to have the utmost care. See where I am going? Inferior to the carotid to the inferior petrosal sinus. Yes. Just khitna mat, khitna mat. This is the same rhomboid region I told you.
Yes, sir. Yes, sir.
I told you in the beginning, the rhomboid region between the intraocular meatus here and the carotid here to open up the this is the safe region, and this is one of the approach anterior petrosectomy for the brain stem. See this bone, and this is what where the inferior petrosal sinus is. I had shown on the skull earlier about the inferior petrosal sinus, if you remember.
Yes, sir.
This is your inferior petrosal sinus. This is the dura. Yes. A little bit of the bone needs to go. Yes.
Sir, Dr. Ramesh Gohiwal sir is saying wonderful demo. A complex anatomy has been made very easy by Dr. Satish Jain.
It's always complex. You have to see again and again. See, you have to see this again and again. Do it again and again to get used to.
Yes, sir. And sir, thanks to Dinesh, this time the video quality is superb. People are appreciating the video quality and everything.
Yeah. No. Give me the drill. Last part of the drill. Scissors. Staying lateral to everything.
Yes, sir. Sir, Dr. Anil Jain from Bhopal is thanking you for the mega party on Sunday and teaching the depth understanding of
All infratemporal muscles, you can cut under vision. In case you need some extensive resection, you can cut under vision. Now you see where we are. Give me.
Yes, sir.
The entire neck and the brain has become one cavity. See this?
Yes, sir. Yes.
That's why it requires a huge reconstruction by means of a free flap. But now what we have achieved, everything and block. Where is the bone? Bone. See this? Petrous part of the bone. See this?
Beautiful,
This
sir.
extra-aortic canal. This is your zygoma, TM joint. Everything and block. See this Petrous part, entire Petrous part. No piecemeal, nothing. The beauty is in surroundings. You know, this is your infratemporal fossa. This is your mandibular condyle. This infratemporal fossa, it gives you amazing access to go anteriorly and remove wherever the tumor is gone. This is parapharyngeal space. It gives you amazing, access to remove the tumor from the parapharyngeal space. This is the vertebral artery level. This is your inferior limit. This is your posterior fossa and the middle fossa, keeping the dura intact always. And see, this is your V3. I told you about the branches. Give me scissors. So what you damage is the seventh nerve completely. This is your auriculotemporal, this one, from this V3 root. This is anterior root giving to the temporal nerves and the buccal nerves and all those. This is V3. These are the inferior branches. See this, lingual and the inferior alveolar. See these two branches?
Yes, sir.
These two going down. The one goes in the mandibular canal, that is inferior alveolar nerve. See these two nerves. See carefully. These are the two nerves. Can you see?
Yes, sir.
So this is the mandibular ramus, and here is going to be the mandibular canal. One of them is going in the canal, and the one medially is going to be the lingual nerve. So this is how the V3 branches travel here. Okay? This is mandible, and this is the infratemporal fossa full of all these muscles. This is about, and see, this is carotid artery all the way. See this. Carotid artery all the way.
Completely mobilized, sir.
See this carotid artery?
Beautiful, sir.
You can mobilize also it. This is horizontal petrous. This is horizontal petrous. Just for the sake of demo. And here, this is not to be done in live surgery like this. And this is right, the entire horizontal petrous, mobilized. Why I'm showing what I'm showing? See this. This is the vertical petrous. This is the horizontal petrous. If you elevate the horizontal petrous, whatever remaining bone here, which we have left, is part of the petrous apex. This is to preserve the carotid artery here, because here the carotid turns to become the cavernous portion. This remaining part is the petrous apex. So, like, suppose we have shown a couple of paragangliomas. In the paraganglioma surgery, when you have a tumor extending into the petrous apex, this is petrous apex. Many a times you have to mobilize the artery anteriorly, because in paraganglioma infratemporal fossa A approach, you have a full exposure of the artery right from here to the petrous, the vertical petrous, and then horizontal, you can combine with the infratemporal fossa B, elevate it by means of using umbilical tape, retract it, and drill away this bone underneath. This is petrous apex. This is petrous apex, and below here is the clivus, the petroclival region. There are many approaches to the petroclival region. See, this is as a whole, the exposure by and large. So for the petroclival region, there are many approaches. Let me show through this. This what procedure I have shown is the most major, I would say, skull base surgery of the entire skull base. The most major procedure of the entire skull base, wherein you have to remove this. In the live situation, it takes hours and hours because of the you need to protect the carotid in the jugular. You have to use most of the time diamond burr. Every time you have to protect dura, some venous bleeding here and there, and it really takes time. But you can remove it and block, and this kind of a resection in the oncology setting with a neck dissection, it cannot be inferior to a piecemeal resection, I can say. There's no way. Now, coming to what I was saying, are you getting this picture of the skull module?
Yes,
Yeah,
sir.
we're getting it. We're all seeing it.
This is the petrous apex. we divided. This was the carotid going in the, this petrous canal. This is the canal, and this is foramen lacerum, where it ascends to become cavernous. This part of the petrous apex which is left, that's why we call it subtotal. Now, this is the petroclival fissure. This area of the clivus petrous, the petroclival area. Now, there are many approaches to address this. Anteriorly, this is sphenoid sinus here. This sphenoid sinus. For many of the lesions which are not extending far laterally, because the carotid is going to come here. If you come endonasal through the sphenoid sinus below here, endonasal, you can't go far laterally. So for midline lesions not extending far laterally, the endonasal is one of the preferred approach. And even if some laterally extending tumors, if you can mobilize in a good pneumatized mastoid, you can mobilize the carotid a little bit, and you can even remove little lateral lesions by the infrapetrous, suprapetrous approach endonasal, and you can remove the extradural lesions. It is not advocated for the too much of the laterally extending intradural lesions. Now, the second approach is the preferred neurosurgical approach. Is the anterior petrosectomy. In that, they elevate the middle fossa dura and come to the anterior petrous. Between the, see this is the, can you get another marker? This is the level of the intraocular meatus, and this is the level of the fifth cranial nerve. In between these two, they remove this anterior petrous bone. I had shown you the exposure, that rhomboid area. Remove this bone and enter it to the brain stem and the petroclival lesion. This is anterior petrosectomy. This is the, what you call that, Kawasai's approach. They call it.
That's a safe area with all the cells over there. That's why it's between the structures and it's called the rhomboid area.
Yes, sir.
Yes.
Yeah.
Then the next approach is the transpetrous approach. Now, suppose I have a huge petroclival meningioma. Meningiomas are different pathology, and involving the carotid artery. Now, once it involves the carotid artery, whether it is intradural, extradural, one of the widest exposure and the best control of the carotid is given by infratemporal B with transcochlear approach. So I will show that on the other side now, all these approaches. So the transcochlear is coming through the entire petrous bone, entire temporal bone, staying between the sigmoid sinus behind and the carotid anteriorly. The entire petrous bone has been removed, and this entire huge exposure is given to the brain stem. You can remove any lesion with full control of the carotid artery, whether it is intradural, extradural. This is the biggest of the surgical approach, or biggest of all is the transcochlear approach with its modifications. So to the petroclival region, this is the third approach, and the preferred indications are when the lesion involves the carotid artery, when you need a wide exposure of the brain stem, when the lesion involves the dura in the bone, when you need to drill out the bone, invaded bone, transcochlear is the preferred approach.
Yes, sir.
Then the fourth one is the posterior approach. Posterior is from here. That is behind the mastoid, that is retrosigmoid.
Yes, sir.
Retrosigmoid is from here, behind the sigmoid sinus. But you can imagine for the retrosigmoid, if you go all the way to the petroclival, you have to go through a lot of neurovascular structures.
Very narrow
that is not
approach.
a preferred approach. And for that matter, it doesn't address the lesion going to the foramen magnum. So that is only for the non-vascular cystic kind of a lesion you can address to the retrosigmoid. So the petroclival lesion can be addressed by four approaches: endonasal, anterior petrosectomy,
Yes, sir.
transtemporal, infratemporal fossa B with transcochlear, and the retrosigmoid. So petroclival and the petrous apex same can be addressed by so many lesions. We need to understand the three-dimensional anatomy of the petrous apex and the surrounding structures, carotid artery, brain stem. This is right in the center of the head, where the posterior cranial fossa, middle cranial fossa, your carotid artery, brain stem, and all the important cranial nerves are passing through the petrous apex. So to address the lesion, same like petroclival, petrous apex, sometime we can address to the nose, sometime through the ear. And in the ear, I will show you the infracochlear approach. You can, like for cystic lesions, this is the cochlea. You can stay inferior to the cochlea and you can reach the petrous apex. This is going to be the place of the cochlea, and in the infracochlear is the approach between the cochlea above, the sigmoid sinus below, and the carotid artery anteriorly. And in between these, if you go, you can reach the petrous apex directly. So in some like cholesterol granuloma, cholesteatoma, limited lesion of the petrous apex, you can go by the infracochlear approach, you can go by the endonasal approach. But once it involves the carotid artery, the safest is the infratemporal fossa B. B gives you the full control of the carotid artery. This is what we are going to show on the other side now. So, for the, by and large, the approaches now we are going to show is to the lateral skull base. You know, let me show you this way. This is entire lateral skull base.
Yes,
Your
sir.
approaches can be through the temporal bone, direct, head-on. All the approaches through the temporal bone to the lateral skull base are head-on approaches. You can see. Pass through the temporal bone, but what it involves? It involves the sacrifice of hearing. Okay? Transcochlear requires the posterior transposition of the facial nerve. So it involves some degree of facial paresis. So the decision making is very complex. It depends upon the extension of the tumor. It depends upon the hearing loss. It depends upon the facial palsy. It depends upon the involvement of the carotid artery. It depends upon whether it is involved the middle fossa, whether it is involved the posterior fossa, whether it is involved both the fossa, then you have to combine. If suppose I have a lesion here, suppose trigeminal schwannoma involving middle fossa and posterior fossa, I can go by the transpetrous and the middle fossa approach, addressing both. So according to the situation, you have to take a call. If any lesion here, the patient has already lost the hearing, already has a facial palsy, there cannot be any better approach than transcochlear. Now you have nothing to lose. But it gives you most direct and the best exposure to the entire brain stem, lateral part of the brain stem, anterolateral part, petrous apex, petroclival region, the largest exposure given by the transcochlear approach. Transcochlear means completely, you know, from the sigmoid sinus to the carotid artery, entire temporal bone structures you are sacrificing. So that is indicated when the hearing is already gone and the facial palsy has already happened, and there are a lot of indications for that. So there are approaches passing through the temporal bone are the transtemporal approaches. Those could be translabyrinthine, transcochlear, modified transcochlear, transotic. Then the lesions which are more in the middle fossa, anterior to it. See this temporal bone, the middle fossa is anterior to it here. So then you can go by the preauricular subtemporal approach. That is infratemporal fossa approach, type D approach, or preauricular, or FTOZ. If the lesion involves the, see this is I. If the lesion involves the orbital apex here, we have patients wherein the schwannomas have involving the posterior fossa, middle fossa, and even the orbital apex and the temporal bone, completely huge lesion like this, then you have to combine with the FTOZ. FTOZ involves removal of this entire zygomatic arch with the lateral wall of the orbit. One
Yes, sir.
piece you can reconstruct again, and then you can remove the lesion right from the eye to the middle fossa to the posterior fossa if you combine with the transpetrous approach. So in lateral skull base, one should have the complete array of all the approaches in the basket so that you can direct according to the pathology which demands, according to the extension, according to the lesion, and according to the symptomatology of the patient. For posterior fossa, there are approaches behind the temporal bone, that is retrosigmoid. For the middle fossa, approaches above the temporal bone, middle fossa approach. So transtemporal, anterior, superior, posterior, and inferior. Infratemporal fossa for jugular foramen, we always use infratemporal fossa A approach. You have seen me doing a lot of glomus jugular. That is infratemporal fossa A here. But what it involves, the facial nerve which comes out of here into the lateral to the styloid process here, deep to the tympanomastoid suture. See, this is tympanomastoid suture line. The
Yes,
facial
sir.
nerve is right deep here where my pen is. It comes out of the stylomastoid foramen. My pen is directly into the stylomastoid foramen, and that is, see, 5 to 7 millimeter deep to this tympanomastoid suture line here, lateral to the styloid process, and deep to it is the jugular foramen. So in order to remove the tumors of the jugular foramen, particularly vascular ones, you have to mobilize this facial now. So we do an anterior transposition, mobilize anteriorly, and then you have a full access. And in lesions which cross the different compartments, lesions crossing the different compartments, you can use combined approaches. Transcochlear combined with the infratemporal fossa A is transcochlear B. Combined with the middle fossa, with the lesion is going from the temporal bone to the middle canal fossa. Combined with the middle fossa approach is infratemporal fossa C. If you combine with the, infratemporal fossa B is the transcochlear B. You combine with the infratemporal fossa with the transcochlear D. So many approaches you can all together combine to address various lesions involving the lateral skull base, extending extracranially, involving temporal bone, extending extracranially in the infratemporal fossa, in the parapharyngeal space, in the foramen magnum region, going behind, extending deep intracranially. Everywhere you can choose the combined approaches according to the lesion. Any question before we move on to the other side to show you all the approaches?
Sir, can you show chorda tympani? Dr. Sanjeev Verma wants to know the anatomy of chorda tympani from the superior aspect.
Had you asked, I would have shown you earlier. I will show you on the other side, but let me make a point over here that is important to know. Let me tell you. See, here now we have completely removed the temporal bone.
Yes,
the chorda tympani, after passing through the middle ear anteriorly,
Yes, yes.
after passing through the middle ear anteriorly, it passes through a petrotympanic fissure. In the fissure is a canal, very small canal. I will show you on the other side the entire course of chorda tympani.
Yes,
entire
sir.
course means passing through the canal of his ear. It comes out of the temporal bone, lateral to the eustachian tube. Had you asked me before drilling the eustachian tube, I would have shown. So it passes lateral to the eustachian tube, medial to the TM joint. It comes in the medial wall of the TM joint anteriorly, and then passes through the petrosquamous suture line, comes down to the medial to the spine of sphenoid. I will show the entire course anteriorly,
Yes.
and then join the lingual nerve. I had shown you the lingual nerve.
Yes, sir.
Then it joins, here is the lingual nerve. Then it joins from behind the lingual nerve here. At this point, a centimeter and a half below the skull base. See the lingual nerve here? So it comes out of the ear, and then after going medial to the spine of sphenoid is the point where it goes in the infratemporal fossa and join the lingual nerve over here.
Yes, sir.
This spine of sphenoid anterior to the TM joint, anteromedial to is the important anatomy which I am going to show you, because the nerve which passes medial to is the chorda tympani, and the nerve which passes lateral to it is the auriculotemporal branch of V3. So that's very important. Sometimes in the accidents, road traffic accident, the spine of sphenoid injury is not uncommon, and in that situation, your chorda and if your auriculotemporal both are injured, both are on the either side of the spine of sphenoid, patient will perceive the complete ipsilateral salivary loss. The chorda is going to supply the sublingual and the submandibular glands, and auriculotemporal give fibers, to the tympanic branch to the parotid gland, and the patient will perceive complete salivary loss on one side. How important the structure is, that I am going to show you. So our goal today is to unroof the entire anatomy of the lateral skull base from different perspective. One should be able to see it three-dimensionally. Now, whatever anatomy I'm going to show you on the other side will be altogether different perspective. The carotid you have seen from above, you have seen from different side. Now you'll see from different side on the other side, how it goes, horizontal, vertical, relation to the cochlea, relation to the jugular bulb, and the eustachian tube, and how important it is in the approaches. The reason is, Why it is so important to demonstrate all this? In the past, all these lesions in the lateral skull base were difficult to address because these are so deep seated with so many important critical neurovascular structures. Now, with the advancement in the technology, you can mobilize the facial nerve, you can mobilize the carotid artery, you can even go to the lesions deep to the carotid and the facial, and you can address every possible lesion much more safely and with a much better outcome. So lateral skull base approaches have the advantage that they avoid a brain retraction. More and more bone removal, less and less brain retraction. That is the hallmark of these approaches. So let's move to the
Yeah, they
Sir,
always
there
say
are some
more
questions
bone
regarding
removal.
Mira approach, but when you do demonstration, that will ask, sir.
what?
There are some questions
What, Sandeep?
regarding Mira approach, sir.
Regarding which approach?
Sir, Mira.
So minimally invasive
Mira. Yeah,
approach.
yeah.
Minimal.
That's what I'm
No,
coming to on the opposite side.
yeah,
See,
yeah, sir. That I will ask.
I had shown you the anatomy of the posterior fossa.
Yes, sir.
I
Yes, sir.
showed you the anatomy of the posterior fossa a little bit with the lower cranial nerves.
Yes, sir. Yes.
I had shown you the 5th, 7th, 9th, and 11th. These
Yes,
are
sir.
the nerves which are to be, addressed by the MIRA. MIRA is minimally invasive retrosigmoid approach.
Yes,
So
sir.
it is
Yes.
retrosigmoid approach, but not with a big opening, with a small opening using endoscope. You can reach to those areas. That is what
Yes.
MIRA is. And this is propagated by none other than Professor Magnan
Yes,
Yes,
sir.
from
sir.
France. Professor Magnan has a highest series of, MIRA procedures in the world. And we
Yes,
have
sir.
been fortunate to have him in Jaipur
Yes, sir.
earlier for a workshop in our hospital. He has
Yes, sir.
demonstrated worldwide. He has published series of 3,000 cases. His amazing experience of Mira, and he is
Yes.
propagated in our country through several workshops as well.
Yes,
Yes,
sir.
sir. Yes.
So now we are moving to the other side. In 5 minutes, yeah, change kar lo sab. Change the camera so it will take a couple of minutes to change the orientation of the camera
Satish,
and microscope and all.
Yes,
Meantime,
sir.
we
No
Satish,
will
good
problem.
discuss the
demonstration.
questions.
Good
Yes,
demonstration. I said good demonstration.
hi Narayan, nothing new for you.
I know, but good demonstration. I said.
So also one request to Narayan sir to have his book available on Amazon, like 360-degree skull base book.
Yeah, we will. The 360 degree skull base book will get released in about a couple of months. We will
Okay.
definitely have it on Amazon. We'll make sure that everyone gets a copy.
Yes, sir. Yes, sir. We are
Yes.
eagerly
Thank
waiting
you.
for that.
Yeah. So for people who are wondering what is it, Atlas's 360 degree skull base is going to be a book coming out by Theme. And that's a book which we are talking of all the lateral skull base approaches and all the endoscopic approaches. And we've got chapters on reconstruction, facial nerve reanimations, and so on and so forth. So it's almost, of course, we could write lots more, but it's a nice book on complete skull base, and you can see the anatomy and all the approaches through either the endoscopic or the lateral neurotological procedures, and so on and so forth. So we'll
Yes,
come
sir.
very soon, and of course, we'll make it. I mean, of course, Satish will also announce it, and we'll also announce it.
Ultimate, sir.
Thank you, sir. It will be like a Bible for all the skull base surgeons to follow.
Uh, that was the whole idea that we give some contribute something back to the society.
Yes, sir.
So, Uddhav, I'm also going to take a quick break. I'll
Fine, sir.
rejoin you. Yeah?
Yeah, yeah, sure, sir. Yeah.
Thanks, thanks.
Hello? Hello?
Yes, sir.
Can you hear me?
Yes, sir, we can hear you.
Are you getting the picture?
Yes, sir, we are getting it.
See, on the other side, I'm raising the flap as a whole so that I can show all the approaches in one go. And see, what is this vein? This is all, number of emissary veins connecting the extracranial veins with the intracranial sinuses, These act as a pressure valves, It acts as a, alternative pathway of the venous drainage in case the traditional pathway is blocked. So these emissary are very important. It acts as a pressure valve to release the high pressure. Is the picture okay?
Yes, sir. Okay.
Now, this point, let me tell you one thing. See, this is extraordinary meatus. This is lobule. This is the level of the angle of mandible. Here is the mastoid process. And here, slowly, utha, jara sa utha. Here, on the sternomastoid, we know an important nerve. Crossing the sternomastoid, we know? Udbhav?
Posterior auricular, sir.
Oh, come on, nerve. See this. What is this nerve? Man, greater auricular.
Greater auricular.
See this?
Yes, sir, greater auricular.
See the landmark. This is mastoid process, and it comes from here, from the McKinney's point, to run on the sternomastoid to go towards the root of the pinna, and here in this process it divides into anterior and posterior branches. In parotid, we should preserve the posterior branch.
Yes, sir. Anterior we need to cut.
It can be used as a source of nerve graft.
Yes, sir.
In facial paralysis. That's why I mentioned this. And see the landmark. One more landmark for this. I always mention. Can you see this vein?
Yes.
This runs 1 centimeter above and parallel to this vein. This is posterior division of the retromandibular.
Yes, sir.
This is always constant. Those people who struggle for the finding the greater auricular, look for the vein. It is so simple as 1 centimeter above and parallel to it is the greater auricular nerve. Okay?
Yes, sir.
Anyway, now I am elevating all this. See this greater auricular, it divides into anterior and posterior division here. And the posterior is the one you need to preserve. The anterior is injured in the, incision. Here now I am cutting off. That's it. This is the temporalis. There are a variety of flaps one can make from the temporalis because the vascularity of the temporalis is unique. Unique in the sense, see the lot of bleeding. See the bleeding.
Yes, sir.
Bleeding cadaver.
So how old is this cadaver?
Pardon?
Sir, this cadaver's body is how old?
Day before yesterday's.
Okay.
See this temporalis muscle. You can make number of flaps of the temporalis based on the unique vascularity. See, I am elevating the temporalis only.
Yes, sir.
Leaving the periosteum intact below. This temporalis has a unique vascularity. At the anterior, say 20 to 25% is supplied by the anterior temporal vessels. Branches of maxillary. Middle 40 to 50% 55% is supplied by the posterior deep temporal arteries. And the posterior again 20 to 30% is supplied by the posterior deep temporal and middle temporal vessels. So middle temporal is what? Middle temporal are branches of superficial temporal. Now see, this is your zygomatic process. I want to show you something. This is zygomatic process. Crossing the zygomatic, the middle temporal comes from the superficial temporal, and it gives number of branches running in the periosteum like railway track. Can you see?
Yes, sir.
This is periosteum. If you elevate this periosteum as a flap, it's a very, very useful flap. I use it for many purposes. The thin flap for covering. See this? Can you see this?
Yes, sir.
This is middle temporal artery base flap. Base here. So you can raise if you want for lining, for coverage. Okay? Now I'm sacrificing. Just to show you. Okay?
Yes, sir. You have shown this in live.
Yes, I had shown in the live surgery also. Now, this is the region of the mastoid process. All this musculoperiosteal tissue behind. And this is the extraorbital canal now, which I have transected. See this?
Yes, sir.
So we can show number of approaches here. That's the facial nerve. See this? Facial nerve in the parotid. Can you see?
Yes, sir.
See the facial nerve in the parotid. Coming out of the stylomastoid foramen from here, it is ascending up in the parotid. This is like, you can say, okay. So, out of all these approaches, we will see all these approaches and see the pros and cons in terms of the exposure, in terms of need of combining different approaches. So what approach provides what? What are the advantages, what are the disadvantages, and what are the indications? This is the goal. Okay? Now, first of all, to begin with, I'll not open the dura. Define the limits of retrosigmoid approach. What is retrosigmoid? They're not drill. I will not open the dura, then I will go the pre-sigmoid and then we'll open the dura together. To see the angles of different approaches to access the area inside, the advantages and disadvantages. Okay?
Yes, sir.
So, we had discussed last time, this is the zygomatic route. See this? Following
Yes,
the zygomatic route behind is the asterion. Asterion is what? Asterion is what? Where the three sutures join. Three sutures means occipitomastoid, paritomastoid, and occipitoparietal or the lambdoid suture. This point is called the asterion. That marks the lower limit of the transverse sinus.
Okay.
So here is going to be the lower limit of the transverse sinus. This transverse sinus goes anteriorly and then turns down towards the jugular foramen, that is sigmoid sinus. So in retrosigmoid, we have to make, or the suboccipital approach, we have to make this opening in this area in the angle of these two sinuses. Got my point?
Yes, sir.
So retrosigmoid, as the name applies, is behind the sigmoid sinus. Okay?
Sir, how do we identify these landmarks outside, sir, on the skin?
How do you identify the?
Landmarks outside the skin, sir. Normally they do markings outside the skin.
This zygomatic root is the best
You have to
landmark.
draw a line. Yes, sir. Draw a line and then do marking of the transverse
Yes,
sinus.
that goes on most of the time.
Yes, sir.
Yes.
And then another landmark is the mastoid tick. If you join, you get this. Okay, let me. So my axis, if I go through this space behind the sigmoid sinus, staying below the transverse sinus, is the retrosigmoid or the suboccipital approach. Okay, this is one of the most versatile, posterior fossa approach. One of the most popular approach for the neurosurgeons. One of the most fastest approach. Like translabyrinthine, we always discuss for the acoustic neuromyelitis and all that translabyrinthine. Translabyrinthine is a time-consuming approach,
Yes, sir.
Time-consuming means you have to drill the petrous bone all the way to reach the CP angle with full exposure. That takes hours and hours of drilling. While this approach with the craniotome, you can open this in no time. In less than a minute, they can remove this entire bone. Now this opening depends upon the need. In Mira, you were asking, they make a smaller opening of 1 to 1.5 centimeters. Yeah, if you are doing endoscopic assisted, then you don't need a bigger opening, okay?
Yes, sir.
So here now I am using the traditional instrument, not using the craniotome. Neurosurgeons generally finish it quickly with the craniotome. So this way, if I remove this bone flap, I will be able to expose the posterior fossa dura. And the structure, if I go through this, the first structure I will encounter, my sigmoid sinus is anterior. The first structure which I am going to encounter is the cerebellum. And then I will show you, in order to go anteriorly, suppose, to the CP angle there, you need to retract the cerebellum. Let me open and then we'll show you the pros and cons of different approaches. This will take 5-10 minutes to drill away. Narayan?
So Narayan sir has taken a break for a few minutes. He will be joining.
So you can take question, any comments or any questions you can take.
Yes, sir.
See what I have opened, some air cells.
Yes, sir.
This is very important for those who are doing this approach to seal these air cells before they open the CSF space. Before opening the dura, all these edges with the air cells should be sealed with the bone wax. Otherwise, it may become a source of CSF otorhinuria. The CSF from the posterior fossa through these air cells can communicate to the temporal bone space. And from there, through the Eustachian tube to the rhinorrhea. And this is one of the most frustrating complications. See these air cells.
Yes,
See
sir.
this axonotary canal. These are communicating. This is pneumatized bone. So before opening the dura, these air cells should be sealed. The reason is, once you open the dura, when the CSF lines the bone, your bone wax becomes less sticky. It may not be so sticky as compared to the previous one. You can enlarge the opening according to the need. You can minimize according to the, like in Mira, you don't need this big.
Yes, sir.
I should have used the craniotome to save time, no? So, see how craniotome can save a lot of time. See Dr. Shiva there?
Sir, I think he is not there.
In Tata, they have a neurosurgeon in their team.
So I think you have answered it, but again, Dr. Fazali from Pakistan wants to know, while craniotomy, what should be the parameters to follow and to save the dura?
I couldn't hear his question. What to save the dura?
Sir, what are the precautions to save the dura while doing the craniotomy?
Yeah, you have to be careful to stay in the right plane. When you are using bar, you have to go with the diamond bar close to the dura. Not to exert any pressure over the. Yeah. See now, I've exposed the dura, okay?
Yes, sir.
This is retrosigmoid, okay? I'll not enter now. To give you a complete idea and comparison of different approaches with indications and contraindications. Though we discussed in our, acoustic neuroma webinar in detail, all these.
Yes, sir.
Now, there are many approaches here. Pre-sigmoid, translabyrinthine, pre-sigmoid, retrolabyrinthine, preserving the labyrinth, retrosigmoid, behind the sigmoid, transsigmoid. Another very interesting approach I will show you is the petro-occipital transsigmoid approach. What is that? In certain indications, particularly, I will show you as I go, you can transect the sigmoid sinus and then go. In translabyrinthine approach, the approach proposed by Professor Mario Sana is the enlarged translabyrinthine. You can improve your access by decompressing all around, by decompressing the middle fossa dura, by decompressing the posterior fossa dura, by decompressing the jugular bulb. Cutting देवर को regular बहुत तगड़ी वाली. It's quite pneumatized. Then beside this, all these approaches, the more extensive are the transcochlear ones. What is there? Give me a good cutting tool. See the tympanic membrane and the axonotary canal.
Yes, sir.
So I want to remove this entire chunk of bone to give you the widest exposure. So all approaches, angles can be shown together. That is the aim. पतला करके see the mastoid air cells. That is the middle fossa dura. Can you see?
Yes, sir.
And along with this, we'll show you like pre-sigmoid, transtentorial, retrosigmoid, transtentorial, going across the tentorium, some of the lesions going up. You can divide the tentorium. See, this is the posterior canal wall.
Yes, sir.
That is the, see below is the lateral semicircular canal. Some more drilling. Yeah, now quickly we'll be through.
दिनेश जी प्लीज पुट ऑन फुल स्क्रीन नो सर का पूरा गैलरी व्यू आ रहा है.
What, Sandeep?
सर वो आपका सारे इमेजेस आ रहे हैं सर, आपका फुल इमेज नहीं आ रहा. We are not able to see you completely on the screen, so I am requesting them to put it back.
निबलर देगा. By exposing the entire area once, see the level of the sigmoid sinus?
Yes, sir.
That's the tip area.
That's the mastoid process. Along with the muscles. You have seen in the on the other side about the anatomy of all these muscles.
Yes, sir. The sternocleidomastoid mastoid below this longitudinal capital we have seen every. Yeah.
Sir, emissary vein has come.
Pardon?
Emissary vein, emissary vein.
Emissary vein is yes, it is always behind this. Probably I had shown in the beginning, if you remember.
Yes, sir.
Yes,
In
sir.
the
Yes.
beginning you showed.
Yeah, yeah. No, I'm just asking you.
This remaining drilling, and then we'll go to the discussion. This is sigmoid sinus. That is the posterior canal wall, lateral canal. Now, this is the sigmoid sinus going. All this bone, if you remove anteriorly, watch. Let me show you. What is pre-sigmoid? What is pre-sigmoid translabyrinthine? What is retrosigmoid? What is transsigmoid? So pre-sigmoid retrolabyrinthine is what? You stay anterior to the sigmoid sinus, but behind the labyrinth. Through the Trotman's triangle. What is Trotman's triangle? Let me show you. It is the space between the labyrinth and the venous channels. Don't be mistaken about the definition of Trotman's triangle. It is not a true triangle. See again what I'm saying. It is a space between the labyrinth and the venous spaces. What are the venous spaces? See, this is the sigmoid sinus.
Yes, sir.
Here, it joins the superior petrosal sinus medially. Got my point?
Yes, sir.
Medially.
Yes, sir. Yes, sir.
Superior petrosal sinus. See this is superior petrosal sinus. So the Trotman's triangle, anterior limit is the labyrinth. Posterior limit is the sigmoid sinus. Superior limit is the superior petrosal sinus and inferior limit is the jugular bulb.
Yes.
So it is a space, again, a space between the labyrinth and the venous channels. All around. This is pre-sigmoid dura. Okay?
Yes, sir.
Yes, sir.
So many people confuse superior pedagogical sinus with the Tegman plate. Plate.
Yeah, so don't get confused about the Trotman's triangle. Below is the jugular bulb.
Yes, sir.
So this is pre-sigmoid dura with the rent here. This is the sigmoid sinus, and this is going to be the level of the jugular bulb. And this is some more bone to be removed. This entire bone will go up to the labyrinth, this bone. This space will be Trotman's triangle. This is superior petrosal sinus. See here. I
Yes,
can
sir.
cut this at further tentorium and we can go above later. Oh, then go thoda ye cut. So now after this, I remove this bone. We'll see the exposure from posterior and anterior approaches and the difference. Come here.
Yeah.
Drill. We have to cover a lot of things. So I am doing this entire job with a cutting bar. In live surgery, as you go close to the critical areas, you have to use the diamond. So if you don't remove the labyrinth in the pre-labyrinthine compartment, pre-sigmoid compartment, you don't have adequate access to do a lot of work inside. You know, though
Yes, sir.
this is a well nematized bone, but it can be used pre-labyrinthine, not translabyrinthine. Pre-sigmoid, retrolabyrinthine is a hearing preservation approach. Find all. Yes. If you don't remove the labyrinth like translabyrinthine, it remains a hearing preservation approach. And it can be used for certain procedures like vestibular neurectomies, microvascular decompressions, where you don't have to ablate the labyrinth, preserve the hearing, and you can certainly use this approach if you have a good exposure. Oh, they're not carry some. 0 degree line. मोटा वाला देना. See, my anterior limit is the labyrinth. My superior limit is superior petrosal sinus. Inferior limit is jugular bulb. See the jugular bulb. This is middle fossa dura. You have seen once we saw from above the thin bone which I have removed. That is the tegmen, and that is the now we have two exposure. If I go inside with this exposure knife, where I need to cut, this is Trotman's triangle.
Yes, sir.
See, my limit is the superior petrosal sinus. Anteriorly is the labyrinth. I can drill a little bit more bone. Posteriorly the sigmoid sinus. Knife. Scissors.
Inferiorly jugular bulb.
Yeah, magnify. Yeah. See,
Yes,
that
sir.
is my superior limit. Okay.
Wonderful, sir. Brain stem we can see.
Yeah, that is cerebellum.
Yes.
Anterior, I could have removed a little bit more. I have not drilled the labyrinth. This is not translabyrinthine approach.
Yes, sir.
This is
It's a sigmoid.
pre-sigmoid retrolabyrinthine.
Yes, sir. Basically. So this is
And
actually what we see in Mira, no, sir. When you open in Mira, this is what we see.
No,
Mira is
retrosigmoid.
retrosigmoid. Now see, the advantage of this is you can do microvascular decompression using the endoscope through
Yes,
this.
sir. That's what.
In live surgical situation, what you can do, you can, in this, see the cerebellum is not coming in the way.
Yes, sir.
But if I go from here, it is right cerebellum. I will show you. In that situation, you can relax the brain by draining the CSF. See the arachnoid. So this is the anterior one. Now what you see there is the 7th, 8th nerve.
Complex, yes, sir.
Can you see?
Wonderfully,
The
sir.
cranial nerves?
Yes, sir.
That was the 5th one, and this is Odek. 7th, 8th.
Yes, sir.
Oh, this is 7th, 8th complex.
Complex.
This is 7th, 8th complex. Can you see?
Yes, sir.
Going into the intraventricular.
Sir, can you
This
show
is the
the?
vessel.
Yes.
That is the ICA loop, this one.
Yes, sir. That's the
This is vestibulocochlear. Can you see?
Yes,
Yes,
yes.
There is a depression. Can you see the distinct color between the upper and lower part?
Yes, sir.
Yes,
This is
sir.
where we decompress. Yes, sir.
The upper one
Or
is
dissection.
what? See this upper one.
Yes, sir.
Upper and lower part, sometimes there is a vessel.
Yes, sir.
And this is how the vestibular neurectomy is performed here.
Yes, sir. Cochlear part and vestibular part.
बस आ जाओ. See? And this is the 5th cranial nerve. That is the 5th one. Now, बिल्कुल पतला देना. Now, this is the 8th cranial nerve. There is a rotation of the nerve almost 90 degrees as they ascend. Surprisingly, this lower part is more. Can you see this lower part?
Yes,
More
sir.
brighter. Can you see more brighter?
Yes.
Yes, sir.
There's a sulcus. This upper one is the vestibular and this is the cochlear nerve.
Yes, sir.
Can you see distinct?
Wonderfully.
In vestibular neurectomy, this vestibular nerve is sectioned. Now see if I retract anteriorly, what is that?
Facial.
Facial nerve, and I can see the distinct bundle of nervous intermediates joining
Yes.
the facial nerve.
Yes.
Okay, this is the exposure after this part. The labyrinth is intact. See, this labyrinth is intact.
Yes, sir.
Now, for lesions where you need to address the pathology is in the intra-auditory meatus. Okay?
Yes, sir.
This is the root entry joint here, and this is the nerve ascending to the intra-auditory meatus porus. This is porus.
Yes, yes.
So, to
Yes, sir.
address the intra-auditory meatus, you need to drill the labyrinth. See this? That is what translabyrinthine approach is. But that is feasible only when the hearing is already gone.
Yes.
When hearing is preserved, you can't do that as a preferred approach. Now behind that is the see, this is sigmoid sinus, behind is the retrosigmoid. Can you see
Yes.
this?
Yes, yes, yes.
If we open this dura, right below is the cerebellum.
Yes.
Then the trajectory will be more from behind like this. Can you see like this?
Yes.
It will be more from behind. That is retrosigmoid approach. Boss,
Yes,
can
sir.
you open the dura and show 0 degree? Let me ask Pankaj boss to open the retrosigmoid dura, and for the audience, show some inside anatomy with the endoscope. Open the dura. Scissors, sir.
Sir, then don't we
Sir, by what device that vestibular nerve is resected, sir? Can we resect by bipolar?
No, scissors, come on.
No, there is a probe kind of thing they were using, sir. Like
No, scissors, pure scissors,
only
without
scissors.
giving any traction.
Okay.
See, the indications of vestibular nerectomy are very less, very well defined.
Sir.
In the situation of acute intractable vertigo,
Yes, sir.
when the hearing is preserved, not coming under control by any other means, when the hearing is preserved, the best, curative procedure, पहले खोलो उसकी ड्यूरा, पोस्ट से रेट्रोसिग्मोइड ड्यूरा खोलो, और इधर लगा दे कैमरा इधर लगा इस पे पहले.
And then, sir, because we don't have to retract cerebellum in pre-sigmoid approach, it's a better approach than the retro-sigmoid approach.
Pardon, can you repeat?
Sir, in pre-sigmoid approach, we don't have to retract the cerebellum a lot.
Not really, because that is anterior to the cerebellum, practically.
So
That's why now Pankaj was is opening from behind the sigmoid. And the structure you will see once he opens is the sigmoid sinus. So in that situation, what generally we do in the clinical setting, we drain the CSF, go inferiorly below the spinal accessory. You saw in the last, on the other side is spinal accessory now.
Yes, sir.
Go inferior to the spinal accessory and open the cisterna magna and drain the CSF to relax the brain.
Yes.
So that you don't need to retract. See the movement he opens the retrosigmoid dura. What is there in front? Cerebellum. So the opponents of this approach say there is a lot of cerebellar retraction is required, though you can minimize by draining the CSF, but still it is required in certain patients when the CSF pressure is high, intracranial pressure is high, then it is really difficult. Now see, the pre-sigmoid can be combined by, if I drill the labyrinth, it will be pre-sigmoid translabyrinthine approach, okay?
Yes.
Without drilling the labyrinth, it's pre-sigmoid retrolabyrinthine.
Yes.
So, if you don't go to the pre-sigmoid region going from behind, the same region you can see, he will show you, now he's showing you from behind, retrosigmoid. The advantage of the retrosigmoid is you don't have to drill all the temporal bone.
Okay.
You just go behind the sigmoid, do a cranectomy in 5 minutes and you can reach the area in no time. Now see, he's tilt kar lo. To reach that area, what he's doing, he's tilting and then he is going to retract a little bit of the cerebellum. See that 7th, 8th complex?
Yes, sir. Wonderfully seen.
The inhibiting factor is the anterior limit, that is sigmoid sinus. Okay?
Yes.
In the live surgery, you can, further decompress the sigmoid by drilling the pre-sigmoid cells. You can further decompress the sigmoid.
So we can see the 9, 10th, 11th nerve also.
No. This is 5th now, and see, at the tentorial margin, what is showing is the 4th nerve.
Fourth nerve, yes.
I showed you from above, along the margin of the tentorium, is the trochlear nerve passing. Then below is the 5th nerve. Can you see?
Yes, sir. Yes.
Largest one, largest five.
Mic हो रहा है क्या?
And the medial to the 5th nerve, you
See all the structures.
Now, can you see this is 4th now along the tentorium?
Yes, sir.
Can you see it?
Yes, sir.
And this is the superior cerebellar artery.
Sir.
Okay, and this is 5th now.
Yes, sir.
See, this superior cerebellar artery is an important anatomy.
While you are operating on the trigeminal neuralgia.
This is one of the commonest region for the trigeminal neuralgia, where this vessel compresses the nerve root entry zone.
And the patient typically presents with the V2 or V3 neuralgia, because according to the topographic distribution, the V3 fibers are the superior and the V1 fibers are the inferior one. So if the V3 is there, if the patient presents with the V3 or V2 neuralgia, we should always search for this superior cerebellar vessel. Some vessels which is compressing over the superior aspect of the trigeminal nerve. Okay?
Yes, sir.
And about the inferior aspect, the majority of the time the offending vessel is the anterior inferior cerebellar artery, which I am going to show you now. So this is the seventh eighth nerve,
Yes, sir.
and here should be the ICA loop. Can you see this?
Yes, sir.
This vessel.
Yes, sir. We can see.
By this.
Now see, you have seen the fifth one.
Yes,
Orient
sir.
from there. Orient from there.
What
This
else?
anterior obstacle is the sigmoid sinus. See that?
See, this is the sixth now.
Yes, yes.
Yeah. See far anteriorly, that is sixth cranial now.
Okay.
See far the whiter one.
And here you can see the opposite side.
Yes. See the opposite side from here.
Where we have operated. And this
See
is
the
the
opposite which we have opened up, you can see from here.
and this is the basilar artery.
Okay.
Below
Okay.
this, below the origin of the sixth nerve is the vertebral artery. And at the level of the sixth nerve, both the vertebral artery combine together and form the basilar artery here.
It is vertebro-basilar junction.
Yeah.
See the basilar artery, the sixth now, seventh, eighth you have seen, fifth you have seen, fourth you have seen, and now directing inferiorly towards the lower cranial nerve.
Hmm.
Can you see the lower cranial nerve now?
Sir, not completely. We have.
Now?
Yes, sir. Now little better.
Yes.
Yes, sir. Now yeah.
Now, can you see
Yes.
this?
Yes. Now we can
Yes.
see.
No. There is a low.
Ninth is separate superior. What can you show this?
Yes.
This is ninth.
Yes, sir.
There is a ninth, there is a 10th,
The multiple rootlets of 10th.
and the 11th and the spinal accessory
And
nerve.
the spinal. The cranial part of the 11th and the spinal part of the 11th.
And this must be the 12th now.
The pica can we see here?
Pardon?
The pica.
Pica, yeah, in relation to these, the vessel is the pica. And see, through these fibers, crossing the vertebral are anteriorly are the hypoglossal. Deep. Pure hypoglossal.
This is,
वो नीचे.
here,
Yeah,
this-
these are hypoglossal rootlets.
Okay.
See, now, once we go to the infratemporal, we'll see how these nerves enter the jugular foramen and then go extracranial from there. So, with this retrosigmoid approach, you have a good exposure of the suboccipital region. You can see all from 4 to the 12 cranial nerves. You can do all kind of microvascular decompression, neurectomies also.
and this is the choroid plexus.
And see, that's the important area. What is now showing is, see, go to the 7th, 8th now. Can you show us 7th, 8th now?
Yeah. I'm following
Go
that.
to the root entry zone of the 8th now. Retract the cerebellum, retract the flocculus, and you will find the choroid plexus.
This is the choroid plexus. What the now?
And that is the lateral recess of the fourth ventricle, into which the cochlear nuclei are there. The ventral and the dorsal cochlear nuclei,
थोड़ा छोड़ा दो.
which need to be stimulated when the auditory
नहीं,
brainstem implant is done.
छोड़ा वाला spatula
So
देना.
in ABI, this is the approach.
नहीं, इससे छोड़ा.
This is the area we need to go at the root entry zone of the 8th nerve, where the ventral and the dorsal nuclei. It is the ventral nucleus which is more important. More connections.
Sir, the tongue depressor
This is the choroid plexus.
That is the choroid plexus. Can you see?
Yes, sir.
Now with the endoscope we can show it better.
Yeah, now you show with the endoscope. You see the lateral recess of. This is what
हाँ? ना जरूरत नहीं endoscope जाएगा.
lateral recess. to stimulate the ventral and the dorsal cochlear nuclei. That's a plate, it's not an electrode. So you just push your plate inside the lateral recess and fix with the fibrin glue. Now the same anatomy. Can you see with endoscope? Hello?
Yes, sir. Beautiful picture. Wonderful picture.
Yeah, this is 7th 8th now complex.
See, going into the porus.
Okay.
That is the porus of the intra-aortic meatus laterally. Can you see?
Yes, sir.
This is the 4th now.
This is the fourth cranial nerve.
Yes.
Can you see it?
Yes, sir. We
This
can
is
see.
the superior cerebellar artery.
Separate karo. This is the superior cerebellar artery.
So Dandy's vein.
Yes, Dandy's or the superior petrosal vein is also there.
Yes, sir.
See, this is the trochlear nerve. Very
Yes, sir.
clear.
Going inside the.
See,
to
going in the
enter
tentorium.
Tentorium.
Yes, sir.
So when you need to cut the tentorium, always start from behind, looking at the nerve so that you don't damage the nerve.
From here only. After coagulation of the tentorium.
This is tentorium. अभी बाद में पहले वो दिखा.
ये रहा. चलो बात में.
So that is so for all
This-
vascular compression syndromes.
There is the 6th now.
6 now entering into the Dorellos canal. Can you see?
Yes, sir. Wonderfully seen. Beautiful.
That is, so it's not a true canal. It's a basically venous plexus, lake of, where see the opposite 6th. Go
Yes.
across.
Yes, sir. Yes, sir.
Can you see the opposite one?
Yes, yes.
And see the opposite
This is-
superiorly.
This is the basilar
That's a
artery.
basilar artery. So many of the lesions which involve the temporal bone and the posterior cranial fossa, temporal bone and the middle cranial fossa, you need to combine these approaches. That's why these are important to understand anatomy.
Lower cranial nerve.
Now, for the fifth nerve, if there is a microvascular compression, you need to separate these vessels from the nerve and use something to interpose, like Teflon, muscle patch, or anything.
This-
Muscle patch nowadays is considered to be better.
And this is the root entry zone over here.
That's the root entry zone.
This is the point of the interest where the offending vessel must be lying.
Yes. Is that the Dandy's vein behind? Behind?
I think collapsed.
Okay. Now, this is the seventh.
Bagi, this is the site for Dandy's vein. I think this is the Dandy's vein.
Okay, collapse.
Yes, sir.
Now, no, seventh, eighth. Now look at the seventh, eighth. See the porus. Now with the retrosigmoid approach, if the lesion is going, suppose we are operating for a vestibular schwannoma, and lesion is going in the intra-aortic meatus. For intra-aortic meatus, we know the best approach is the translap, but it involves sacrificing the hearing. If the patient is a good hearing and the tumor going in the intra-aortic meatus, then there are two options, either to go by middle fossa approach for the intra-aortic part, but then you can't remove the posterior fossa component. But if you are doing with a retrosigmoid, see what he's doing. He's removing this periosteum, this dura.
Dura over the
Porus.
posterior to the posterior lip of the
The
internal.
posterior lip of the porus, so that you can drill the posterior lip. Microphone में करो.
हाँ नहीं इससे भी कर सकते हैं.
So what he's doing, you open up this dura, elevate the dura,
Cutting बात
and
कर रहे
remove the posterior lip of the intra-aortic meatus and go laterally to remove the tumor. So what can happen? You can remove, using the endoscope, angled endoscope, you can pluck out the tumor from inside the intra-aortic meatus. But this is indirect to certain extent, because if the lesion is extending far laterally up to the fundus, then you cannot remove completely with this. If you try to, you can end up damaging the, either the vestibular aqueduct or the crus commune going laterally. So by this drilling, generally if you drill by 5 millimeter, you are safe. Up to 5 millimeter drilling is safe. And then after that, after 5 to 6 millimeter, you can go laterally and endanger the inner ear structures. The most medial one being the crus commune. Medial to that is the vestibular aqueduct, endolymphatic sac. So that is something not warranted. So for lesions completely compressing into the intra-auditory canal, generally translab is the approach of choice, and those are the patients which actually have not useful hearing, which Puritan audiogram may show. Suction Bandkar. Puritan audiogram may show some hearing, but that is not actually a useful hearing. If the real picture of the hearing, useful hearing, is shown by the speech discrimination score. Otherwise, if you try to preserve that hearing, that can be troublesome to the patient, giving, wrong input to the brain, and that is more troublesome rather than sacrificing the hearing. So this way, you can remove the posterior lip of the canal and enter into the intra-auditory meatus, Sometimes what surgeons do, if the hearing is preserved, they are not able to remove it completely from here by the retrosigmoid from the canal. At least they slit the dura of the canal from behind and decompress it to prevent the pressure on the nerve for the future preservation of the hearing. See the part of the canal as is going laterally. So using an endoscope, many a time you can plug the tumor, but tumors extending to the fundus, practically one cannot remove.
No.
If you try to, you can end up losing the hearing.
This is the advantage of endoscope.
Yes.
You can see inside. We need not to do the complete drilling of the.
Yes. Only the posterior part of the lip of the porus is drilled, and you can enter into the canal.
This view cannot be achieved by just microscope.
Yes. You need endoscope. So this is about the 7th, 8th now, and below now is the 9th, 10th, 11th.
Yes,
See this 9th as a separate dural, envelope as it goes inside. 10th separate. See 9th where it enters into the jugular foramen. Just above the 9th. See below the intra-auditory meatus, and just above the 9th, if you drill this, you'll find the cochlear aqueduct.
Yes, sir.
Just superolateral to where the glossopharyngeal enters the jugular fossa.
Yes, sir. So Dr. Palaniappan wants to see the cystagna magna.
That is below. He will show you below. So this is 9th. Yeah, that's a separate dural envelope. As a separate, see the separate entry into the jugular fossa.
Yes, sir.
10th filaments, multiple have separate entry. And the 11th, and below the 11th, if you try to, this is vertebral artery behind, and see the 12th.
12th.
See the multiple rootlets of the 12th? And that is passing into the occipital condyle. So where are we seeing? This is pica. Yeah, see? Now see the bone lateral to where we are is the huge one, that is occipital condyle. This is the entire occipital condyle, through which the hypoglossal is passing, making entry into a canal. Now, if he tries to separate the arachnoid below the 11th, see now, to open up the cisterna magna. Or karo. See, these are the arachnoids, which is opening to drain the CSF through the cisterna magna.
Beautiful.
वो दे दे सिंपल फ्रंट रूटिंग
scissors they good. Use some scissors. Yeah. And see, this is cisterna magna,
This is pica caudal loop.
caudal loop of the pica.
Tonsillar
Yes,
loop.
yes.
And this is the cisterna magna.
That is cisterna magna, where the CSF is drained from.
Beautiful, sir. Ultimate.
We can do endoscopic assisted. We can perform endoscopic assisted. We can do endoscopic assisted by the small craniotomy.
So that is what MIRA is. Make a small opening, retrosigmoid opening, use the endoscope and explore the entire area and do a lot of procedures.
Holding endoscope with one hand and operating from the other hand.
But endoscope gives you a panoramic view. That's the cerebellar tonsil.
And I'm going to show the.
This cerebellar tonsil is one which is responsible for the coning in raised intracranial hypertension. That goes inside the foramen magnum.
The area where opposite side.
That's the opposite side.
And this is the ipsilateral tonsil. And here should be the. If you retract more.
So you can see the entire posterior cranial fossa, panoramic view with the MIRA, minimally invasive retrosigmoid approach using the endoscope. So you can do many decompression, treatments like decompression of the fifth nerve, decompression of the seventh nerve for the facial nerve spasm, hemifacial spasm, decompression of the ninth nerve for the glossopharyngeal neuralgia, and if it is required, then you remove the upper fibers of the vagus also for the complete decompression. Then hypoglossal decompression, everything can be done through this. So this is MIRA, and the difference from the retrosigmoid and the pre-sigmoid is with the translabyrinthine. Suppose now you add on and remove the labyrinth together. That gives a direct access to the intra-aortic canal and the CP angle. What is this? Hold my please. Give me other glove. So, let me.
Sir, what is the lateral limit or cutoff limit of the IAC drilling?
Yeah. So the question is lateral limit of cutoff of the ISC drilling here. It should not be more than 5 millimeter, otherwise you never know when you enter into the inner ear structures. So in case of trigeminal neuralgia, you have to place something interposed here in between. Lot of people do sling technique. Take a suture of the vessel towards the tentorium and make a sling so that it doesn't fall back. What you do anytime sling? You do sling? Sling onto the vessel to keep it away. Then this is fifth. Then the seventh decompression. For seventh, you really need to separate. Mostly it is the ICA which is responsible. And these are the lower cranial nerve. I hope this is all about the retrosigmoid approach, the access, all the vessels, and now the limitations. If you have to address the lesion in the jugular foramen, see, jugular foramen is far anterior and inferior. You can't address by the retrosigmoid approach. See, Yeah. Yeah, schwannoma, epidermoid, you can. Lower cranial nerves. Yes. Yes. So, no, the issue is these nerves are going into the jugular foramen, which I am going to show you from anterior. From here, we will show you the jugular foramen. From here, once we remove this labyrinth, I will show you. First, we'll remove the labyrinth and then. So, the schwannomas or the lesions arising from the jugular foramen, these nerves are leading into the jugular foramen. You don't have adequate access through this sole approach. For jugular foramen, you need to go by infratemporal fossa approach, which I'm going to show you after this. But certain lesions like lower cranial nerve schwannomas arising from these nerves, like acoustic nerve schwannoma, can be addressed by this. Epidermoid is cholestatoma. Cholestatoma inside the cavity, anywhere can be very well addressed. This approach is so fast, so versatile. So generally, for CP angle, any other tumor than acoustic, this is the approach of choice. For acoustic, for us, if the hearing is already gone, our translab is the choice because it gives you direct access and ability to clear the intra-auditory meatus completely. Only thing is, you need to drill away this entire chunk of labyrinthine bone. This is your editus, this is your lateral canal, your posterior canal, your superior canal. If you remove this chunk of bone, and then you can reach the intra-auditory meatus directly from laterally. You can preserve, find the facial nerve laterally and preserve it all the way. That is the biggest advantage. So, there are advantages and disadvantages for the various approach, and one should be able to choose all the approaches rather than pushing in a single approach for everything. Yeah. So now let us go back to the microscope.
If you want to operate for the lower cranial nerve schwannoma, you can extend your cranial towards the foramen.
Yes.
You need not to move your cranial
The issue is how to address the jugular bulb. Now, the approach which I am going to show you is an excellent approach wherein you can address the jugular bulb lesions yet preserving the facial nerve and hearing. I have not drilled the labyrinth yet. I am not drilling it now. We have opened from behind. Now I am going to tell you how to go into the jugular foramen without, drilling the labyrinth. क्या प्रॉब्लम है?
माइक्रोस्कोप सेट कर दो आँख के नीचे पहले आपका माइक्रोस्कोप सेट कर लो.
Now coming back with the microscope. Hello?
Yes, sir.
I hope it was clear.
Very clear.
Now, coming back with the microscope, our labyrinth is intact. If the hearing is good, you have a lesion in the posterior fossa, lesion in the middle fossa, lesion is going above the tentorium, you can cut the tentorium. You can go by the middle fossa approach, above in the middle fossa, yet preserving the hearing. See this? I am cutting off this dura to show you that. You know, अभी कटूंगा थोड़ी देर बाद. Now, see now, this is the tentorium. And if I go above now, what you can see now? You have seen up to the fourth cranial now, and going through the tentorium now, you can go above and see even the third cranial now, even the second cranial now, even the carotid artery. All these can be seen through here. This is, see this? This is transtentorial retrosigmoid approach. You are much above, and see this opposite side. This is transtentorial. You can really go above the brainstem, the upper part, and see that. Now, coming to the jugular foramen. So, for example, you have a lesion in the posterior canal fossa, you have a lesion in the going above the tentorium, you can address to here, you have a lesion going into the middle fossa, you can combine this, you can do a middle fossa craniotomy here and combine this retrosigmoid with the middle fossa. If you have a lesion where the hearing is gone and the lesion in the temporal bone, you can drill the petrous bone, the labyrinth, and it is extending above, you can join it, combine it with the middle fossa, transpetrous middle fossa approach. So now still the labyrinth is intact, and suppose we have a lesion in the jugular foramen. Hearing is preserved, non-vascular lesion, how we can reach the level of the jugular without sacrificing the hearing and without transposing the facial now. That is what I'm going to show you. So give me some gauge pieces so that I have to drill a lot. You know. And that approach is a unique one, petro-occipital transsigmoid approach. Therein, what we do, we take a suture and divide the sigmoid sinus. I'm pushing some something to prevent the bone dust. What you need to do is, you have to go infralabyrinthine.
So Narayan sir is back online.
Pardon? Pardon?
Narayan sir is back.
Narayan. See this, what I am doing. My labyrinth is here. What I am looking at the course of the facial now. Okay? And go retrofacial. That's the vertical facial. Can you see? See this. Can you see the vertical course of the facial here?
Yes, sir.
Now, all this bone below, I am removing. That is the retrofacial region. Retrofacial region, my superior limit of this bone removal, staying inferior to the facial now, is going to be this posterior semicircular canal. So that I don't end up damaging the labyrinth. My inferior limit is going to be the jugular bulb. What I am showing is the petro-occipital along with this combination. Petro-occipital transsigmoid approach, by means of which one can reach the jugular foramen without transposing the facial nerve and without sacrificing the hearing. This is my posterior canal. This is my superior limit, posterior semicircular canal. This is laterally the facial nerve. And see, this is the axis. What an axis. This is infralabyrinthine. Anterior limit is going to be the carotid artery. Anterior superiorly will be the cochlea. This is a huge axis. Once you do this, You have to ligate the sigmoid sinus here. Here I will ligate this, and you have to ligate the internal jugular in the neck. And then you
Satish,
can.
you're showing the POTS approach.
Pardon?
You're showing the POTS approach, is it?
Narayan.
Yeah.
See, I have shown the. I don't think you were there. I've already shown the retrosigmoid, Narayan.
Yeah. No, now you're showing the POTS.
See this.
Yeah. Okay.
This is retrosigmoid. I have shown pre-sigmoid, retrolabyrinthine. Okay.
Okay.
Now, keeping the facial nerve intact, keeping the labyrinth intact, I am showing how to reach the jugular foramen.
Okay. All right.
Okay.
Yeah.
So what I am doing to enter into the jugular foramen here, what ultimately you need to do is ligate the jugular vein in the neck and the sigmoid sinus behind, and you can actually address the entire sigmoid sinus easily.
So have you discussed the indications for this approach?
Pardon?
Have you discussed the indications for this approach? Which tumors you would remove?
Yeah, for this, I will remove the lower cranial nerve schwannomas extending into the jugular foramen and posterior fossa.
Yeah.
Together. Hello?
Yes.
My commonest indication is the jugular foramen tumors involving the posterior fossa and the jugular foramen together.
So
non-vascular tumor, number one. See this. This is how you can ligate the jugular bulb. You can ligate the jugular bulb and see where I am extending to.
Yeah. So you use this for jugular foramen schwannomas, right?
Yes.
So what about jugular foramen meningiomas? What is your approach for jugular foramen meningiomas?
Meningiomas also you can address, but not the glomus tumor, not the paragangliomas. For paragangliomas, this approach can be used as a second stage for intracranial lesions.
Yes.
Now see, all these cranial nerves, lower cranial nerves are ascending here. This is your sigmoid sinus. See this? See the cranial nerves, Narayan?
Yes, you can see everything.
Medial wall of the jugular bulb here. All these cranial nerves ascending, coming here and take a right 90-degree angle turn to enter into the neck. Okay? Let me drill it little bit more.
It's critical to mention here that all the nerves go below the medial wall of the jugular bulb or deeper to the medial wall of the jugular bulb.
Yes.
That's the most important thing to avoid cranial nerve weaknesses.
Absolutely, Narayan. Now, see what bone I am drilling, this bone. This is a jugular process of occipital bone. Now see the interior of the jugular foramen, what I am trying to show you. See the interior of the jugular foramen, and there are lots of openings. Lots of openings which I am going to show you. Let me open it. Can you see multiple openings?
Yes, you can.
So just, I will cut this dura and show some good anatomy over here in the medial wall of the jugular bulb. This is important to understand the approaches and lesions of the jugular foramen. Now, see the medial wall dura is intact. Only blood. Let me remove a little bit of the bone more. This is just to show you anatomy. No. Yeah. See the medial wall of the jugular bulb. I hope the picture is clear.
Yes, sir.
Now, these cranial nerves, see this cranial nerve ascending here. They are entering the medial wall of the jugular bulb here, tightly adherent to the dural envelopes. Scissors. Good enough. Iris. See what is that entry anteriorly? What is that opening in the medial wall? There are multiple openings. These are the openings of the inferior petrosal sinus. There are variables. Generally, the inferior petrosal sinus openings are between the 9th and the 10th, 11th cranial nerves, where they pass in the medial wall. See this inferior petrosal wall sinus opening. Can you see?
Yes, sir.
Yes, we can.
And
Satish, can I make a point?
yes, please see the inferior petrosal sinus openings.
So the thing is that in schwannomas, almost like a rule, we open up the capsule, debulk the tumor, and then take off the capsule. But in paraganglioma, Satish already told you that we cannot use this approach, and that's because we do not have adequate control of the carotid in this approach. So paragangiomas definitely are not done by this approach. It's very rare, but it's a good approach for schwannomas. And again, meningiomas, if they are within that area, sometimes meningiomas extend far more anteriorly, and then you would want to choose a different approach for that.
Yeah. See, little bit of bone, removing the dome side to show you the nerves relationship better. Iris. See relationship of all these nerves. How they enter in the medial wall. Not touching, man. The nerve is injured, man. See now, the 9th nerve has gone up. See this 9th one? And 10th, 11th here. And see this huge opening with multiple openings. Can you see this? This is where the inferior petrosal sinus opens in the medial wall. Is that clear?
Yes, sir.
This 10th and 11th, they generally go together. Generally, they go in a single dural envelope. And here the cranial accessory joins the vagus nerve. See how tethered is the dural envelope to the medial wall of the bulb, to these nerves. See this? 10th and 11th are here, and 9th there, 9th is there, and in between is the inferior petrosal sinus. Okay? Now, posteriorly, there are another opening in the jugular bulb. This opening here, posterior-medially, here the opening leads to the posterior condylar vein. Posterior condylar vein from here drain into the vertebral venous plexus, and that those are variable, it is not a fixed anatomy. So posterior condylar veins, from here they drain into the vertebral venous plexus, and that is the important pathway of drainage. When the internal jugular vein is ligated in the neck, there is hardly any pressure change in the brain because the condylar vein and the vertebral venous pathway, plexus pathway is intact to drain the cerebral venous system. But if the jugular bulb is occluded with occlusion of the condylar vein, with occlusion of the emissary vein, it may lead to rise in venous pressure. And if the bilaterally done, that can be disaster. Bilateral ligation of the internal jugular vein may not create that much of a problem because of the integrity of the vertical venous system through the condylar veins. But bilateral ligation of the sigmoid sinus can be troublesome. Now see here. This is 10th, 11th, this is 9th. And now what is this? This below. There's the 12th cranial nerve medial to the jugular bulb coming. Can you see this?
Yes, sir. Yes.
Where it is coming from? See this? See this? The 12 cranial nerve roots are here. Here are the 12 cranial roots. See here.
Yes. Yes, sir.
They
Yes.
are passing through a canal in the occipital condyle here.
Hypoglossal canal.
This condyle, I will find the hypoglossal canal. And this is coming out of the hypoglossal canal differently medial to the jugular bulb. See, this is jugular bulb. Hypoglossal canal is medial to the jugular bulb. 9th, 10th and 11th cranial nerve pass through the medial wall of the jugular bulb, and the 12th cranial nerve passes medial to the jugular bulb through the occipital condyle. This is entire occipital condyle, this one.
Sir, which is more medial?
Vertebral artery medial to the condyle. You saw the far lateral approach. This is the mastoid. The far lateral, the vertebral artery is more than 1 centimeter deep and below. And here it passes through deep to the condyle to come here inside the cranial cavity. So this is the structure in between. This is the structure in between.
So which is more medial? Hypoglossal nerve or 9, 10th, 11th bundle?
See, let me show you again. 9th, 10th, 11th is here. See this?
Yes, sir.
This one is here.
Okay.
This is the venous compartment of the jugular foramen, and this is the neural compartment of the jugular foramen. Okay?
Yes, sir. Yes.
This is the hypoglossal, which is coming from deep to the jugular through the occipital condyle.
Okay. Okay.
That is much deeper in a canal. Let me drill it and show you. Come on.
Okay.
Don't keep in confusion. Let me drill the occipital condyle. Okay?
Yes, sir.
Just to show you the hypoglossal canal. Now the rest of the nerve I am cutting away for the sake of demonstration of the hypoglossal canal. See this? This is, I am drilling, what I am drilling is the occipital condyle. Oh. See, these are the nerve roots below. Those are the hypoglossal nerve roots. See the hypoglossal canal there.
Yes, sir.
See the hypoglossal nerve roots here, passing through the canal, and that is deep to the jugular. That is the hypoglossal nerve. Now see, through and through. See very clear. See, this is hypoglossal nerve roots.
Yes, sir.
See the hypoglossal canal. Can you see the nerve canal?
Yes, sir. Beautiful. We can see complete canal.
And these are the hypoglossal nerve roots. See this?
Yes,
Yes,
sir.
sir. Yes.
This is the hypoglossal canal in the occipital condyle.
Okay.
This is occipital condyle.
Yes, sir.
Lateral to the occipit, lateral to the condyle is the jugular foramen, jugular bulb where the jugular bulb is, and medial to the condyle is the posterior cranial fossa, foramen magnum, and through the condyle is the hypoglossal canal. The rest all the nerves are lateral to the condyle. Only the hypoglossal, see, all these nerves are lateral to the condyle in the medial wall of the jugular bulb. But hypoglossal canal comes separately through a canal inside the hypoglossal, inside the occipital condyle. I hope it is very clear.
Very clear. Very clear. Yes, sir.
So 9th, 10th, 11th are separate, and the 12th is coming further deep through a canal in the occipital condyle, that is hypoglossal canal.
Okay.
Once it comes to drilling the canal, one should avoid drilling beyond the exposure of the hypoglossal nerve. You can drill the posterior part of the condyle. If you drill the entire condyle, it may lead to craniocervical instability because it is below, has a joint with the atlas. So condyles are very important. You can't drill the condyles completely. Only this posterior part of the condyle can be safely drilled away.
And sir, sir, can you show the tubercle?
Pardon?
Jugular tubercle.
Check the jugular tubercle.
Jugular tubercle is here. The jugular tubercle is not very prominent. Let me show you. See this. You ask the question at the right time. These three nerves, can you see this? 9th, 10th, 11th.
Yes, sir. Yes.
Are passing on a bone. Can you see this bone?
Yes, sir.
Yes, sir.
So all three nerves are running on a bone that is jugular tubercle. See this?
Okay.
And hypoglossal is running deep to the jugular tubercle.
Yes,
and
yes.
this tubercle of the bone, if I remove this tubercle, see what are the massive access to the lower clival region. See that?
Yes, sir.
This jugular tubercle is the biggest hindrance to access the lower clivus. See that?
Yes, sir.
If you drill away this tubercle right from here to here completely, this is jugular tubercle. You have a massive access improved. So all the three nerves are run on the surface of the tubercle, and the hypoglossal is deep to the tubercle into the occipital condyle. If you remember, I showed, let me show you again on the skull, all this anatomy. I showed in the morning, if you remember.
Yes, sir.
Yes.
Beautiful.
Let me show you again. Let me show you again. See now. Visible? This is jugular foramen. Can you see? Hello?
Yes, sir.
Sir.
9, 10th, 11 now ascend in the jugular foramen in this anterior compartment. This is neural compartment. Okay? And
Yes, sir.
the sigmoid sinus runs, becoming a bulb passing through the posterior compartment. Can you see this? There is a laterally intrajugular spine which separates the two compartments. So anterior one is the neural and the posterior one is the venous. And these nerves from the brain stem, these nerves run on what? What is this? To enter the jugular foramen? This is jugular tubercle.
Tubercle.
So this is the hindrance. Once you come from here, see how big a hindrance this to the lower clivus. Can you see?
Yes.
Yes, sir.
And here, this is the occipital condyle. See the jugular foramen, medial to that is tubercle and medial to that is condyle.
Condyle, yes.
Through the
Yes.
condyle is a separate canal for the hypoglossal. Let
Beautiful.
me turn it back. These are the condyles, and there is a separate canal for hypoglossal. Can you see? So these two condyles, these occipital condyle below have an articular facet to join the articular facet of the atlas. That's how the atlanto-occipital joint is formed.
Yes,
So
sir.
these condyles, once it comes to drilling, one should not drill more than lateral 1/3 of the condyle, more than posterior 1/3, so that the craniocervical instability doesn't happen to occur. Is that clear? The jugular foramen,
Yeah, bundle
medial
fully explained.
to jugular foramen is jugular tubercle, and medial to that is occipital condyle.
Yes, sir. So this is very important anatomy, very difficult to understand. Thank you so much.
That's why this model is helping.
Yes, sir.
So this is posterior cranial fossa, this is medial cranial fossa. Our petrous bone has relation to both the cranial fossa. So tumor from here can enter into this, tumor from here can enter into this. This tumor from here can enter into this, can enter into this. So there are a number of approaches to address various areas. Okay?
Yes, sir.
So we could address the jugular foramen by transsigmoid approach, divided the sigmoid sinus, staying infracochlear, infralabyrinthine. See this?
Yes, sir.
We didn't transfer the facial nerve, didn't do any labyrinthine dissection, yet by the transsigmoid, you can reach the jugular foramen and address the lesions, particularly the non-vascular lesions like schwannomas most likely, you can address through this approach easily. For glomus tumors, the paraganglioma, they are vascular. For that, you need to have a bigger exposure because they have a relationship with the carotid artery anteriorly. They involve the carotid artery anteriorly. Anterior to jugular foramen is carotid artery. In that situation, to control the carotid artery, you need to have bigger exposure. And the biggest obstacle to the anterior part of the jugular foramen is what? Facial nerve.
Facial nerve.
Yes, sir.
In that situation, we transpose the facial nerve. Here you have seen a couple of times. Transpose it anteriorly and then drill away. This bone lateral to jugular foramen, this bone is the tympanic bone. Transpose the facial nerve anteriorly and drill away from here to here tympanic bone. You have a huge exposure of the jugular foramen. You can control the carotid artery anteriorly much better. Okay?
Yes, sir. Yes.
So now, let's see what I was talking about the carotid artery and jugular foramen, how the carotid enters, how it behaves, how the facial nerve is. So let me quickly, Uddhav, you can take questions.
Yes, sir. So I think you have shown the sternum magna, tubercle, condyle. So Dr. Umesh wants to see cochlear aqueduct.
Cochlear aqueduct. Cochlear aqueduct. See, this is the intra-aortic meatus here. It was.
Yes.
And this is the jugular foramen where the glossopharyngeal was going. Cochlear aqueduct is right here above the glossopharyngeal. If I drill this bone, we'll find the cochlear aqueduct.
Okay, okay.
Just above the jugular foramen, where this glossopharyngeal is entering into the jugular foramen like this, arching here. It was arching here like this, arching here, just above that, here. With the cochlear artery. Now, this is the facial nerve. See vertical segment?
Yes, sir.
See the stylomastoid foramen? There's the thick periosteum at the stylomastoid foramen here. See the facial nerve. See the facial nerve.
Yes.
See the facial nerve. Ascending into the parotid tissue. You have seen a couple of times in the parotid surgery and the glomus surgery. See this facial nerve all the way?
Yes, sir.
Yes. So you have to pick up this, transpose this anteriorly. If I elevate this entire facial nerve and put it there anteriorly, my entire region is clear.
Clear.
Infratemporal posterior type A.
I hope you have seen several times.
Yes, sir. Yes.
Sir, in type B, posterior you transpose it.
Drill. So now coming to the course of the carotid artery in the jugular foramen, infratemporal fossa A and B. From the B, jugular infratemporal fossa B, and further C, we can go to the nasopharynx, we can go to the sphenoid sinus, and all those pathologies lateral to the sphenoids, lateral to the pterygoid can be removed to the lateral skull base approach as well. I'll show you you have seen the sphenoid sinus in the morning by superior approach.
Yes, sir.
Now with the lateral approach, where the carotid is, where the sphenoid is, where the foramen lacerum is, you can see from here. See, this is facial nerve. What I am drilling is the tympanic bone. Tympanic bone is a thick bone forming the circumference of the extra-aortic canal. That is the middle ear. That is the bridge. I have taken down the atic here. That is the incus. See the vertical genu of the facial now, the incus there. See this anatomy we see day in and out, so I am not focusing much on it. That is the middle ear. Just to show the relationship, that's it. See the promontory, the malleus incus.
Yes, sir. Yes.
This is facial now. This is our middle ear. This is tensor tendon. This is ossicles. I can remove. That is the horizontal. The process is cochleariformis. You saw these ossicles from above in the morning.
Yes.
Yes, sir.
Yes.
Morning, what we were seeing, the entire anatomy was from above, from
Above.
here. Now from here, we must see, we know from the endoscopy, and we must know from the open approaches, all the full perspectives, complete. See that now, genu, I am going as a horizontal facial now anteriorly. Okay, that is promontory. Then the cochlea, we saw the cochlea from above in the morning. And anterior, the cochlea we saw in the morning, what is there anterior to cochlea? That's the carotid artery. See the carotid there.
Genu, yes, sir.
And lateral to the carotid is what? Eustachian tube we saw in the morning.
Yes, sir. Eustachian tube.
So the all anatomy stands clear. And what is there superior to the Eustachian tube? This is tendon or tensor tympani.
Tensor tympani.
This entire anatomy we saw in the morning from different perspectives. From above. Okay?
Yes, sir.
Now, this is tympanic bone. See this tympanic bone? See this tough tympanic bone. Now, in the live surgical situation, your jugular foramen, see this jugular foramen here,
Yes.
is medial to this bone. How can you access without keeping the facial nerve? I mean, keeping the facial nerve here. So in vascular lesions, we transpose. What do? We'll take it like this here and mobilize here and from anteriorly make a new canal. The facial nerve, rather than going from here, it will go from there. That is transposition, and I'm not showing here to save the time because we have shown this couple of times. Okay?
Yes, sir.
Let us see the course of the carotid artery, the important part.
Yes.
I'm sacrificing the facial now, for that matter. This is the hypotympanum. See this? That is the hypotympanum, point out. See below the promontory. This is tympanic bone. Very, very thick tympanic bone. This anterior wall of the exotic canal, see this? We saw in the morning, immediately anterior to that is the TM joint. Remember?
Yes, sir.
See, if I remove the anterior wall, just I'm showing the anatomy. Just immediately anterior to it, that is TM joint.
Why is it slow?
And below the TM joint, medial to the TM joint, that is the carotid artery. What I'm drilling is the bony eustachian tube. See, I can see the carotid artery.
Yes, sir.
here from anterior to the cochlea we saw in the morning,
You can see the
turns
periosteum.
it turns anteriorly. That is what happening.
We are seeing from below now.
I am skipping the lower part. We have seen the course of vertebral artery in the morning,
Yes, sir.
seen the carotid, and now carotid from different perspectives. See the carotid artery now. This is carotid artery. This is carotid artery.
Yes.
This is cochlea, the promontory, and the carotid is immediately anterior to it. See this?
Yes, sir.
And what is there laterally is the Eustachian tube, bony Eustachian tube. And what is there laterally, there anteriorly is the TM joint. That is TM joint.
Capsule.
Here, the artery is taking a turn. You saw in the morning how it turns anteriorly.
Yes,
Just anterior to the cochlea, same thing you see. And what runs superior to the artery? What runs superior to the artery? The GSPN.
Yes, King.
This is GSPN going anteriorly. See this one. That is GSPN. See that GSPN. Superior to the artery. We saw in the morning, the moment we saw the GSPN, we went inferior to the GSPN, immediately inferior was the carotid artery. And you can witness the same thing. Can you see?
Yes, sir.
Inferior, the horizontal carotid, it is becoming horizontal now. See that? It is going horizontal like the suction tip now. And parallel and above to that is the GSPN. See that? That is the course. Now, once it becomes horizontal, in morning we saw certain things cross the carotid artery. Remember?
Yes, sir.
I am drilling away the Eustachian tube just to show you anatomy. This is bony Eustachian tube. See that bony Eustachian tube? And what is there beyond the cartilaginous Eustachian tube? See that?
Yes, sir. Yes, sir.
That is the Eustachian tube. See that?
Yes, sir.
Many a times we have seen this paragangliomas going through the Eustachian tube into the nasopharynx, oropharynx.
Yes, sir. And hanging as
We have
a.
removed couple of cases. Sandeep remembers.
Yes, sir. Yes, sir.
Many times this goes into the patient present with a bleeding mass in the nasopharynx, oropharynx.
Pharynx. Yes, sir.
And see, this is the Eustachian tube which I have drilled.
Yes, sir.
This is a part of the tube is still remaining and it runs lateral to the carotid. See this?
Yes, sir. Beautiful, sir.
See the carotid. Now see the carotid has become horizontal.
Yes, sir. It will go on.
So the two things run parallel in the temporal bone. Both are the most important thing in terms of decision making, in terms of choosing the approach, are the carotid artery and the facial nerve.
Facial
And
nerve.
both have a similar course. Both have a similar course. See this. The carotid has a vertical course from the carotid foramen, like this. The facial has a vertical course from the stylomastoid foramen. Parallel and behind. Can you see?
Yes, sir.
That
Yes, sir.
facial is a genu. Facial is a genu running anteriorly. See this?
Yes, and similarly.
Carotid has a genu running anteriorly.
Yes.
Similar.
Yes. Similar.
And both are the most important things. Now see the huge horizontal segment. See this complete.
Yes.
When we remove the paragangliomas, this vertical segment is a thick, you see this thick periosteum. See this? but this horizontal segment doesn't have a thick periosteum. So
Yes, sir.
removing the tumor from the wall of the horizontal segment, you have to be very, very tricky. If you are not careful, you can injure the vessel. What's my point?
Yes, sir.
Now, coming lateral to it. See now, if you have to expose the carotid further, suppose you have a tumor which is directing you to go anteriorly. You cannot follow the course of the carotid beyond this. What you need to do is, what is the obstacle? The TM joint. Now, to go further anteriorly with vision, under vision, you need to remove this lateral thing, and that is the TM joint. If I remove this TM joint and follow the carotid anteriorly, that will be infratemporal fossa B approach.
Okay. Yes, sir.
The beauty with this approach is, you have the complete control of the carotid artery. If you have a tumor around the carotid, you can remove it. Now the question is, where is the petrous apex? You saw where the horizontal carotid was running. Let me show you again. See this. See? Hello?
Yes, sir.
This is the horizontal petrous carotid running to the foramen lacerum and then turning up.
Yes.
This horizontal petrous carotid, the petrous apex is deep to it. See this? So, see now, the horizontal petrous carotid is running there. See this?
Okay. Yes, sir.
If you elevate this, see this with a good exposure. This is not a good exposure. You can mobilize and see this bone deep to it. This is cochlea.
Yes.
This bone deep to it is petrous apex.
Petrous apex.
Yes. So in a pneumatized bone, how you can enter into the petrous apex? By the infralabyrinthine route here. Stay below the cochlea, posterior to the carotid, above the jugular foramen, and then drill into this bone to go deep to the carotid to drill this bone. That is infracochlear approach to the petrous apex. Okay?
Yes, sir. Anterior to facial nerve.
Yes. Now, to go further anterior would be the foramen lacerum where this the carotid ascends. And that is the paraclival region where you can see the sphenoid sinus. But to go anteriorly to the foramen lacerum, I need to remove this TM joint. In the live surgical situation, you can bring the TM joint down with a TM joint retractor. Here I don't have a retractor in the lab here. So what I will do, the same anatomy what you saw from above, the sphenoid sinus, V1, V2, V3, abducent, the pterygoid process, median canal, everything what you saw from above, now you can see from below.
Yes, sir.
That is infratemporal fossa B and C approach. This is TM joint capsule. That is TM joint capsule. Here I am just quickly removing, without wasting time. This is zygomatic arch. This is the TM joint capsule. See the TM joint? See the articular facet? I want the TM joint to be pushed inferiorly. See this?
Yes, sir.
And remove this lateral bone to go all the way. But here I don't have a retractor. So what I will do, I will divide this TM joint. Okay? For the sake of demonstration of anatomy. Yeah. Drill. I will divide it and then I'll have a through and through exposure. I hope it is clear.
Yes, sir. Very clear.
Feel free to ask anything if you have any doubt.
Yes, sir.
I've taken the joint away. See what this muscle is inserted on the neck of the joint anteriorly. This is lateral pterygoid, which I am dividing.
Okay.
See this?
Yes,
Yes,
This
sir.
is lateral pterygoid.
So
Both the
enter
head,
right here.
both the heads of the lateral pterygoid insert here on the neck. Okay.
Yes, sir.
So my condyle is coming out. Okay. So this will give me good access now. Okay.
Yes, sir. Infratempral fossa.
Yes, to work. It's all pterygoid muscles. Okay. Now this thick bone. See, that is our carotid artery. Now this thick bone forming the skull base here. This all thick bone. This thick bone forming the skull base is the greater wing of sphenoid. This is all greater wing of the sphenoid. This bone has to go. Once this bone is gone, see, once this bone is gone, you can start following the carotid artery there directly.
Yes, sir.
Got my point?
Yes.
That's the part of the Eustachian tube. Okay? The bone lateral to the carotid is Eustachian tube. Now, can you see some vessel? See this vessel? Artery. Crossing the carotid artery. See this vessel?
Yes.
This vessel.
Yes, sir.
Yes. That is middle meningeal artery. I showed you in the morning. The
Yes,
two
sir. Yes.
structures, one after another, crossing the carotid artery from
Sir, from
laterally.
okay, sir. From foramen spinosum.
This is passing through the. Here is the foramen spinosum.
Yes.
This is the superior branch of maxillary.
Okay.
Crossing the carotid artery. See, this is carotid artery.
Yes, sir. Yes, sir.
So this is one structure, and next to this would be what? I showed in the morning. Yes, V3 drill motor. So posteriorly foramen spinosum, anteriorly foramen ovale,
Ovale.
through which the V3 passes, that crosses the carotid artery.
Got it, sir.
So that was the anatomy I showed in the morning was from above.
Above.
And now this is what you are seeing from the lateral side. And earlier you have seen from the anterior side. Nose. What is See now, this bone lateral to the carotid, this entire huge chunk of bone, that is the greater wing of sphenoid that I need to remove. There's a huge bone. Hugging the temporal dura. Flushing the temporal dura. See how thick bone without taking the TM joint down, without drilling this bone, you can't follow. Now, underneath this vessel is the petrous apex. I told you in the morning, lesions involving the petrous apex and the petroclival regions involving the carotid arteries, this is the best approach because this approach gives you the best opportunity to control the carotid artery. All the way. See, this is my temporal dura.
Yes, sir.
I am removing this entire bone, see, crater sphenoid bone, hugging the temporal dura. See how thick bone it is. So morning, we saw this entire anatomy from above, the course of the carotid from above, now it is from lateral side. In the next webinar of the open approaches, that is solely dedicated to the open approaches, which will still have a place in spite of the endoscopic advancement. There are certain approaches which are relevant. One should know.
So many people want to keep measurably.
From different perspectives. The course of the carotid from different perspective altogether.
Yes, sir.
Next webinar is on 25th, most probably.
Pardon?
Next webinar is on 25th of this month, and then we have our isocon. Announcement for isocon we can do. We can.
Yeah, I take you this opportunity to invite you all for our, the Indian Society of Otology conference webinar from 21st to 22nd of November, 2 days. It's a pure live surgical event with multiple faculties coming with full 2 days of live cases demonstration from basic otology to the most advanced skull base with variety of cochlear implant situation for the normal cochlea, malformed cochlea, CSOM, everything. See the foramen spinosum now.
Yes, sir.
You are telling foramen spinosum, this is foramen spinosum.
Wonderful, sir. Yes.
See how this middle meningeal enters here into the skull. This one. That is foramen. Okay. Spinosum. Let me remove this bone. What is this? The Eustachian tube. Can you see this? Cartilaginous Eustachian tube?
Cartilaginous part.
See this cartilaginous Eustachian tube? If I open it up, you can see the nasopharynx. Hello?
Yes.
Yes, sir. Yes.
This is cartilaginous. Can you see the interior?
Yes, sir.
Can you
We
see
can see.
the interior of the tube? See this?
Wonderful,
Yes, sir.
sir. Yes. Yes.
Cartilaginous part.
And
Beautiful.
that is your nasopharynx.
Yes, sir.
See
Beautiful.
Yes, sir.
that? That is the nasopharyngeal secretions.
Yes, sir.
See this?
Taurus.
See the nasopharynx?
Yes, sir.
This is nasopharynx cavity.
Yeah.
This is cartilaginous tube. Okay? So this is Eustachian tube and the cartilage. That is the nasopharynx. Very clear?
Yes, sir. Very clear.
This is all cartilaginous tube. Now going further anteriorly. Drill. This is horizontal carotid. Now the huge structure coming up, crossing the carotid. I told you in the morning, the largest of the nerve. What is that? V3, mandibular nerve.
Mandibular nerve.
See this, largest. We call it mandibular canal. It's not a simple foramen. It's so huge. See that?
Yes, sir. Yes, sir.
See this huge. This is crossing the carotid below. See the carotid below.
Yes, sir.
This is horizontal petrous carotid. See this? Okay. Now you see this is, what is this thick one? The mandibular nerve. V3. See now what I told you. This is petrous apex now. Let me tell you. Deep to the carotid here, I told you this is petrous apex, anterior to the cochlea. This is cochlea here.
Yes, sir.
Anterior to the cochlea, this is petrous apex.
Yes.
Deep to the carotid. And what is the structure crossing the petrous apex? Are the mandibular, the maxillary ganglion and its branches.
Yes.
See this. That is V3 we saw in the morning. The most lateral one is the V3.
V3.
See this? And I can cut the V3 now. See this.
Yes.
Thick periosteum. Now the V3 gone. See that? Now, as the V3, as you go anterior to the V3, you know,
Yes, sir.
anybody, what is there anterior to the foramen ovale? V3 is the pterygoid process.
Yes.
See in the endonasal anatomy. What is there anterior to the V3?
Pterygoid process.
Yes. Now see, what is this nerve? What is this nerve? Which this was the GSPN going, crossing the carotid, going down here.
Median.
Median, yes. Because at the foramen los residuum, there is a crossover.
Yes,
The
sir.
GSPN, which was running intracranial, is now going extracranial, and this carotid, which was running extracranial, now it is going up.
Yes, sir.
That is what cross. See now, at the foramen lacerum, now carotid is going to ascend. See the carotid ascending?
Yes.
See this? Can you see this carotid ascending?
Yes, sir.
Yes,
Yes,
sir.
sir.
Taken the turn, and at the petrous apex where the carotid is turned, see what is there inside. Which nerve is this? See the nerve going lateral to the carotid. That is sixth cranial
Six
nerve.
now. Yes, sir.
Now,
Abdussalam.
now.
I showed in the morning from different side.
Yes,
Yes.
sir.
So don't get confused. See now this nerve is
Dolus
running
nerve.
lateral to the carotid. See this?
Yes, sir.
Yes, sir. Seen.
This
It
is
crosses
running
the
lateral
cavernous
to the-
sinus.
This nerve is running lateral to the carotid into the cavernous sinus.
Yes.
That is
Sixth now.
sixth nerve.
Six now.
And this is the paraclival carotid. See this paraclival.
Yes,
Did you
sir.
Yes.
see this?
Yes, sir. Yes, sir.
And this goes up and take an anterior band. See this anterior band of the carotid.
So we can see the whole cavernous sinus, the carotid going in between the
This
sixth
is
nerve,
cavernous sinus only. My dear, this
Yes.
is cavernous sinus only.
and some medial
See
to
this?
the. Yes.
Now, this is the paraclival carotid. This is the posterior band and this is the horizontal cavernous carotid.
Yes. Yes.
Can you see?
Wonderful, sir.
Horizontal
Beautiful.
cavernous carotid.
And so
Very
we can
clear?
see. Yes, sir.
Now, once you have seen the carotid ascending up, where is the sphenoid sinus? Paraclival carotid forms the lateral wall of the sphenoid.
Yes,
You know
sir.
it. Okay. See, the foramen lacerum, the anteriorly, the inferior thing is the pterygoid process. And what is there about the pterygoid? This one is sphenoid
Maxillary sweat.
sinus.
Yes, sir. Yes, sir.
This is sphenoid sinus. Where the
Form,
paraclival carotid runs? In the lateral wall of the sphenoid.
so basically, medial wall of cavernous sinus.
Choki Debar. Choki Debar. Choki Debar. Take a retractor. What, Uddhav?
Like, it is forming the medial wall of cavernous sinus, the sphenoid bone, which now we are.
Possible?
So it is forming the cavernous sinus medial wall. The bone which you are now drilling is a part of the cavernous sinus. The bone, this sphenoid bone.
Yeah, the cavernous sinus is where this carotid edge it ascends the foramen lacerum.
Yes.
See this level of the abducent now. Here
Yes.
above it becomes the cavernous carotid.
Yes.
And then it takes a frontal turn. Okay, and here is the
Sphenoid
sinus.
sinus.
Now,
Sphenoid sinus.
yeah, now there are a lot of things. We open the sphenoid sinus in the morning between V1 and V2.
Yes.
Remember?
Yes, sir. Yes.
Above the level of the foramen lacerum. This is pterygoid process, and that is the sphenoid sinus. That is sphenoid sinus from inside. Okay?
Yes.
Now, light भी. What happened? Off. Off. Hello?
Yes, sir.
Yes. Can you hear me?
We can hear you.
We are getting external camera picture.
This is how we have explored the anatomy from all around.
Complete 360 exploration of anatomy, sir. Beautiful. Sir, we are not getting the microscopic picture.
Once you drill the pterygoid process,
Yes.
you can find the median nerve as well. See the cavity of the lumen of the sphenoid sinus first.
Yes, sir. Yes, sir.
See this?
Beautiful. Yes.
Yeah, could be. Yes. See the sphenoid sinus?
Yes, sir. Yes, sir.
Now, what is there in the floor of the sphenoid sinus? See
Sir.
this. I showed you in the morning, if you remember. This is the foramen lacerum where the carotid is turning up.
Yes, sir.
In the floor of the sphenoid sinus are two nerves. Laterally is the V2, superior-laterally, and inferior-medially is the median nerve.
Median nerve. Median nerve.
So, superior-laterally here, if I drill, will be the V2, and if I drill away this pterygoid process completely inferior-medially, would be the median nerve. What's my point?
Yes, sir. And sir, the bone between them is the
That
maxillary
is how
sweat.
to relate. Pardon?
Yes. Sir, the bone between them is the maxillary sweat.
Yes. See the maxillary stud between V2 and the superior orbital fissure.
Yes.
See now the entire carotid can be transposed. Now suppose with this exposure, first you have to expose, then you have to take the vessel into control, take the umbilical tape around the vessel and transpose it. See this?
Yes.
Yes,
Once
sir.
you transpose it, your entire petrous apex is open. Can you see this?
Wonderful, sir. We can see the whole petrous bone till the apex.
Now, If I remove this remaining bone, see this, with the carotid artery anterior limit and the sigmoid sinus posterior limit. See this huge exposure. The moment I remove this bone, cochlea, what will this be? The transcochlear approach. I told you, this gives the biggest exposure, can be afforded by any approach in the lateral skull base.
Yes, sir.
So in transcochlear approach, the moment you remove the cochlea, the things are different. You know, you get right onto the petrous apex. See now the cochlea being removed, just to show you what kind of exposure one can get once the cochlea is removed. Now see, transcochlear exposure through and through. With transcochlear exposure, this is transcochlear plus infratemporal fossa B. Can you see?
Yes, sir.
Your
Yes.
carotid can be exposed. Your carotid can be transposed. This carotid is transposed. This entire petrous apex removed. See this? Your petroclival region is exposed. See now the middle fossa above. And all this anatomy ventral to the brain stem. See this? Now I am going ventral to the brain stem. It's pretty clear. So for any lateral skull base tumor, if you have this exposure of the transcochlear with infratemporal fossa B, see this, you can control the carotid very well. You can remove any invasive petroclival tumor. See this, with this exposure, amazing exposure, there cannot be, afforded by any approach on the planet. I tell you.
Yes, sir.
This transcochlear was still here, and then infratemporal fossa B added to this. So this is transcochlear B. Transcochlear B for all petrous apex, petroclival lesion, invasive lesions. When the carotid is affected, this is the approach of choice. Even if the tumor is going intradural in the posterior fossa, temporal bone, infratemporal fossa, middle cranial fossa, anywhere, the huge 1 kg tumor you can remove. Tumor involving all critical structures with this kind of access, one can remove any lateral skull base tumor. I am using this word, any lateral skull base tumor. Now suppose the tumor is involving the lower clivus. The lower clivus is here. The lower clivus is here. The tumor is involving the lower clivus. I will join with this transcochlear with the infratemporal fossa A. See that? Like we do for the glomus. Complete this removal till extracranial. Extracranial to intracranial with infratemporal fossa A like glomus. With transcochlear, you can address the lower clivus. If you want to address the foramen magnum along with, expose the vertebral artery, do the far lateral approach and combine this transcochlear with the far lateral. That is for the foramen magnum. If you have a more middle fossa component along with this, combine with the middle cranial fossa approach from above, make a craniotomy here, retract the temporal lobe and remove along with this the middle cranial fossa component. So the point is, the bottom line is, combination of approaches can take you to anywhere in the lateral skull base, petroclival region, clivus, foramen magnum, carotid artery control, middle fossa, posterior fossa, infratemporal fossa, parapharyngeal space, anywhere in the lateral skull base with full complete control, with no brain retraction. See, in this approach, your cerebellum is here, your middle fossa is here, and you reach everywhere with hardly any bone retraction. And these are the, the approaches of choice for the lateral skull base. With full carotid artery control, with full bone invasion, you can remove by drilling the bone. You can go from orbit, cavernous sinus, orbit, sphenoid sinus, pterygoid, infratemporal fossa, right from there to the foramen magnum. Any tumor going anywhere in the skull base, you can remove. This is the hallmark of lateral skull base approaches. But one should have in armamentarium all these approaches full three-dimensional, five-dimensional anatomy, I would say, five-dimensional with complete control of vessels, multi-compartmental tumor one can address. Anything, Udbhav?
No, sir. I think we have covered all the things wonderfully explained from all the views. Sir, people are completely speechless.
Thank you. Any questions? Anybody, or we call it a day?
Sir, you have answered all the questions.
No
Seriously, all the
question.
questions. No questions. Sir,
Hello?
whatever people want to see, you have shown all the things from all the approaches, from superior aspect, middle aspect, lateral aspect.
Anywhere in the skull base, right from orbit to the foramen magnum.
Sir, earlier we
Seven-
could see why VDN is important. V2 is important for identification of the infiltrate artery in nasal
Why?
surgery.
What is
V2
nasal
is
surgery? Yeah,
V2 is
V2 is
important
a great
landmark.
landmark. V2
Yes,
is
sir.
a great
We
landmark.
could see from this side, sir.
Not exclusively for internal carotid, but
Yes, sir.
V2 is a great landmark for the middle fossa floor.
Yes, sir. Yes, sir.
It is a
We could
great landmark for the
we could
pterygoids.
collateral. We could do see it from this opposite side, sir.
Sandeep, all these nerves and vessels, V2, V1, V3, cavernous sinus,
Yes, sir.
one should be well versed five dimensionally from all around. You can do
Yes,
anything.
sir. Yes, sir. Yes.
It's all about anatomy.
Yes, sir.
Yes, sir.
Any cranial fossa involved, anterior cranial fossa, middle fossa, posterior fossa, orbit, cavernous sinus, sphenoid sinus, pterygoid, infratemporal fossa, parapharyngeal space, foramen magnum, anything, any damn thing.
Yes, sir.
Combination of approaches are required.
360.
That's why many of the lesions which used to be considered inoperable earlier, now with the use of combination of various skull-based approaches, are very much addressable with good results.
Right, sir.
Thank you. Thank you all for being with us.
Yes, sir.
Thank you very much.
Thank you, sir. Thank you.
Disconnect.